pre-excitation. So how would you be sure? And of course, you may not be able to measure intervals, but I can answer if you ask me the narrowest or the low, jo bhi puchna hai. So how would you be sure, 100% sure? I'm your attending, you are calling me, I am groggy with sleep, I'm irritable, and I say, tell me 100%, is it pre-excited AFib or not? 100%.
On this ECG alone?
On this ECG alone, 100%. You cannot go wrong. What is the parameter that you will look at? Well, that can happen. That can happen. I want 100% input so that I get up and come to the hospital. Because this is a serious condition. It can kill you. Agreed? So वो 100% क्या है? Point with 100% specificity के साथ आप, with 100% predictive value, you can say this is pre-excited AFib. अच्छा, आप लोग तो लियाकत नेशनल से हैं?
I am from RIC.
RIC, oh great. So tables से idea हो जाए, मुझे मैं जानता नहीं आप लोगों को, तो पता चले कि कहाँ से, यहाँ से ज़्यादा बात आ रही है. RIC, good. तलहा बिन नज़ीर हूँ.
And Dr. Qurban.
And Dr. Qurban.
Even
Qurban तो बैठा हुआ ना, तलहा है नहीं, हाँ?
Sir, but if another thought is that it's AFib with an underlying bundle branch block or an aberrancy, but this is not a typical bundle branch block.
So if it was AFib with bundle branch block, will it be polymorphic or monomorphic?
Monomorphic.
Monomorphic. Is this monomorphic?
No. Yeah.
No.
So the morphology is changing.
So when the morphology changes, it becomes polymorphic. Bundle branch block तो fixed रहेगा ना, RR interval vary करेगा with, and it's generally slow. आपने कितना atrial fibrillation में, because it's bombarding the AV node, and you know that AV node decrements 170, 80, उससे ऊपर नहीं जाएगा rate. हाँ बोलो, जोर से बोलो. ठीक है, so shortest pre-excited
R2R interval.
RR interval, ठीक है. If that is less than 200 or equal to 200 milliseconds, you can be 100% sure, because for that, अब इसमें ले लेते हैं, अब हमारे पास है नहीं, but let's say this is clearly, अगर यहाँ देखें आप तो this डब्बा is there, तो अगर ये one large square का है ये, तो ये 200 milliseconds है, which means for this particular RR interval, you've gone down at a rate of 300 beats per minute. And this is an adult patient. Adult patients rarely can conduct that fast. So they have written papers on it that you can be 100% sure if you can have a Sperry, that is the shortest pre-excited RR interval of 250 का भी उन्होंने number दिया, लेकिन अगर 200 or less है, that's it. So that's what you're going to tell me when I will ask you, ठीक है? Otherwise, RR interval that is variable. So pre-excited EF is polymorphic. And atrial fibrillation with bundle branch block is irregular but monomorphic. Because bundle branch तो fixed होता है ना, unless there is variable degree of aberrancy. But अगर fixed हम bundle branch block की बात करें, which is the differential that will fall in this, and this is very fast. यहाँ भी देखें multiple intervals हैं जो 300 beats पर जा रहे हैं. Mike? ठीक है, okay, good, agree. Any comments? What will you not give? Blocking drugs? Amiodarone? नहीं देंगे? तो फिर क्या देंगे? और लेट्स से कि खराब हुई है डीसी कार्डियोवर्जन की मशीन, आईवी, तो प्रोकेनामाइड है ही नहीं पाकिस्तान में, एमियोड्रोन है खाली. आईवी आइब्यूटालाइड भी नहीं है. एमियो देंगे या नहीं देंगे? रिमेंबर, एमियो हर जगह देंगे. क्यों नहीं देंगे? फास्ट पाथवे को ब्लॉक करेगा एमियो. यू विल गिव ड्रग्स विच विल ऑल्सो ब्लॉक द accessory pathway in addition to the AV node. Verapamil is bad because it preferentially blocks the AV node and causes a हाँ adenosine आप नहीं देंगे, वो एक तो ऊपर अगर atrial fibrillation नहीं भी होगी तो कर देगी. डॉक्टर मनान, यार वो किधर गया? मेरा वाला माइक इनको दे दें, रोटेट करा दें. हाँ
previously amiodarone in a case of pre-excited fibrillation was in a classification of a recommendation of a 2B, but now it's class 3, and it's a harmful. Why? Because it's a multi-channel blocker, and we don't know the genotype of the patient. Sometimes the beta blocking effects will dominate. So that's the reason in our setup, the only remedy is sedation and a cardioversion. So
Class 1 indication
because
is
we have one
cardioversion.
patient who went into ventricular fibrillation and a cardiac arrest after just getting the amiodarone. So
And I agree with वो तो मैं वैसे सवाल पूछ रहा था. But if you don't have other things, let's say if you had amiodarone and verapamil, you would give amiodarone and not verapamil. ठीक है? Stand by the patient. And but cardioversion is the treatment. Next, please. ये तो इसी का है. So इसमें क्या है? Okay, ठीक है. तो this is what you will look at naturally when you break your pathway localization. तो इनमें सबको पता होगा. कहाँ है pathway इसमें? हाँ? Left free wall. And why do you say that? Positive delta in V1. Positive delta in V1 would tell you that it's a left-sided.
And
But
inverted
how would you know कि free wall? So
Inverted AVL will tell us.
inverted
it's in the
AVL.
left
So,
free wall.
so my mentor used to tell me that when you see an accessory, a pre-excited ECG, the first lead to look at is AVL, because 60% of the pathways are free wall and left-sided. They are more common and they are better because we can do transeptal, we can go and sit on them. They are easy to ablate versus a right free wall because उसके लिए हमारे पास सामान नहीं है, ठीक है? So you should be happy when you see a delta wave which is negative, because then you can safely say, next please. Okay, what has happened? Same ECG. किसने कहा ablate कर दिया? और कुछ हो सकता है? You are right, ablate हुआ है, लेकिन कुछ और possibility हो सकती है. If you get up in the morning and you see the same ECG. हाँ? हाँ, सबसे ज़्यादा pre-excited कौन से pathways होते हैं? Right free wall, septal, left lateral. इसमें अच्छा, now let's put some value to it. Left thumb amputation. I will take away your left thumbs if you are wrong. And I'm being kind because right में लूँगा तो जो lefties हैं उनका right और जो righties हैं उनका left thumb जाएगा. अब जवाब दो.
फिर भी जाएंगे सर, कटवाने को तैयार हैं.
ठीक है. So I always believed when I was training कि right जो है should be more pre-excited, but no, that's not the case, because जो septal pathways हैं वो एक दूसरे के ऊपर पड़े हुए हैं. So जो parahischian pathway will be the most pre-excited pathway. ठीक है? चलो, good. So ये तो ablate हो गया था, but lateral pathways can be subtle also sometimes. अगर आपका AV node की brisk वो है और young आदमी है और ये young ही होते हैं ना, तो अगली morning हो सकता है pre-excitation ना हो. But that does not mean कि adrenaline surge के साथ नहीं
So
आएगी.
these are the answers we have already discussed. So let's go
ठीक
to
है.
next ECG.
Okay, so this is an ECG of a 52-year-old woman with recurrent palpitations. First of all, what is the rhythm and what do you think is happening? So we've given adenosine, 6 here and 12 here. ये तो ECG पढ़ने वाली बात है, simple. इसमें कोई quiz नहीं है. So this is the rhythm, then adenosine is given in this strip, and then this happens, then this happens, and then this is the rhythm, 12 is given, and then atrial flutter. कहाँ? अच्छा, सुनो, एक जिसने खड़ा होना है वो हमें उसको माइक देंगे. क्रेडिट आपकी टेबल को जाएगा और अंगूठे भी जब जाएंगे तो सारी टेबल के जाएंगे. ठीक है?
So it's a narrow complex tachycardia going on. Then adenosine is being given. So tachycardia seems to be break after the PVCs. Then a sinus beat comes in, and then again an APC comes in, which goes through a long PR interval.
Okay, so you are saying कि यहाँ ब्रेक हुआ, ये PVCs आई और ये कुछ आया
जी,
और फिर ये भी आया कुछ, और फिर आप ये कह रहे हैं कि ये PAC है.
Looks like this is a PAC, and
Okay.
it went through a long PR interval, probably the slow pathway, and
Okay.
then tachycardia recurs again.
Restart it. ठीक
and
है,
then on the PVC the
सही.
tachycardia
So
stops.
do we agree with him? या कोई ये कह रहा है कि नहीं है ऐसे? Okay, ठीक है, we may agree with you. Then what happened? नीचे भी तो है ना ECG, इसमें क्या हुआ भाई? वो दे दो, वो अभी पूरा जवाब नहीं दिया था उन्होंने.
So
Okay.
the tachycardia on the lower strip, the tachycardia goes on, then a PVC comes in, and probably this PVC or adenosine after 12 milligram, the tachycardia, and patient went into the AV block, I think,
Okay.
transiently.
ठीक है, सही है. सो AV ब्लॉक, सिर्फ AV ब्लॉक में क्या है? साइनस अरेस्ट में? ये क्या
Yeah, I
है?
think this is
ये
P
क्या है?
wave.
ये क्या है?
These
ये
are
क्या
the
है?
all P waves.
सो हाउ विल यू, मैं घर में बैठा हुआ अगेन, आपने कहा मैंने 12 एडेनोसिन दिया और 12 एडेनोसिन के बाद मरीज को कुछ हो गया है, तो व्हाट विल यू एक्सप्लेन? हाउ विल यू एक्सप्लेन टू मी? एक्सप्लेन दिस. आपने एडेनोसिन दिया, यू which initiated a PVC, this not a clean termination, and then you had a sinus beat, and then how would you describe this? आपने कहा AV ब्लॉक हो गया, I agree with you, but I'm not happy. जोर से बोलो यार, आपके पास टेबल पे ना माइक्स पड़े हुए हैं, वो वाली टेबल सो गई है जो एंड में डॉक्टर आजम के साथ बैठी हुई है, बिकॉज उन्हें आवाज ही नहीं आ रही है, और डॉक्टर आजम ने भी अपनी टेबल चेंज कर ली है. सो हाँ बोलो, सही बोल रही थी.
Ventricular is
एक्सेलेंट, ठीक है. दी हार्ट हैज मल्टीपल रिदम्स, इसमें स्केप रिदम आया ही नहीं है, साइनस आया है. अच्छा, जब साइनस इस तरह से आपने देखा होगा, कुछ लोग पेस मेकर के लिए आते हैं, उनकी होल्टर्स में ये होता है, एकदम ब्लॉक हो जाता है. व्हाट शुड हैपन टू द साइनस नोड? ब्रैडीकार्डिया होगा, टैकीकार्डिया होगा, फास्ट होगा ना. तो यहां क्या हो रहा है? Adenosine effect. ठीक है, तो ओवरऑल adenosine can do multiple things. It can slow down your sinus, it can cause atrial fibrillation, which is sometimes can be dangerous if you have an accessory pathway, and it can cause a ventricle standstill. Now, and it can sometimes cause a standstill. So when you give adenosine, although 10 सेकंड इसकी half life होती है, you need to have a crash cart, and you should be ready with a plan to troubleshoot, because they may require pacing. मेरी जिंदगी में जब भी इस किस्म के ब्लॉक हुए, आई बीन अनप्रिपेयर्ड. मैं खड़े होकर बस नेचर को देखता जा रहा था, पीस गुजरती जा रही थी कि कोई QRS किक इन कर ले, एंड एवरी टाइम नेचर हैज कम टू माय रेस्क्यू. बट दैट्स नॉट गुड.
अगर आपकी इजाजत हो तो एक कमेंट करूं.
बट दैट्स नॉट गुड मेडिसिन. हाँ हाँ बिल्कुल आप करें यार.
Okay, so this is just an observation and has been reported in literature. When you give adenosine, and what has been displayed here is PVCs. And adenosine-induced polymorphic VT भी हो सकता है, especially if you are giving for AV and RTs. And you will see this observation, आप उसको ignore कर देते. And that is why anytime you give adenosine or you do a carotid massage, you should be ready with your defibrillators.
Excellent point. ठीक है. So adenosine is ये डॉक्टर मन्नान ने मुश्किल सवाल पूछ लिया है कि व्हाट इज द मैकेनिज्म बिहाइंड द पॉलीमॉर्फ, कुछ आइडिया?
इसमें कैटेकोलामीन सर्ज होती है, स्पेशली आफ्टर यू गिव adenosine. So you know it's a reflex phenomena, and this is reported in literature. Rare phenomena, but happens. And and Dr. Amir's strip is also displaying this कि जी PVC आई है. So that is how it does not happen very often, but it does, and so that is why it should be taken with caution, that any type of vagal maneuver, carotid or adenosine, should be dealt with caution.
Yeah, anecdotally I can tell you this कि हम जब भी सेंट्रल लाइन से देते हैं, be very careful, because हम उसी गस्टों के साथ देते हैं जो हम पेरिफेरल लाइन से दे रहे होते हैं, and central line effect is much more exaggerated, and I've seen बिल्कुल flat line भी ऐसे patients में, so be careful. Next please.
Let's go to next.
ठीक है, ये हमने कर दिया, बड़ा अच्छा एक्सप्लेन किया, गुड. अच्छा जी, ये आ गई है ECG. सर पीछे बैक. हाँ, व्हाट इज द टैकीकार्डिया? Why is it AV&RT or why is it not AV&RT? हाँ, Why is it not an atrial tachycardia? Can we terminate atrial tachycardias with adenosine? Yes, we can. So there is a subgroup of atrial tachycardias which is adenosine sensitive, and you can. So adenosine termination of a narrow complex tachycardia does not give you an SVT diagnosis. You have to look, still read the ECG. तो इसमें क्या आपको पीज नजर आ रही है कहीं? और ये टर्मिनेट किस पे हो रहा है? QRS पे टर्मिनेट हो रहा है, तो इट डजंट हेल्प यू. अगर ये P पे टर्मिनेट हो रहा होता तो एट्रियल टैकिकार्डियाज आर प्रैक्टिकली रूल्ड आउट. ठीक है, कैन यू सी P वेव्स? एटलीस्ट 200 मिलीसेकंड्स में तो नजर नहीं आ रही. ये तो आपकी T वेव ही लगती है. सो मोस्ट लाइकली जो आपकी अच्छा सूडो S देख सकते हैं इधर, लेकिन जब आपकी तो कैसे पता चलेगा कि ये सूडो S ही है? कि द फर्स्ट डिसेंट साइनस बीट जब आएगी आपको तो उसका QRS का एंड देखिए, वो इट्स वेरी सिमिलर. सो मोस्ट लाइकली व्हेन यू कैन नॉट सी, अकॉर्डिंग टू दैट एल्गोरिथम दैट द अमेरिकन हार्ट एसोसिएशन हैज, वेरी नाइस वन, 2003 में शायद पब्लिश होता, अभी तक चल रहा है, इतना अच्छा है कि उसमें व्हेन यू कैन नॉट सी P waves, टॉप ऑफ योर डिफरेंशियल शुड बी AV नोडल रीएंट्रेंट टैकिकार्डिया. ठीक है सर? एनी आप उधर आपके पास है माइक है?
मैं एक्चुअली ये सोच रहा हूँ, देखिए अगर आप पहली एरो है, दूसरी एरो है, सो व्हाट आई वाज थिंकिंग वाज, कैन दिस बी साइनस टैकिकार्डिया और P विद अ फर्स्ट डिग्री AV ब्लॉक?
इट्स अ पॉसिबिलिटी.
अब उसमें सिर्फ जो चीज़ अगेंस्ट जाती है वो ये कि सो आई वुड आर्ग्यू कि आपका ये ख़त्म हो गया, यहाँ पे टैकिकार्डिया, साइनस नोड भी स्लो हो गया और वो भी कम हो गया. मैं ये सोच रहा हूँ कि जैसे ये यहाँ पे साइनस नोड AV ब्लॉक हुआ, साइनस ब्रेडिकार्डिया भी हो गया, P वेव आई, और फिर ये जंक्शनल रिदम आ गई, पॉसिबली जंक्शनल बीट आ गई, पॉसिबली, एंड देन देयर इज दिस वन बीट दैट आइदर कंडक्टेड और अगेन मे बी दिस इज अ P wave, another P wave comes here, this is a junctional beat possibly, and then you have this long first degree AV block because of your adenosine, and then ये जो है, ये अगर इस P wave को मैं देखता हूँ तो this looks very different to me than this T wave. This T wave looks very different. और मुझे लगता है कि जैसे इन 3-4 T waves के अंदर हो सकता है कुछ छुपा हुआ हो. So एक मुझे ये लग रहा था कि हो सकता है कि साइनस नोड भी स्लो हुआ हो, वो भी स्लो हुआ, साइनस नोड की एक्टिविटी बढ़ गई तो पॉसिबिलिटी है, बट आई डोंट.
नहीं, आई एग्री. सो दैट्स हाउ यू शुड रीड दिस ECG. सर ये वाला दे दें, ये तो आपका पास है. तो आई थिंक दिस इज राइट. उसमें सिर्फ ये है कि व्हेन यू गिव adenosine in someone who has a sinus rhythm, what will happen? मैंने सर्जन्स को देखा शॉक करते हुए साइनस रिदम को, बार बार कर रहे थे. जब तक मैं पहुंचा था तो 8-10 शॉक कर चुके थे. तो क्या होगा? और वो कहते यार ये तो खत्म ही नहीं हो रहा. मैंने कहा आप कोशिश करते रहे, मरीज खत्म हो जाएगा तो ये भी खत्म हो जाएगा. What happens when you shock, when you give adenosine to sinus tachycardia? It will slow down, it will go into this AV node block and then it will wake up again and वापस चले जाएगा. अगर ब्रेक होके वापस नहीं आता और a sinus rhythm comes and then warms up and you don't see a big PR interval, because इतने बड़े PR interval के साथ generally इसके ऊपर आपको ये देखिए तकरीबन 140 के रेट पे जा रहा है. It should start when की बाख. अगर आपका PR interval 400 milliseconds का, रफ intuitively makes sense, but must always look at the P waves, and Dr. Azam's thing is all कि adenosine दिया break हो गया तो just don't jump to a conclusion. Think about it. Less likely to be sinus rhythm with first degree AV block, sinus tachycardia with first degree AV block. So that's it. Okay, good. हाँ जी. 78-year-old man with pacemaker and complains of palpitation now. ये पहली मेरा ख्याल से थोड़ी सी स्विंग होती हुई बॉल आई है. अभी तक तो स्ट्रेट बैटिंग हो रही थी. हाँ, सो डॉक्टर मनान ने अच्छा सवाल किया जो आप लोगों को करना चाहिए कि सिंगल है पेसमेकर, डबल है, ट्रिपल है, क्या है? तो डुअल चेंबर पेसमेकर है. आप लोगों को जो आप लोग टेबल पे बैठे हुए हैं, किसी प्रेफरेंस से बैठे हुए, इंस्टीट्यूशनल प्रेफरेंस से, दोस्तों के साथ, या मिक्स्ड हैं? मिक्स्ड हैं, तो मुझे मतलब कोई अंदाजा नहीं हो सकता कौन कहाँ से है.
It's a
So-
pacemaker mediated tachycardia.
किसने बोला?
Here, sir.
हाँ, पेसमेकर मीडिएटेड टैकीकार्डिया, ये
Yeah.
तो यहाँ क्या हुआ है?
So now,
कौन बोल रहा है?
so this here.
हाँ, हाथ खड़ा किया करो ताकि नजर आ जाए कौन बोल रहा है. ठीक है, एक्सेलेंट. पॉसिबिलिटी इज, ये इसका रेट क्या है?
Sir, it's around 80.
130 के करीब है. ठीक है, तो मोस्ट 120 and 30 most dual chamber pacemakers will have an upper rate of 130. ठीक है, तो ये upper tracking rate के ऊपर पेस हो रहा है with a wide complex, very wide complex rhythm. So it's a paced. तो इसके क्या डिफरेंशियल हो सकते हैं और क्या हो सकता है? पेसमेकर मीडिएटेड टैकीकार्डिया के अलावा क्या हो सकता है?
साइनस टैक हो सकता है.
ठीक है, साइनस टैकीकार्डिया हो सकता है. ये लेटा हुआ मरीज है तो एक्सरसाइज तो कर नहीं रहा. लेटे हुए किसी का रेट और क्या पॉसिबिलिटी है? पेसमेकर मीडिएटेड टैकीकार्डिया मान लिया मैंने आपका. अपर ट्रैकिंग रेट पे और क्या पॉसिबिलिटी हो सकती है? एक, चलो एक बता दो. कौन से रिदम्स होते हैं जो ट्रैक हो सकते हैं जो 130 से ऊपर जा रहे हैं?
एट्रियल टैक.
हाँ,
एट्रियल टैक हो सकता है.
एट्रियल टैकीकार्डिया हो सकता है, फ्लटर हो सकता है. ठीक है ना, अगर एट्रियल फिब्रिलेशन भी हो सकता है समटाइम्स, बट ऑफ कोर्स उसके बीच में थोड़ा बहुत आगे पीछे होगी. फिर क्या हुआ?
Then two sinus beats and then there's a PVC.
ओके, देन देयर इज अ साइनस बीट एंड साइनस के बाद क्यूआरएस कैसा है?
This is a dial.
और उसके बाद जो साइनस है उसका क्यूआरएस कैसा है? और फिर ये क्या है? और फिर ये क्या है? द क्लू इज इन द ईसीजी.
जो पहली बीट है
Third beat.
ये तो फ्यूज, यानी जो रिवर्जन के बाद जो पहली बीट है वो तो फ्यूजन लग रही है,
ये वाली?
ये वाली.
ओके.
उसके बाद जो है उसमें एक नैरो क्यूआरएस है, लेकिन उसके बाद हम एक पेसिंग.
अरे नैरो क्यूआरएस नहीं है ये आपका, इट्स अ स्प्लिट क्यूआरएस.
सर वो स्पाइक नहीं है.
सो देखो, अगर हम मान लेते हैं कि ये पेस्ट रिदम है, बिकॉज इस पे स्पाइक आ रही है ना, तो हम इसको पेस्ट रिदम मान लेते हैं. और अपर ट्रैकिंग जब भी होगी पेस ही करेगा ना, तो उसके बाद ये साइनस बीट आती है, ये रिलेटिवली नैरो टू दिस आता है. सो दिस इज अनदर, इट कुड बी अ फ्यूजन बीट, इट कुड बी अ नेटिव complex which is conducting down, and then this beat comes through, and then this beat. What is this beat?
PVC.
अच्छा सुनो, why would you say that this is a PVC?
और उसकी मॉर्फोलॉजी पूरी वैसे पेस्ट की तरह.
Exactly, excellent. ठीक है, so तो ये क्या है? ये क्या गई है? Should on a pacemaker with lower base rate pacing, would you expect the pace beat to be here, so close to?
No.
इसमें तो आप कहेंगे डिस्फंक्शनल है, पेसमेकर सेंस ही नहीं कर रहा. तो अगर हम कह रहे हैं अप्रोप्रिएटली सेंसिंग, नॉर्मल पेसमेकर है, रूटीन चेक के लिए आया है, और उसके बीच में ये बीट आ गई, तो ये क्या बीट है? इसमें आंसर है आपका.
This is a PVC with, and the patient might be having a lot of PVCs which are triggering this mediate.
नहीं देखो, इसने अभी एक बड़ी जबरदस्त ऑब्जर्वेशन की है. Why would the PVC come from the tip of the RV lead? Why would it come? और ये पुराना पेसमेकर है, या तो ये कि आपने पता नहीं बहुत ऐसा गलत डाली हुई है लीड के, वो वहां से पीवीसी जनरेट करा है. पर जब हम लीड्स फिक्स करते हैं आमतौर पे भी मेक श्योर कि वहां से पीवीसी नहीं आ रही ना, बैठा के भेज. तो अब दिस इज डिटो, सो आई वुड से दिस इज अ पेस्ट बीट. सो इफ दिस इज अ पेस्ट बीट, व्हाई इज इट कम हियर? एंड ये यहां देखो, दैट्स व्हाई वी आर डिफरेंट फ्रॉम द रेस्ट इलेक्ट्रोफिजियोलॉजिस्ट्स, बिकॉज वी थिंक. नहीं तो गुब्बारा तो फूल जाता है.
I have another thing
Sir,
to
one thing.
say.
अभी तुम कहना, एक
नहीं,
मिनट.
मैं एक और चीज बता रहा हूँ.
Sir, if we say this is a PVC, if we say it's a paste.
No, I'm not saying you are professionals.
just,
You are going to read this.
Sir, if it's under sensing, or if we think that maybe it won't pace with such a long AV delay.
Okay,
Very good.
so you have,
Unless we have set that so long.
excellent thought again. कि ये आया, there is a wobble, ये थोड़ा सा छोटा है, देन ये थोड़ा सा बड़ा हो गया अकॉर्डिंग टू इट्स टाइमिंग साइकिल, एंड 200 मिलीसेकेंड्स फर्दर गिव्स यू अ क्लू. अगर पीआर इंटरवल ज्यादा बड़ा हो जाता है तो उसका क्या नुकसान होगा? अच्छा, एक सवाल मैं आपसे पूछता हूं कि अगर किसी को 3rd डिग्री एवी ब्लॉक है तो उसको वीए ब्लॉक भी होगा? ऊपर से अगर ब्लॉक्ड है तो 100% नीचे से भी ब्लॉक्ड होगा?
Not necessarily.
ठीक है. अब ठीक है, डॉक्टर आर कह रहे हैं कि if he has got AV nodal block then he has no VA conduction.
There are different
But-
fibers. For antegrade and retrograde conduction, there are different fibers. It's not necessary that you have got an antegrade block and you will have a retrograde.
तुम्हारी ना आवाज लग रही है डॉक्टर फरिया सादिक अली की तरह, तो जब बोलती हो मैं देखता उधर हूँ.
It's not.
अच्छा हाँ, जोर से बोलो.
There are different fibers for antegrade and retrograde
ठीक है.
conduction. So it's not necessary.
मेरा जो रिसर्च आर्टिकल था उसके बीच में सबसे पहली रिजेक्शन उस पे इसलिए आई थी क्योंकि जो मनूवर करते बेस से पेस, उन्होंने कहा इसकी 4 इनपुट्स होती हैं एवी नोड की, एक लेफ्ट से आती है, एक राइट से आती है, तो अगर आपने क्लॉक करके कैथेटर ये मनूवर किया तो सब गलत है. तो फिर हमने कहा नहीं, हमने तो काउंटर क्लॉक करके बाहर निकाल के किया है मनूवर, तो डेफिनेटली सो वीए कंडक्शन हो सकती है. पीआर इंटरवल बढ़ेगा तो यू कैन हैव वीए कंडक्शन. अगर वो छोटा रखेंगे आप तो वो रिफ्रैक्टरी फेज में होगा बाय द टाइम द क्यूआरएस कम्स थ्रू. तो कुड दिस हैव गॉन बैक अप and produced an A which the pacemaker sensed and this went down, but then it could not come back again. अगर ये आ जाता वापस तो री-एंट्री हो जाती. Agree?
I agree to your point, but going on to the initial phase of the trace where the tachycardia is going on, 1, 2, 3, 4,
अच्छा,
5,
एक तो मैं
6 beat.
और भी दिखा देते हैं. एक मिनट आगे.
अच्छा, वो थोड़ा 6 बीट पे कमेंट करना चाहते हैं.
अच्छा,
The 6 beat is very interesting. It
so
comes
1
early.
2 3 4 5 6.
अगर
Where
लीड
the
1
tech-
में देखें सर, if you look at lead
अच्छा,
1.
ओके ओके,
So
ठीक है,
this
ठीक है.
6th beat is very important
सही
to
है.
terminate that.
ठीक है.
This 6th beat actually terminates the pacemaker tachycardia. It's had different morphology. It comes early, so probably it's a fusion beat that did not allow the retrograde conduction, and hence the tachycardia stops.
ठीक है. दूसरी चीज ये है कि व्हाई आर वी थिंकिंग कि इट्स अ फ्यूजन बीट. इसको ड्यूअल चेंबर पेसमेकर पड़ा हुआ है, हो सकता है द पेसमेकर इटसेल्फ ट्रीटेड द
Yes,
टैकीकार्डिया.
this is a possibility. लेकिन उसमें ये होता है कि वो पेसमेकर ये इसका जो QRS टाइम है वो अर्ली मेरा ख्याल है कि नहीं होना चाहिए. पेसमेकर इज ट्रीटिंग द
वो
PMD
डिफरेंट उसके
because different devices have different algorithms. The PWARP extension
Extension
and
हो सकती है.
क्या कहते हैं,
इट कैन ड्रॉप अ पी.
it can drop a B and then
Yeah,
atrial pacing, so it delays the QRS rather than
Agreed.
comes in.
एग्रीड. आई एम नॉट
This
श्योर
is
कि
one observation.
इसके साथ वो क्या था. आगे चलाओ. सो दिस इज द फुल 12 लीड ECG ऑफ द टैकीकार्डिया. ठीक है. सो इफ यू लुक, इट्स राइट वेंट्रिकुलर पेसिंग आपका ऊपर का एक्सेस है, एंड यू हैव गॉट अ लेफ्ट बंडल मॉर्फोलॉजी. थोड़ी STD चेंजेस इधर आती हैं, but I think that's just tachycardia induced and relative to your depolarization, which is a natural thing. Next now. Next. So, any difference over here? Still paced? Okay. Okay, next. Next. Any difference here? ठीक है. So you
If you go to this ECG, this is different from fully paced RV, so this is likely fusion, I would say. अगर आप पीछे वाले आगे वाली में जाएं, तो this is not pacing, maybe. I
Yeah.
can't see.
So you have got a right bundle branch block pattern, which is the native underlying rhythm. So this is an A paced, and that is the reason the AV delays were opened up. ठीक है. जब आप प्रोग्राम करते हैं डिवाइस को डालने की, अगर आप 100% मैंडेटरी पेसिंग वेंट्रिकल स्टैंड स्टिल है तो आप उसके AVs को छोटा रखते हैं. जब आपकी नेटिव पेसिंग आ रही होती है, नेटिव पेसिंग इज ऑलवेज सुपीरियर टू राइट वेंट्रिकुलर पेसिंग, तो उसके बीच में आप AVs खोलने की कोशिश करते हैं, कीपिंग इन व्यू कि आपका अपर रेट जो है डिपेंडिंग ऑन द एज ऑफ द पेशेंट वो कॉम्प्रोमाइज ना हो. और उसमें फिर ये एक चीज़ रहती है, एंड रिमेंबर सारी डिवाइसेस के ऊपर पीएमटी ऑप्शन ऑन नहीं आता, एंड अगर आपने वो छोड़ दिया है और इसको ये हो रही है तो ही विल कम बैक टू यूर टैकीकार्डी इंड्यूस्ड कार्डियोमायोपैथी. वो कहेगा मुझे पैल्पिटेशंस होती हैं. पाकिस्तानी पेशेंट्स आर वेरी रेजिलिएंट, दे डोंट टेल यू टिल दे स्टार्ट फीलिंग शॉर्ट ऑफ ब्रेथ. ठीक है, ओके नेक्स्ट. ठीक है जी. अच्छा, हाँ सॉरी, हाँ यावर, वो तो नहीं, उसका एक्सप्लेनेशन हो गया ना कि वो आपकी जो पीआर बढ़ा हुआ है, पीआई sorry QRS higher, that QRS went up retrograde and that was sensed and you got a single paced beat, but वो उसको maintain नहीं कर सका, couldn't go back up because it is a system. Next आओ, next. Sorry, आप कुछ कह रहे हैं? सर आपका माइक नहीं है आपके पास.
Have to be very short to
नहीं मैं नहीं, इसमें डिवाइस ने उसको यहाँ नहीं, यहाँ तो वो खुद ऊपर देखो, ये जब नीचे से ऊपर जाएगी तो ये नेटिव सिस्टम के थ्रू जाएगी. अगर आपकी टोन बढ़ी हुई है, बढ़ गई है,
वो बात सही है, ऊपर चली गई, लेकिन the pacemaker has to track that beat. If this falls in the P valve, the pacing would have not come.
हाँ, सो वो पी वार पे नहीं पड़ रही ना, तभी तो वो ट्रैक हो रही है. ये चूंकि ECGs है हमारे पास, चलते फिरते हमने ली हुई है. अगर ये पेसमेकर वहां से ली होती तो आई वुड हैव शोन यू द होल ट्रैक, बट ये यहाँ हम सिर्फ सपोज कर सकते हैं. सो देखो रेट्रोग्रेड पी में अगर इसकी टी और इसकी टी को देखो तो देयर इज सटल डिफरेंस. सो दैट्स व्हाट आई एम सेइंग के ये पी प्रोबेबली यहाँ आई होगी एंड देन इट हैज गॉन डाउन.
बट आमिर, व्हाई वुड यू गेट अ रेट्रोग्रेड पी आफ्टर अ कंडक्टेड बीट?
बिकॉज द पीआर इंटरवल इज ओपनड अप ना, तो तब तक हो सकता है ये नीचे से गई है, उसको चांस मिल गया ऊपर जाने का.
So
जा
we
सकते
think,
हैं.
so the only way that could happen is if there are dual AV nodes. I mean, so you have to have a
बिल्कुल,
slope.
बिल्कुल.
उसके अलावा तो मुझे
नहीं आप सही कह रहे हैं. सो दैट इज अ पॉसिबिलिटी एंड द रीजन दैट इट कुड नॉट सस्टेन इट ओवर हियर ऑल्सो टेल्स यू दैट maybe ये नहीं घूम सकी. Is there any other explanation for this?
I mean, is there what I'm looking at is there ventricular undersensing going on?
So this pacemaker had
because there seems to be a pacing spike after the QRS, at the end of the QRS. Or is that something else? या artifact है आपके साथ?
नहीं, कहाँ है ये? यहाँ
नहीं इसके अगले बार
इधर.
उसके बाद तो ए पेस है आगे वाले में.
जैसे एक
नहीं, ये तो ए पेस है ना, ये ए पेस है और ये नेटिव है.
या तो ये कि ये is it possible के
ये आप ये ले लें.
एक ये है, फिर यहाँ आ रही है, are those, what are those?
सर आई थिंक ये तो QRS का हिस्सा ही है. दिस इज नॉट अ पेसिंग स्पाइक.
That is looks like a fractionated QRS. So
आपकी टेबल पे जो माइक है वो आप शेयर करेंगे. माइक के बगैर नहीं बोलना बिकॉज यहाँ लोग नहीं समझ सकते. बट इस पे बहुत सारी पॉपुलेशन थी जिसके बीच में QRS ऐसे आ रहा था. तो दिस इज नेटिव QRS, दैट्स व्हाट आई थिंक. But all explanations are welcome.
Could there be a possibility of a premature atrial ectopic that is hidden within the QRS?
It could be. Definitely it could be. But the thing is कि बाकी सारे traces में कहीं भी atrial ectopy का हमें नहीं मिल रहा था. So अगर why would you get a single PAC out of nowhere?
No. So what I think that's probably because when you have a native QRS, after a native QRS, a retrograde P is very rare. How often you see a retrograde P after a native QRS unless there is dual AV nodal physiology?
So that is a possibility.
So, or there is a premature atrial ectopics. And I think the third possibility is the ventricular sensing, and that's why it's giving you the PVC at the wrong time, because this PVC which comes is actually very close to your T, you see. So
yes, so if you see this,
so this is I think it's ventricular, maybe probably
ये हो सकता है. That's a possibility.
There is ventricular undersensing because this comes very, and if you see how soon it comes after the next QRS,
it looks like 60 beats per minute.
Possibility हो सकती है, but the fact
looks
that
like less 350 milliseconds.
हाँ, but the fact is कि ये थोड़ा सा different भी है. Could be दो मिनट, माइक.
So 7th QRS अगर टाइम करें अपने पेसिंग वाले QRS को तो it looks like 60 beats per minute.
नहीं, तुम कह रहे हो ये स्पाइक है.
नहीं. I'm saying जो 7th QRS है that is
1 2 3 4 5 6 7.
Yes.
हाँ.
यहाँ से टाइम करें तो it looks like it could be 60 beats per minute और
नहीं, मैं समझा नहीं तुम्हारी बात. ये तो
1000 milliseconds लग रहा है आपको? Looks like कि जो बीच वाला QRS है वो अंडर सेंस हुआ. मतलब this is the possibility.
Dr. Amir, मैं एक comment.
हाँ, फरिया please do.
So, what I would think कि जो जिसको PVC कह रहे हैं, it is actually an A-sense B base. This is why is it happening at very short interval. PAC coming out of nowhere. It could be a far field oversensing from the ventricle leads, and so it is falling within outside the P valve, and that is why it's being tracked. That is one possibility. And I don't think there's undersensing, because in a dual chamber pacemaker, the timing is based on the atrial, so your lower rate interval will be interrupted when you have an atrial sense. So so every time there's a ventricular event, your lower rate interval will start and will be interrupted if you have a sensed event. So there's no undersensing here. There's appropriate atrial pacing at a lower rate interval after that paced beat. So my differential would be this is a PAC which is being tracked, or this is far field oversensing which is being falling outside the P valve, and that is why it's being tracked.
बिल्कुल सही है. So I think explanations सबको समझ आ गई हैं? Okay. नहीं आई तो अब next. इसको आगे कर दो मेरा ख्याल से. आगे. हाँ. Okay. What about this? So this is a 72-year-old gentleman, 20 to 25% global hypokinesia. How would you read this ECG? पूरी रिपोर्ट चाहिए मुझे. घर पे हूं. And also tell me whether you are concerned or not. यानी कि फोकस जो है वो सेंट्रल टेबल पे चला गया. अब सेंट्रल 2 टेबल्स के ऊपर, वहां से आप लोग अपना उठाएं अलम. नहीं, एक बंदा बोलेगा और फिर उसके ऊपर वी कैन जंप इन. These are all ECGs which will generate a lot of discussion. आज हम मेरा ख्याल से 13 खत्म नहीं कर सकेंगे.
So these are biogeminis.
Okay.
There's a sinus beat followed by PVC, and the PVC origin looks like to be RVOT.
Okay.
Right side, and 2-3 AVI positive outflow track.
RVOT.
Yeah.
Okay. ठीक है.
Can you read? Why don't you read the ECG from the beginning, like we would, as a medical student would?
So I would have thought. देखो जब भी इस किस्म की चीज आए, why is PVC important? The sinus is important. कि उसका underlying क्या चल रहा है, और उसके साथ फिर आप उसको करेंगे. So I would read this, ठीक है ना? And आप V1 में जहाँ भी आपको पहले साइनस रिदम बताओगे. अंडरलाइंग साइनस रिदम क्या है? आर देयर क्यू वेव्स?
LVV pattern looks.
नहीं, डोंट जंप टू कंक्लूजन्स. रीड एज डॉक्टर आजम इज सेइंग. Always read the ECG. So give me a sinus report. Leave the PVCs. I don't care about the PVCs. I am worried about के 25% ejection fraction है. Underlying sinus क्या बता रहा है? Does it look like a cardiomyopathic ECG of sinus rhythm? क्यों? क्यों? और अगर आप लोग देखो, जो आंसर जब दे लेता है और मजीद ऐड करने को नहीं है, कैन से पास एंड द नेक्स्ट पर्सन कैन टेक ओवर. दैट वे वी विल जनरेट अ हेल्दी डिस्कशन, जैसे हम लोग कर रहे हैं आपस में, सीनियर्स. सो अच्छा, सबसे पहली चीज है, इज इट साइनस रिदम? व्हाई? बिकॉज पी इज upright in lead 2 and inverted in AVR and positive in lead 1. So coming What is the PR interval like? I know there's no grid over here, but ये थोड़ा सा अगर आप impression ले लें, तो it's more than 120 milliseconds and less than 200 milliseconds. So PR interval is normal. What about the axis?
Axis is normal.
Sure? So आपका जो ये वाला axis है lead 2 में, ये isoelectric तो नहीं है, positive थोड़ा सा ज़्यादा है. जो amplitude, अब आप देखो कि सबसे ज़्यादा amplitude किसका, ये eyeball ही करना पड़ेगा. 1 का है, ABL का है, या -3 का है. और -3 में से आप थोड़ा सा ये पॉजिटिव माइनस करेंगे, तो ये इससे आप समझो ये इतना है. ABF जो है एग्जैक्टली ABF जो है आइसोइलेक्ट्रिक है, तो इस पे 90 डिग्रीज पे 1 होगा, ठीक है, और 0 डिग्री के बाद ABL भी पॉजिटिव है. सो इट इज बॉर्डरिंग ऑन योर एक्सिस शिफ्ट. ये कोशिश कर रहा है उधर जाने की, क्योंकि आप सिर्फ तो इसके ऊपर नहीं कर सकते ना, इसको भी तो आपको देखना है. ABL is positive, that means के between 0 and -30 के दे, तो some books would even suggest ये left axis है, although let's go with Dale Dubin, and it's a leftward axis. What about the QRS duration? Is it narrow, wide, normal? So it is kind of wideish, and then you have your STD changes. If you look at the STD changes, are they commensurate with the depolarization abnormality or are they significant? जब बंडल ब्रांच ब्लॉक होता है या वाइड QRS होता है, तो क्या फॉलो करता है रूल? टी वेव उसी डायरेक्शन में होगा जिसमें ऑपोजिट डायरेक्शन में. तो इज इट ऑपोजिट और इज इट ऑपोजिट? सो रिलेटिवली नॉर्मल. ओके, then is it a left bundle branch morphology or a right bundle branch?
Left bundle branch.
Okay, should you have a small R wave in left bundle branch block? क्योंकि लेफ्ट अगर ब्लॉक हो गया तो मिड सेप्टम तो लेफ्ट टू राइट एक्टिवेट नहीं होगा. तो अगर ये आ रहा है तो शुड यू कॉल इट अ लेफ्ट बंडल ब्रांच ब्लॉक? यू कैन कॉल इट IVCD, बट ये मैं सवाल इसलिए पूछ रहा था बिकॉज देयर इज एन एंटीरियर fascicle, there is a posterior fascicle, and there is a mid fascicle, which actually is a small one, goes and feeds the mid septum, and that's why in a significant majority of or significant number of left bundle branch blocks you don't lose this R wave. Ideally you should. अगर लेफ्ट बंडल ब्रांच ब्लॉक आप जिस तरह से हमें स्कूल में पढ़ाया जा रहा था वो बंद हो जाता है तो आप नहीं जाएगा उधर, वो आर लॉस हो जाएगा, बिकॉज दिस इज सेप्टल एक्टिवेशन. दिस आर वेव इज सेप्टल एक्टिवेशन. तो बहरहाल मिड फैसिकल के साथ होगा. तो आई will go with you that this is a left bundle branch block, क्योंकि V6 is very classic. Sorry, ये तो PVC है. ये भी even classic of left bundle branch block, although transition has been pushed right down to V5. So normal ECG shows a left bundle branch block with a possible left anterior hemi block trying to happen. So this is not just a clean left bundle branch block. अगर left bundle branch block, does left bundle branch block cause axis shift? No. Normally it does? Doesn't. And if it happens, what is the cause? So whenever you have an axis shift, it's because of the anterior fascicle going before the posterior. Posterior बहुत robust होता है, dual supply होती है, मोटा होता है, जाता नहीं आराम से. Anterior fascicle easily जाता है. But अगर left bundle branch block itself is a morbid condition. It causes cardiomyopathy on its own. अगर आपको लेफ्ट बंडल 10 साल रह जाता है, 15-20 साल, इफ यू गेट एन एंटीरियर फैसिकल ब्लॉक मॉर्बिडिटीज, उसे हम पुराने वक्तों में जो क्लासिक शैमरॉथ की किताबें उसमें लिखा हुआ है, डॉक्टर जनरल इमरान बताएंगे कि वो उसको कहते थे कॉम्प्लिकेटेड लेफ्ट बंडल ब्रांच ब्लॉक, इवन इन दोज डेज. एंड अब तो हमें पता ही है कि वो करें, तो दिस वुड प्रोबेबली बी रिफ्लेक्टिव ऑफ द कार्डियोमायोपैथी. अब पीवीसी बताओ. अब इन दिस मिली सेटिंग पीवीसी को पढ़ें, और पीवीसी कैसे पढ़ते हैं, दैट इज व्हाट आई वांट यू टू टेक अवे फ्रॉम हियर. जब आप रिपोर्ट करते हैं पीवीसी, क्या सारी पीवीसी एक जैसी होती है? कोई मार सकती है? तो जो मार सकती है उनकी क्या खासियत होती है, तो वो इसमें पिक करने की जरूरत है. और क्या इसमें पीवीसी के साथ मरने का चांस ज्यादा है कंपेयर टू अगर मैं कहता बिल्कुल नॉर्मल अंडरलाइंग नॉर्मल वो है ईसीजी. When you read ECGs, when you get numbers, when you get labs, you should see कि how is it translating at a larger level for the patient. अगर ये वाली ECG में देखूंगा मरीज को कहूंगा आपके मरने के चांसेस ज़्यादा हैं, या सोचूंगा हम छलांग लगा के प्रोसीजर कर देंगे विदाउट इवन डिस्कशन, उसको बताओ कि क्यों कर रहे हैं, बिकॉज ऑफ व्हाट. तो ओके, व्हाट इज शॉर्ट कपलिंग इंटरवल, यहां से आवाज आई है शॉर्ट. व्हाट इज शॉर्ट कपलिंग? हाँ, अब 220 नहीं, मतलब कि कोई कट ऑफ होना चाहिए ना. मतलब डेंजर कब आता है? जब आपकी पीवीसी पड़ रही होती है, वो किस जोन में डेंजर होती है? टी वेव के प्रॉक्सिमल या डिस्टल लिम के ऊपर पड़ जाती है, या इवन यू वेव के इन सर्टेन कंडीशन, तो वो शॉर्ट कपल. तो आपका नॉर्मल क्यूटी इंटरवल कितना होता है? 430, 415 विमेन. तो अगर 400 की रेंज में पड़ रही है तो इट्स अ शॉर्ट कपल्ड. अगर आप 460 से लेके 600 पे पड़ रही है तो इट्स अ लॉन्ग कपल्ड, या इट्स सेफर. इफ इट्स मोनोमॉर्फिक, एक जगह फिक्स्ड कपलिंग इंटरवल है, तो लेस लाइकली टू कॉज डैमेज. इफ इट्स मूविंग, it's more likely to cause damage. If it's polymorphic, that means it's changing origin or changing exit points, it is more dangerous. And in this milieu, it will be very dangerous. तो पूरी रिपोर्ट आनी चाहिए आपको. And then डॉक्टर यावर कहेंगे मैं तो इसको अबलेट करता हूँ, तो आप क्या इन्फॉर्मेशन देंगे कि आप क्या समझते हैं कहाँ से आ रही है? क्योंकि कुछ जगहों से आप 90% सक्सेस के साथ अबलेट करेंगे, कुछ जगह आप नहीं कर सकते. तो दैट इन्फॉर्मेशन ऑल्सो. सो करना है किसी, चलो आगे प्रेस.
जैसे डॉक्टर यावर कह रहे हैं कार्टून से मैप करेंगे और वो निकाल लेंगे कहाँ से आ रही है.
हाँ वैसे ये बात भी है. ठीक है, सो ये मैंने कपलिंग इंटरवल निकाल लिया. सो करो प्रेस प्रेस प्रेस. सो दिस इज साइनस रिदम, नॉर्मल पीआर, लेफ्ट एक्सिस डेविएशन, बॉर्डर लाइन, लेफ्ट पंडल ब्रांच ब्लॉक, बाइजेमिनल पीवीसी, लेफ्ट पंडल ब्रांच ब्लॉक मॉर्फोलॉजी. एक्सिस आपने बताना है पीवीसी का, ट्रांजिशन आपने बताना है पीवीसी का कि किस जगह पर ट्रांजिशन हो रही है. R equals S. MDI is maximum deviation index बताना जरूरी होता है, बिकॉज अगर आपका 55% से ज्यादा है, जब मैं ट्रेन करता हूँ 60% होता था, वो नीचे हो गया, तो उसका एपिकार्डियल फोकस की बात हो सकती है उसमें. एंड कपलिंग इंटरवल आपने इसमें बता देना है. ठीक है, सो दिस रिपोर्ट नीड्स टू कैरी ऑल दिस इंफॉर्मेशन बिकॉज यू वर द वन हु सॉ एंड मेजर्ड. ठीक है जी, नेक्स्ट प्लीज. ये मैंने MDI इसमें निकालने की कोशिश की है, बट आई थिंक वी शुड मूव टू. ठीक है, अच्छा MDI में ये कि आप चेस्ट लीड जो है उनको सबको अलाइन करेंगे, और उसमें जो आपकी अर्लीस्ट एक्टिवेशन आती है, यानी कि आपने उसको निकालना है फ्रॉम स्टार्ट टू द मैक्सिमम. उसमें जो उन 6 लीड्स में जो सबसे अर्ली आ रही है उसको डिवाइड करना है विद अ वाइडेस्ट QRS, तो आपको फिर MDI देगा. ठीक है, दैट्स इट्स इंपॉर्टेंट स्पेशली विद इन द realm ऑफ अब्लेशन. नेक्स्ट प्लीज, नेक्स्ट.
आमिर ये इनको एक दफा बता दे कि MDI अगर ज्यादा हो तो एपिकार्डियल फोकस क्या वो क्या.
हाँ, मतलब कि अगर आपका MDI जो है लेट्स से 55 आप कह रहे हैं, 60 या 65 आ जाता है, तो आपका जो फोकस ओरिजिन है वो एपिकार्डियल होगा. ठीक है ना, यू कैन हैव इट इन दी ऑन द लेफ्ट साइड इन दी एओर्टिक. अगर आप RBOT से जा रहे हैं, एपिकार्डियल भी हो सकता है, यानी कि यू हैव टू देन अप्रोच इट फ्रॉम आउटसाइड. एंड नेचुरली एपिकार्डियल एक्सेस का एपिकार्डियल एब्लेशन की मॉर्बिडिटी इवन इन एक्सपर्ट हैंड्स इज मच मोर देन व्हेन यू गो एंडोकार्डियली. ठीक है, तो ऐसी चीज पे हाथ डालने की जरूरत नहीं है. अगर आपको पहले से पता चल जाता, मरीज को बताएं कि भाई ये बाहर से आ रहा है, एंड वी मे हैव लिमिटेशंस गोइंग अप ओवर देयर. एंड आई हैव सीन इन माय करियर पीपल से नहीं करो करो अब्लेट करो अब्लेट करो अब्लेट करो. अल्टीमेटली जब वो अब्लेट हुआ तो वो अब्लेट नहीं हुआ, डायगनल अब्लेट हो गई. ओके, आज ये भी उसी किस्म का केस है, इसको आगे निकाल देते हैं. आई जस्ट वांटेड टू शो कि ये नैरो कॉम्प्लेक्स के साथ है और वो वाइड कॉम्प्लेक्स के साथ था, और उसी किस्म की रिपोर्ट है. नेक्स्ट प्लीज, आगे कर दो ये. नहीं, क्योंकि टाइम कम है एंड आई वांट द इंटरेस्टिंग ECGs टू बी. हाँ, ये so this is a 59-year-old man with syncope back in 2020. this is the ECG. ये तो सिंपल है, ये करोगे तो अब अगली पे चलेंगे. फर्स्ट डिग्री AV ब्लॉक. जो बोल रहा है वो हिम्मत के साथ हाथ उठा के पूरी रिपोर्ट पढ़े. टाइम कितना है अभी? कोई बात नहीं. है? अच्छा,
Yes, 25.
नहीं वो हमारी अच्छी जनरेट हो रही थी. डॉक्टर आजम खामोश हो गए वहां जाके, लैटरल लेफ्ट लैटरल टेबल पे जाए. सर आप सेंटर में आए, ये क्या बात हुई यार? यहाँ सीनियर लोग जो हैं आप लोगों से ज्यादा तेज हैं, वो पिक कर रहे हैं. हाँ बताओ ना, खड़े होके जल्दी जल्दी करो. इसके लास्ट वाली ईसीजी का सेट बहुत अच्छा है, सो डोंट मिस दैट.
It's a complete heart block with the ventricular.
अच्छा, ओके ओके, आई विल आस्क यू 3 क्वेश्चंस. ठीक है, नहीं देखूंगा ईसीजी की तरफ. आर देयर मोर पी वेव्स? व्हाट इज द पीआर इंटरवल वेरिएबल और फिक्स्ड? पीआर इंटरवल को देखो और मुझे बताओ वेरिएबल या फिक्स्ड. अगर फिक्स्ड है तो कंप्लीट एबी ब्लॉक नहीं हो सकता. आरआर इंटरवल फिक्स्ड है वेरिएबल है? फिक्स्ड है. तो क्या डायग्नोसिस बना? ठीक है, नहीं आरआर फिक्स्ड है या नहीं है पूछ रहा हूं ना. नहीं है, ठीक है. बट हम उस जगह पे रुक जाते हैं कि अगर पीआर इंटरवल फिक्स्ड है तो इट कैन नॉट बी थर्ड डिग्री एबी ब्लॉक, इट कैन नॉट बी वेनकी-बाख ब्लॉक. So the only condition which remains is second degree AV block. And second degree AV block, now the question is it a high grade block? हाँ, later half में RR fixed है, but PR interval also fixed. But my question is कि ECG में आप widest देखते हैं, shortest देखते हैं, most dangerous देखते हैं, तो क्या कोई ऐसी जगह है जहाँ high grade block आ रहा है इसमें? कमान यार, ये तो मेडिकल स्टूडेंट वाली लेवल की ईसीजी है. फायदा ये होता है जब आप ईसीजी पढ़ा रहे होते हैं ना अंडर प्रेशर करने पर, ये कह दें बस कि मेडिकल स्टूडेंट की. मुझे भी 6 घंटे लगे थे इसको समझने में. 3:1 हो गया है, तो 3:1 हाई ग्रेड हुआ ना. व्हेन यू ड्रॉप 2 P's यानी 2 QRSs ऑन अ P, देन इट्स अ हाई ग्रेड ब्लॉक. तो यहाँ हाई ग्रेड ब्लॉक हो रहा है ना. ये देखो P मॉर्फोलॉजी बिल्कुल चेंज हो गई है. And this is the basic PP interval. So this is sinus tachycardia with a high grade AV block. And यहाँ 2-1 block भी चल रहा है आगे बीच में. अब पेसमेकर डाल दिया. नेक्स्ट नीति. अच्छा ये तो हो गया है. नेक्स्ट, हाँ अब हमने ये डाल दिया इसको पेसमेकर. और पेसमेकर डालने के बाद वो एक दिन मेरे पास आ गया कि मैं बिल्कुल ठीक रहा हूँ, 2 साल कुछ भी नहीं हुआ मुझे. अब मुझे फिर पैल्पिटेशन शुरू हो गई है. So, what do you think? 2 साल के अंदर अंदर खराब हो गया पेसमेकर. कुछ हमने गड़बड़ कर दी है, गलत वाला डाल दिया था, लीड चेंज करने की जरूरत है. सब लोग अपने फोन छोड़ दें. कम ऑन, पेसमेकर डल गया है. पेसमेकर के बाद वो मेरे पास पैल्पिटेशंस के साथ आ गया है. तो क्या उसको पेसमेकर मीडिएटेड टैकीकार्डिया हो रहा है? क्या हो रहा है? आरआईसी है, राइट बंडल ब्रांच ब्लॉक. पीछे जाओ एक, तो ये पीछे का है. आगे आ जाओ. ये क्या है? इधर क्या है? एक दफा फिर पीछे जाओ, इनको ओरिजिनल वाला दिखा दो. ये ओरिजिनल था, आगे आ जाओ. अब ये, सो ट्राई टू, दीज आर द सेम पेशेंट्स. 20 साल, मतलब 20 साल कह रहा हूं, 2 साल अपार्ट. पेसमेकर सिंड्रोम टेबल पे हो जाता है, मतलब अर्ली होता है ना पेसमेकर सिंड्रोम. वेंट्रिकुलर पेसिंग अगर आपकी होगी तो आपको चक्कर चक्कर आना शुरू हो जाएंगे ना, सिर्फ अगर एवी सिंक्रोनी आपकी लॉस होगी. यहां तो वो आपको कह रहा है मुझे पैल्पिटेशंस हो रही हैं, मुझे घबराहट हो रही है, और 2 साल के बाद.
वैसे डॉक्टर यावर ने कहा लीड V1 को देखें, तो आप लोग नहीं देख रहे.
डॉक्टर यावर की बातें सुनते नहीं आप लोग.
गौर से देखें, गौर से.
किसने कहा, किसने कहा एक्सेप्ट? तो वेयर, ठीक है, 2 P वेव्स, एक ये है एक ये है. तो क्या ये हो सकता है पेसमेकर में? तो पेसमेकर क्यों नहीं 1-to-1 क्यों नहीं कर रहा? MVP मोड भी बहुत ही फजूल मोड होता है. वो इसलिए मैं कहता हूँ फजूल मोड होता है। कनाडा में एक दफ़ा मुझे बर्फ़ में उन्होंने बुला लिया था, मैं गया, सर्जन ने सर्जरी की थी, कह रही थी, नर्स ने कहा कि ये पेस मेकर ख़राब हो गया, तो वो MVP मोड में था। मैंने उसको जाके नॉर्मल में कर दिया, वो खुश हो गए। सर्जन खुद ट्रॉली लेके मेरे साथ चल रहा था उसकी पेस मेकर की, बट बर्फ़ में निकलना पड़ा था। नहीं, MVP में यू विल मिस ए साइकिल इन ऑर्डर टू सी के नेटिव पेसिंग हो रही है, पर यहाँ तो एक ही पूरी ECG चल रही है ना एक जैसी। अपर ट्रैकिंग रेट में ये होता है कि देखो ये अपर ट्रैक भी नहीं कर रहा ना, ये तो तेज नहीं है। अपर ट्रैकिंग में आपकी रेट अपर ट्रैक पे चली जाती है 1 to 1, तो यहां तो रेट नॉर्मल चल रहा है, पर उसे बड़ा बुरा फील हो रहा है, जो कि पहले नहीं हो रहा था। ही वॉज वेरी वेरी हैप्पी। और ये पिक कर लिया आप लोगों ने, ये क्यों नहीं पेस हो रहा, ये ए क्यों नहीं ट्रैक हो रहा? यस, दिस इज एन एट्रियल टैकीकार्डिया, ठीक है, तेज हो गया है, या इवन साइनस रिदम हो सकता है, साइनस टैकीकार्डिया। अब साइनस टैकीकार्डिया इसको क्यों होगा? जब मैंने पेसमेकर डाला था उस वक्त इसका इजेक्शन फ्रैक्शन नॉर्मल था। जब हमने एको कराया तो इसका इजेक्शन फ्रैक्शन 20 से 25% था। तो इज कॉम्पनसेटिंग फॉर दैट। सो दिस इज हार्ट फेलियर कॉम्पनसेशन, एंड ये उसका रेट तेज हुआ है, तो ये 2 to 1 ब्लॉक में चला गया है। आगे हाँ, जो आप कह रहे हैं कि जो 2020 का था उसमें, हाँ बिल्कुल आप सही कह रहे हैं कि उसमें वो भी हो सकता था, और ये प्रॉबेबली साइनस टैकीकार्डिया, इनअप्रोप्रिएट साइनस टैकीकार्डिया, साइनस री एंट्री, वो सब चीजें हो सकती हैं अपनी जगह पे। लेकिन ये कि उसके साथ उस वक्त हम पेसमेकर बीटा ब्लॉकर नहीं दे सकते थे इसको, लेकिन पेसमेकर डाल के ही वाज फाइन एंड ही डिडंट हैव एनी प्रॉब्लम, बट देन द EF वेंट डाउन एंड पॉसिबली ड्यू टू मायोकार्डाइटिस या कुछ इस किस्म की चीज हुई है। आप पता है वो माइक यूज करोगे, मुझे आपकी आवाज नहीं आ रही।
सो ये जो फर्स्ट, सेकंड, थर्ड, फोर्थ, फिफ्थ QRS कॉम्प्लेक्स से प्रोसीड कर रहा है पहले,
ये यहां से 1 2 3 4 5।
सो PR इंटरवल ऑफ दिस,
यस,
as compared to the rest of the PR intervals, how do you feel about them? मुझे
हाँ,
तो
ये देखो जो आप कंडक्ट कर रहे हैं ना, ये रिलेटिवली फिक्स्ड है जो कंडक्ट कर रहा है। ये तो पहली वाली PCP,
लेकिन ये फिफ्थ वाली का I feel it's not fixed, it's different from।
अच्छा, हमने इसको मेजर किया था
इससे पिछले वाला जो था। So if we take it to the fifth one,
so 1 2 3 4 5,
ये this PR is not the same as the other ones.
इसमें ना तला थोड़ा सा QRS की भी मॉर्फोलॉजी का डिफरेंस है,
राइट,
कि अगर आप देखो ना यहाँ मॉर्फोलॉजी चेंज है, इधर मॉर्फोलॉजी चेंज है, तो ही हैज कंडक्शन सिस्टम इश्यूज एट दैट टाइम आल्सो, ही इज गॉट अ राइट बंडल ब्रांच ब्लॉक, तो उसकी वजह से भी लग रहा है PR इंटरवल। बट बाय एंड लार्ज जो हमने इसका लॉन्गर स्ट्रिप्स वगैरह देखी हुई हैं, बिकॉज वी आर प्रिवी टू दैट, उसमें फिक्स था।
मैं सिर्फ इसलिए थोड़ा सा इसको पॉइंट आउट किया, आई थिंक क्वाइट ऑफ्टन वी कम अक्रॉस लॉट ऑफ डॉक्टर्स आस्किंग, सर ये फिक्स तो चल नहीं रहा है, देयर इज अ सटल डिफरेंस। तो उसमें
सटल डिफरेंस हो सकता है, बिल्कुल, इट्स अ वेरी गुड पॉइंट। सटल डिफरेंस हो सकता है, आप डिपेंडिंग ऑन कहाँ से आपका एस्केप आया है, इवन रेस्पिरेटरी वेरिएशन AV के ऊपर भी आती है, और अगर आपका PP इंटरवल के बीच में QRS पड़ रहा है, तो ड्यू टू मल्टीपल मैकेनिज्म्स इट कैन पुल इन द PP द RR, सो उससे आपकी वेंट्रिकुलोफेजिक चेंजेस आ सकती हैं। तो वो फिक्स्ड वाली बिल्कुल सही कहा कि वो नहीं चलता। नेक्स्ट 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 नेक्स्ट, दिस इज 2 to 1। दिस ये वाला जो है वो तो हाई ग्रेड था, ये जो पेस मेकर के बाद है उसके बीच में यही हुआ है कि दिस इज फॉलोइंग द P वार्प एज शी हैड सजेस्टेड, एंड वो कंडक्ट नहीं कर रहा, बट उसके जो सिम्टम्स ज्यादा हो रहे थे वो हो रहे थे बिकॉज ही सडनली स्लो डाउन। पहले 1 to 1 कॉम्पनसेट कर रहा था वो, जब वो उसके रेट इतना तेज हुआ कि वो जब 2 to 1 ब्लॉक कर गया, हार्ट रेट स्लो हो गया, ही स्टार्टेड बिकमिंग सिम्टोमैटिक, एंड नेचुरली द EF वाज लो, ही वाज इन फेलियर। बट द रीजन वाज क्योंकि प्रोग्रेसिवली कॉम्पनसेट करने के लिए साइनस तेज होता गया टिल द पी स्टार्टेड फॉलिंग इन द पोस्ट वेंट्रिकुलर एट्रियल रिफ्रैक्टरी पीरियड. It could be. That's an excellent question and that is what we worried about. फिर हमने इसके सारे टेस्ट कराए. It turned out कि नहीं था वो. फिर हमने इसको अपग्रेड किया to CRT. Next.
Dr. Faria.
Faria? हाँ.
The first thing that we want the fellows to know that if this lead is in the right position,
yes,
if the nurses or technicians have placed the leads in the right position, the first thing that you see is positive R wave in V1 and V2, and you question yourself, is the lead in the right ventricle or not? And obviously you're going to look, you follow the Klein maneuver and you do it, and you make a habit of looking at the ECGs that way. Since the axis is negative and V1, V2 could be misplaced V1, V2 position, so this doing Klein maneuver will make your leads look better than in the RV position.
Thank you. Very, very important point. ये किसी ने भी नहीं उठाया था कि जब पेसमेकर इसको पड़ गया, this is a purely paced beat, तो ये आपका राइट बंडल, इसका मतलब फाड़ दी हमने लीड, दूसरी तरफ चली गई है, लेफ्ट पे जाके पेस करेगी तो राइट बंडल पैटर्न आएगा ना, और ये राइट बंडल पैटर्न है. So what Dr. Faria is saying is, which is a very common mistake. ये जो ऊपर वाली लीड्स हम लगाते हैं, अगर विमेन होंगी या फैट लोग होंगे, उनके बीच में हम कन्वीनियंस प्लेसमेंट कर देते हैं, थोड़ा सा ऊपर कर देंगे. जब हम remember always that if your AVL resembles your V1, you are in the wrong position. And sometimes जो हमारी ECGs हम रिपोर्ट कर रहे होते हैं, हम कहते हैं Qs and V1, V2, septal infarct. सेप्टल इंफार्क्ट के बाद उसकी लंबी इन्वेस्टिगेशन शुरू हो जाती है. टर्न्स आउट देयर वाज नथिंग रॉन्ग. नाउ इफ आई वर टू डू एन एंजियोग्राम ऑन दिस पेशेंट एंड गिव हिम अ स्ट्रोक व्हिच इज 1 in 1000, तो वो तो मारा गया. सो ऑलवेज गेट द लीड पोजीशन करेक्टेड. एंड अदर देन दैट, अगर आप करेक्ट करने के बाद भी ये इमेज रहती है, तो सेप्टम का एक पार्ट ऐसा है which sometimes behaves like the left ventricle. It has been well reported. तो हम अगर जब आप प्लेस कर रहे होते हैं लीड, तो आप कोशिश करते हैं कि आप सेप्टली प्लेस करें लीड को. इवन एपेक्स के साथ भी सेप्टम में जाएंगे, क्योंकि अगर फाड़ के उधर निकलते हैं तो फ्री वॉल इज अ डेंजरस प्लेस. वहाँ आप स्क्रू इन कर रहे हैं, जोर लगा रहे हैं, फाड़ सकते हैं आप आराम से. तो बेटर, तो ये चीज़ हो सकती है. अगर आपने मिड सेप्टम में हाई अप लगा दी तो इस किस्म की पोजिशन आ सकती है. बट लीड करेक्शन इज वेरी वेरी इंपॉर्टेंट. हाँ, सो वो बिल्कुल वो सारी चीजें बेसिक्स ऑफ ईसीजी आपने नहीं छोड़नी है. बट ये चूंकि पेस्ट रिदम है, लेस लाइकली टू बी रिप्रेजेंटेटिव. बट अगर ये कि नेटिव रिदम आ रही, तो आरवीएच अगर होगी ओवर टाइम, तो वो भी आर बड़ा कर सकती है और उसके साथ यहाँ एक्सेस शिफ्ट हो जाएगा.
So we have 10 minutes.
हाँ, आगे चला दो इसको. वो लास्ट वाली जो है ना, हाँ, ये तो खैर, व्हाट डू यू थिंक? सिंपल है, ब्रेड एंड बटर ईपी है. इसके ऊपर मुझे जल्दी से बता दो डिफरेंशियल डायग्नोसिस, top of your differential diagnosis, and then tell me what you're going to do when the tachycardia breaks. What's the first thing you're going to look at? सही, वो पकड़ के उसमें माइक्रोफोन में बोलो यार. चीफ इधर रहने दो एक ना इनके पास, ताकि ये लोग थ्रो कर सकें. बैठ के ठीक है.
Narrow complex regular tachycardia and P waves are visible with 1:1 conduction, and this seems to be long RP tachycardia.
अच्छा, so where are you seeing the P waves? These? कहाँ?
सर V5, V6 के अंदर बहुत अच्छी.
ये?
सर T के बाद P waves नजर आती है.
ये यहाँ? देखो, P wave is a real robust morphology. हल्की हल्की squiggles नहीं होनी चाहिए. बाकी जगह भी देख लो, बाकी किसी जगह पे नहीं आ रही है. If you were to say कि ये यहाँ, because जो STT changes, STT waves हैं, these are gradual slopes. अगर इसमें sharp squiggle आ रहा है, तो then it could be harboring an inverted P wave over here. यहाँ आ सकती है. ये जो blip आ रहा है ना, if you were to say that this is a P wave, now let's say this is a P wave, it's a narrow complex tachycardia, what would be your differential? Top of your differential? AV-NRT या AV-RT?
AV-RT.
Antidromic?
Orthodromic.
Orthodromic, ठीक है. So that should be the top of your differential. However, slow pathways, as General Imran can tell you, can present in any way, intermediate, slow, fast, पता नहीं क्या क्या होते हैं वो, तो P can fall anywhere, but going with the majority, if the P wave is falling over here and inverted over here, so it's most likely to be AV, RT, that would be top of our differential diagnosis. So what would you look for as soon as you terminate?
So delta waves on.
Delta waves. So let's say if I did not have delta waves on the ECG, would I still be AVRT? Possibility?
Yes.
Why?
Concealed pathway.
Concealed pathway. And उसकी कोई percentage है? कितने होते हैं concealed pathways?
Exactly, sir.
चलो कोई बात नहीं. इंतखाब वो इंतजार देते हैं. इसका जवाब तो differentially में रहेगा. About 60% of the free pathway of the accessory pathways can be concealed. वो मेरे पास वो नहीं है इसको. अच्छा.
Sir, could it also be septal pathways?
ये सही. Sorry.
Sir, hello. Sir, could it be septal pathways as well?
So the previous one.
Yeah, the previous one.
So I cannot see the P waves in. So if you can see the P waves, you can track, yes. Okay. So let's say if you had a free wall, I will go with a common example, then you will see that the P wave will be inverted in one AVL.
Yeah.
In septal pathways, the spread is going to be like AV and RT.
Yeah.
So sometimes it becomes very difficult, except the fact that the RP interval will be more than 70 milliseconds. So that, so this is the baseline ECG. हाँ, so नहीं 2 minutes back. ठीक है, so delta?
Yes, sir.
Okay. This was not a concealed pathway. What about this? 71-year-old man with recent stroke, and he was referred to us, and he was on anticoagulation, and he was read as atrial fibrillation. So do you concur? Agree with me? इस trace पे, do you see atrial fibrillation? Okay, what do you see? How would you read this trace? मुझे बताओ फोन करके. एक मिनट यार, पता है मुझे हर तरफ से आवाज आ रही है. एक बंदा आइडेंटिफाई करके बताए ताकि. So how do you read this? इसको छोड़ दो बेशक, इसको read करो.
Sir, first of all, we get basically sinus beats, and there's sinus bradycardia at the start.
Okay.
And then up till the third beat, we have that, and then there's another focus which takes up because the P wave morphology has changed.
Yes.
And then the rate picks up, goes to around about 100, and then that focus slows down, and we get the same sinus beat again after a long pause.
Okay, so what do you think is the origin of this rhythm?
I think it's from the left atrium.
Sorry?
The left side, maybe.
So I don't know the leads that they put because this is not my regular trace.
Okay.
But what about the width of the QRS? If you were just to look at of the P wave and compare the width of the P wave to the, let's say you didn't know the leads.
Yeah.
What would you say the origin would be? Would it be center of the heart, right free wall, left free wall?
Near to the septum, I think.
Near to middle of the heart, probably. Yeah. And what is that organ or not organ component
CS,
that?
Maybe near the CS somewhere?
CS can. Let's say if this activity was more rapid and this was the morphology and the patient had a stroke, where would you try to look for the triggers? देखो सेप्टम से तो सब चीज CS भी आएगी और लेफ्ट साइड से अगर पल्मोनरी वेन से रिदम निकल के बाहर आ रहा है इस साइड के ऊपर, चूंकि उसकी मतलब पैरेलल स्प्रेड होगी, सीरियल स्प्रेड नहीं होगी, तो इट विल गिव यू अ नैरो कॉम्प्लेक्स एंड मैकेनिस्टिकली यू वुड एक्सपेक्ट कि दिस कुड ट्रिगर अ एट्रियल फिब्रिलेशन इवेंट. So right-sided pulmonary veins. If you have left-sided pulmonary veins, probably it will have a longer time because वही निकलेगा वहाँ से Bachmann's bundle से ऊपर जाएगा या foramen बीच में से या CS से जाएगा and will right side will be the last point to be activated. So QRS, the P wave will become wide. Sir?
Without the leads even being labeled.
No, I'm not, sir, I'm not labeling. That's why I said.
No, I'm really saying that it's not fair to ask these people where it's coming from. All you can say is that the P wave is narrow.
Yes.
So you will suspect that it is somewhere coming from the septum.
Precisely.
Your comment regarding coronary sinus, if it is near coronary sinus, yes, your P will be broad.
Yes.
But when you are in the septum, let's say mid-septal area, it will be narrow. So all this is
yes.
what we can say, but I would not ask somebody where is this coming from. You know, questions about is it superior wear or this in conduction time? There are a lot of factors, you know, because we do 3D mapping.
Gigi.
And I see all the garbage in there, that the conduction can be too long, all that. So believe me.
No, I agree with you.
It's not that simple, just a comment.
No, I understand that it's not simple. I'm just trying to put across a mechanism in their minds that a lot of times, this patient may not have a 3D map. So if you don't have a 3D map and you have this, they should have a mechanism in which they can at least say that this is mid-septum or, you know, it's coming from lower down.
Where it is helpful is, I will send you, if I have your phone, I'll send you an ectopic tachycardia for your interest, incessant ectopic tachycardia, which I'm going to do 3D mapping. And I showed it to Imran yesterday, and
yes.
I already have in my head where it is, like I was telling him, like golf, before I do my setup and then hit. So the thing would help you if you are going to do an ablation or something, or mapping to pre-plane, but you need something more than this.
Oh, definitely. We will do an EP study when we go in, we map the tachycardia, but they only have this ECG. So they are going to give me some thoughts on that. Okay, so next please.
So we have two
Next. Chale, what do you think about this? This is the last, I think, yeah. And we have 6 minutes. What do you think of this? ये तो bread and butter है. You will have no problems. So with the last ECG, the question was not where this is coming from, what can be the possibility of the origin of the tachycardia. You understand that. And so you should understand that when you do not have complex mapping systems and you're looking at just point blank ECG, which in many places in Pakistan you should be able to know what you're dealing with. Have an idea and then refer the relevant patient to a center where expensive 3D mapping will be done. हाँ जी, nobody? ये तो यार every day देखते हैं. Sinus rhythm? Any STD changes? So how many of you will call it an MI, an ST elevation MI? Okay, and why would you do that? So there are ST elevations in the inferior leads and ST depressions and one in ABL, and this is your reciprocal, and you are seeing some degree of ST change in V1 and V2 as well. So run of the mill inferior wall MI. Shall we go in and do an angiogram? Okay, we go in and do an angiogram, and there is some disease in RCA, and the interventional cardiologist fixes it, and there is non-obstructive disease on the left side. Next ECG. Next. Okay, so these are serial ECGs, just keep looking, and then we can discuss. Abhi rok ke rakho, break, aage. So this is C. Keep looking at what do you think about the ST segments? Bad gayi. Okay, very good. Next. And what about these changes? Were these changes? ये मेरा ख्याल से खत्म हो गया. हाँ, so T wave inversions over here also, na? In V5 and V6, my pointer has died on me. Next, please. What about now? And this is evolution over time. अब क्या हुआ है? So that means nothing happened when we fixed the right coronary artery. Now we've done something to the lateral territory as well, or apical territory, because there are ST elevations of. What would be the differential in your mind now? Troponins are sky high.
And the patient had relook angiogram that showed stent was patent in RCA.
And we had done nothing to the left side. So pericarditis causing a new rupture, MI? Yeah. So you would say, but in pericarditis generally you have ST elevations. You're getting ST depressions also. So you're saying that you had an MI and a concomitant coronary artery acute event. Two things generally don't happen together, but yeah, rarely they can. ठीक है? Next, please. Next. What about here? What do you think? What about the rhythm? Hyperkalemia, potassium is 100% okay. What is happening to the rhythm? जोर से बोलो माइक में.
There is AV dissociation.
So when we say AV dissociation in the old, language, it means that ventricles should be faster than the atria. Is this ventricular AV dissociation or third degree AV block?
It's a third degree.
ठीक है. So you are seeing more P waves. मेरा pointer खत्म हो गया, but you are seeing more P waves. P and PR interval is variable. RR interval is fixed. So this is complete AV block and a wide escape. So we put in a TPM. ठीक है? Okay, आगे चलो. Same ECG, same patient. What do you think now? This is such a beautiful evolution that I wanted that I should share it with you.
We put a TPM, but he came back to normal sinus
Yeah.
rhythm with one-to-one conduction. So here it is not pacing.
What are the possibilities? आपने सारी की सारी ECGs देखी हैं, तो यहाँ अब क्या दिमाग में घूम रहा है? You are in the CCU, he's still there.
He is still there after 3 weeks.
Well, myocarditis तो चलो होगा, इधर क्या हो रहा है? हम तो ECG की बात कर रहे हैं सिर्फ. Are you worried about this ECG? Should you be concerned? Should you call for something? या किधर bundle branch block? What is happening to the amplitude of the ECG? So why would you have low voltage ECG? Pericardial effusion is 1. Post MI, post stenting, can you expect pericardial effusion sudden? क्यों? ड्रेसलर सिंड्रोम जो है 4 से 6 हफ्ते के बाद होता है. ये अभी दाखिल है. आपने स्टेंट डाला है, फाड़ सकते हैं आर्टरी को? नहीं, डिसेक्शन नहीं. आप पर्फ करके, और क्या रीजंस हो सकते हैं पेरिकार्डियल इफ्यूजन के? हेपरिन दे रहे हैं आप, यू कैन ब्लीड इनटू द आउटसाइड. ठीक है ना? पेरिकार्डाइटिस के बीच में वोल्टेज लॉस होना चाहिए. मायोकार्डाइटिस, wherever you're losing muscle electrical activity, you will drop your amplitude. और या आप एम्पलीट्यूड करेंगे क्योंकि बिटवीन द रिकॉर्डिंग इलेक्ट्रोड्स एंड वो मेरा टाइम खत्म हो गया. रिकॉर्डिंग इलेक्ट्रोड्स यू कैन हैव इश्यूज. सो नेक्स्ट प्लीज. सो वी गॉट एन echo done. There was trace pericardial fusion. So what happened to this gentleman? Next. That's it. So possibly, so not possibly, this guy had myocarditis. He had an incidental right which was parked and maybe had a problem which was fixed, but he didn't fix anything because the myocardial changes kept on going, and then it evolved very nicely into a low voltage ECG not because of pericardial effusion. We got the echoes done, and that is what you should be doing, because you are also giving heparin, and pericarditis can bleed into the pericardium. But he was losing muscle. So this is kind of a bad kind of myocarditis. So that is why the voltage is being lost. See, it's really minuscule now. चले with this. Echo के ऊपर global LV dysfunction हो गया था, and it has gone down to 20%. हाँ, but RCA was sorry. MRI, yeah. वो अभी नहीं उसका हुआ.
वो नहीं हुआ इसलिए कि he was in bad condition, hemodynamically unstable. He had renal disease.
या हाँ नहीं वो बिल्कुल वो आपका बिल्कुल सही पॉइंट है कि आई थिंक इट स्टार्टेड विद probably the myocarditis triggered a plaque rupture, and that caused a right coronary infarction. They did fix it, but it kept on increasing, and you till very late you maintained that ST depression, reciprocal ST depressions, and then overall you lost myocardium and you lost amplitude. Spasm हो सकता है, लेकिन वो बड़ी discrete, उसकी left side पे भी disease थी, but non-obstructive. चले, thank you very much. It was really nice being part of this.
Thank you. With this, we come to the end of today's session. But before the session ends, we'd like to give a shield to Dr. Intisar.
Thank you, Inti.
I would like to call Dr.
Very
Azam,
nice.
for the shield presentation. Sir?
मैं उसकी बता मुझे जाना होगा राउंड करने, नहीं तो मैं इसके
Intisar. Surprise. Surprise. It's going to be a 15 minutes tea break before the next session ends. Thank you.
डेली आप लेकिन सिर्फ ओपीडी अभी फिलहाल हाँ आप अपने पेशेंट्स लेके जाते होंगे फिर अगर आपको कुछ अपडेट करना हो कुछ इंटरवेंशन लेकिन फिर वो चीज़ें ना थोड़ी लॉजिस्टिक्स सही है अब कितनों को
Bring your teas to the table now. We are going to start the session now. The next session is going to be on the analysis of CRM and device tracing. This session is going to be coordinated by Dr. Liaquat Zaman, Dr. Azam Shafqat, and Dr. Zubair Mumtaz.
Thank you, Dr. Mohit, and Assalamu alaikum, everybody. So I am Dr. Zubair Mumtaz, and today I will be discussing some interesting traces. So now to start with, a patient with a paroxysmal complete AV block was implanted a dual chamber pacemaker. So at follow-up, the real-time EGM strip was recorded. So it's a simple one for PGs, for the fellows. So in what pacing mode is the device being programmed? So it's a simple one. We know we have few modes, single chamber, dual chamber, and whenever we see a sense or a pace, it means it's a dual chamber pacemaker. But we have different modes in it. So which mode is it? Any of the EP fellow? Okay, sure.
AV interval is variable. On the other end, paced A's are being tracked. So this is DDI pacemaker.
Okay, very good. So the catch here is, so look at the pacing intervals.
DDI.
Okay. So now,
What if this is DD pacing and somebody put the upper rate at this by mistake? Let's say, for example, no. Let me explain to you. This is 996, 995, whatever, and there is a progressive prolongation of the AV interval. Okay, you can see that this 387. No. Hold on. Pacemaker Wenkebach is a phenomenon which we described long time ago from University of Miami. What it looks like is that if it has to maintain the same rate, what it will do is, because it has to maintain the rate, so gradually the AV interval will prolong. Ultimately, one AV interval will come in the refractory period, so it will not be sensed, drop, then it will start again. So it looks like that, but it could be DDI also. So those are two things. Yeah.
So sir, I think it's if the VV is fixed, like V pacing is fixed here, no? If you are talking about AV, the Wenkebach, pacemaker Wenkebach phenomena, that will be irregular.
I think
this is a regular rhythm.
Dr. Zaman is talking about any algorithm like search AV interval. Search AV interval.
No. He's talking about upper rate behavior. Upper
rate behavior.
But it's 1000 millisecond. No?
Well, but look, we can't argue this, but the point is, I discussed this also with some expert.
Okay.
I tell you that it could be that as well, but because you will be surprised to see that if you follow a patient in your clinic and if patient comes from outside, one of the first things you want to see is how it is programmed, because you can see all kind of stuff. So upper rate behavior will keep the upper rate.
Okay, it could be one of the differentials.
Yeah.
Yeah.
But the other good one is that DDI pacemaker.
DDI pacemaker. Yeah. So if you look at closely here, so there is A pace, V pace, which is abbreviated. Then again, there is a sense V pace, but the AV intervals are changing beat to beat. Then there is a atrial event, which is being sensed in P-warp. So that's why it was labeled as AR. It means it has been sensed in P-warp refractory period. Right. So again, the A pace, V pace with the same abbreviated, then A sense, V pace, A sense, V pace, and then again there is an event which has been sensed in the P-warp. So as the question is, which is the pacing mode? So basically it's a non-tracking mode. So there are a few tracking modes, we will talk about it later on. So this is DDI mode, which is one of the non-tracking modes.
Right, good.
So now for
Can you bring that just quickly back? Just right. I was just looking, you know, where there is AP. Look at the electrograms, which are sense electrograms.
Yes,
okay,
paste.
look there, yeah.
It's a
so
paste
why
one.
is it that we don't see any electrogram there? Just little digil there, yeah.
Because of automatic sensitivity algorithm in the devices. It adjusts the sensitivity of the EGMs accordingly. So whenever there is a pace, so it adjusts the sensitivity of the atrial to a shorter one.
For the paste, yeah.
For the paste one.
No, I saw that. It's
Yeah.
right there.
Yeah.
But there is no electrogram, no captured electrogram.
हाँ, लेकिन सर थोड़ा सा
That automatic thing, sensitivity.
Automatic, yes. Now,
decremental.
Yes.
Okay, usually that is for the ventricle. Because, and usually it is for, okay, you know, typically the people, the St. Jude people use that quite often, the auto adjustment, similar like it is for the VFib thing. But I don't know, you know, I have not seen this, that's what I'm saying.
Yes.
No, marker will show you only AP.
Sir, I'm talking about the pattern of the EGM that suggests that this is a St. Jude device.
Oh, okay, yeah. So St. Jude does that auto sensitivity stuff here.
But that's on the V.
Yeah.
What is on the A?
Yeah. So why is it that on the A we see this little dot, but there is nothing else? I'm just saying, you know, I'm just. Yeah. Anyway, you can go ahead, but that, you know, I was amazed with that why the hell.
So one of the explanation could be because it's pacing and sensing from the same bipole.
Okay.
So it could be when there is a pacing. So
you know, we have those. I could show you that. If you have that, you see the electrogram. That's how you see the capture.
Yes.
Capture, and then you don't see the electrogram. The other thing is, one thing to teach the fellows, which is very important, is that, you know, like when we do the ablation or mapping, ECG is the most important thing. Okay, that's like the setup of golf, that you set yourself and then execute. ECG is very important, and particularly those who are not familiar with conduction system pacing, that is how we measure the threshold. Let's say this becomes from non-selective to selective, or right bundle correction, left bundle. ECG is important. This thing will tell you that it paced, but it doesn't tell you whether it captured or not.
Yes.
Yeah. So you have to look at EKG.
So now this slide is for the beginners. As we see, there are algorithms or abbreviations like VVI, triple D, or DDI. So what does this VVI, triple D, and how can you understand what the pacemaker is going to do, or what's the actual programming means? So the first letter shows the chamber being paced. So in VVI, the first V shows the ventricle is being paced. And in DDD, the first D shows means both A and V are going to be paced.
When you say D, first D is, okay, I call it PSR. That's my synonym. Paced sense response. So when you say D, first D, that means atrium and ventricle both are paced.
Yes.
And when you say second D, that means ventricle and atrium are both sensed. And when you say the I, that means it's only inhibited, not triggered like
not triggered.
The previous one.
Yes. So basically this is the revised one. So in 2001 it was being revised, and the fifth V is the multi-site pacing which was being added. And then the second letter shows the chamber being sensed. Like in VVI, the second V shows which chamber is going to be one of the sensing. So in VV, the first V shows ventricle being paced, second V shows ventricle are being sensed. So in triple D, both A and V will be sensed. So then the third one is what will be the response to the sensing. So either it should be inhibited or triggered. So the D means the device will either inhibit or trigger. So it can do both the functions. And the O means, 0 means it will do nothing. So like similarly in O here, it means it will only pace, no sensing, no response to sense. And the fourth one is the rate modulation. So basically, no, I haven't seen. OVO we have seen.
No.
Triple O we haven't seen.
No no pacing, no sensing, no response. Is there any pacemaker?
I don't think
I will
so.
just enhance your knowledge. The Micra leadless pacemaker has that capability.
Okay.
I've done a bunch of Micras, so that has that thing. But other regular ones don't have that.
Okay, fine. And the fourth letter shows whether there will be a rate modulation or not. So the rate modulation means the device is going to increase the rate of that chamber through pacing, through special sensors. And the fifth letter shows the multi-site pacing. Either it's in the atrium, means multi-site pacing in a single chamber, or multi-site pacing in 2 chambers. So D means there is a multi-site pacing in both A and V means there is a multi-site pacing in V only. So now dual chamber pacemaker, there are some tracking and non-tracking modes. So tracking means there will be a P-synchronous pacing, it will be more closer to the normal physiological rhythm of the patients. So the triple D and VDD are the tracking modes. And in the non-tracking modes, we have DDI, VDI, and DVI modes. So in these 3 modes, the device is not going to track the P waves. So now we have another interesting case. A 74-year-old patient with ischemic heart disease had a single chamber ICD implanted 3 years ago for a resuscitated VF. He was admitted after having received multiple shocks. The tachogram is shown and the EGM strip is also shown just before the shock is being delivered. So this is the tacho. So any of the fellows? So for the beginners and the PGs, basically the tachogram is a plot interval in which the ventricle activity here is shown as a dot. So it means it's a single chamber device, and the settings are written here. So the VF is 330 milliseconds, fast VT 250, and VTS 400 milliseconds. So basically this is milliseconds, not the beats per minute. So here we can see, and we know the smaller the number, the faster is the heart rate. So this is the 200 milliseconds, the first line, the VF, fast VT, and the VT zone. So 2 lines showing the 3 zones here. So now you have to see the activity, where the activity is the most.
There is a lot of ventricular activity, and mostly the tachogram shows that the VV interval is less than 200 milliseconds. So it seems like, for example, if you would really have a ventricular tachycardia or something, it would not show a lot of activity like this. It seems like there is some sort of oversensing going on.
Basically, it's a scattered one.
Yeah,
No,
and
scattered
this is
one.
scattered.
Yes.
This is scattered, so this might be T-wave oversensing or maybe a lead fracture or something, because there is a lot of activity.
So in T-wave, oh, okay, sir.
Now, one question. I think if you, just a hint, just a little hint, what do you think the VV intervals are spread out over a wide range? But majority of them are following at a range. What are those? The down below that big line. What do you think is the timing interval? There's less than 200, right? So it's maybe 140, 130, 110. He may show you that. So what will make you think of that when things are coming?
That means that maybe there is some noise or oversensing.
Okay, well, yeah.
That may be noise or oversensing because the VV interval is very short.
It is oversensing, definitely. But what is it oversensing? What kind of things when they come very, very early?
I mean, what are the differentials?
Is it physiologic?
This is non-physiologic. Yeah. This.
So here we can appreciate the tachogram is scattered one, but there is a lot of activity in the VF zone. And you can appreciate the shocks here. So 29.5 joules, 30, 30, again we have 30, like 4 or 5 shocks again. So after the shocks, so still we have the tacho which is scattered one. So it means the activity which was present and which was detected was still there after the shocks. Now it will give you a clear picture. Now again for the beginners, so this is...
Anybody who is non-EP or people who are not familiar with this, so if you look at it, the first lead over there, it says P sets. That's the pace sensed electrode. And where it says HVA, HVB, what's HVA and what is HVB? High voltage A and high voltage B. So this is between the two ventricular coils, between the two coils. It's recording an ECG between here and here. So if you look at the EGM, which is the pace sense क्या होता है कि दो electrodes होते हैं, जैसे आपकी ECG, आपने जैसे TPM का वायर रखा हुआ है, TPM के वायर के दो electrodes होते हैं ना, so they are close to each other, and the depolarization wave travels from one to the other. तो आपको एक उसमें इलेक्ट्रोग्राम नजर आएगा. अब चाहे वो एट्रियम में हो, उसमें भी इसी तरह का एक इलेक्ट्रोग्राम नजर आएगा, वेंट्रिकल में हो तो उसमें भी वैसा ही इलेक्ट्रोग्राम नजर आएगा. तो उसकी कोई शेप पे की कोई स्पेसिफिकेशन ऐसी होती नहीं है. तो वो जो है आपको इट विल लुक समथिंग like this one over here, जो I'm sorry मेरे पास it will look like something like this. This looks like a typical electrogram जो हम देखते हैं. ठीक है. अब why do you need an HVA and HVB? हम ECG कैसे रिकॉर्ड करते हैं? हम एक इधर रखते हैं, एक इधर रखते हैं. हम दूर से देख रहे होते हैं. जब हम दूर से देख रहे होते हैं तो वी कैन अप्रिशिएट के पी वेव की मॉर्फोलॉजी इस तरह की है, QRS की मॉर्फोलॉजी इस तरह की है. जब हम पेस सेंस से देख रहे होते हैं वो सब मॉर्फोलॉजी एक ही लगती है, क्योंकि हम सिर्फ इतने करीब से मायोकार्डियम को देख रहे होते हैं. इट इज़ लाइक लुकिंग एट लॉट्स ऑफ ट्रीज. आप बिल्कुल करीब के उसके ट्रंक पे जाके देखेंगे, आपको कहेंगे हाँ कुछ यहाँ है, मगर आपको ये नहीं पता लगेगा कि ये नीम का दरख्त है या ये बादाम का दरख्त है. आप थोड़ा पीछे हट के देखेंगे, देन यू कैन सी द बिग पिक्चर एंड यू कैन से हाँ भाई ये है. इसी तरह जो HVA HVB है ये दूर से आप देख रहे हैं. सो दिस इज लुकिंग एट इट फ्रॉम अ डिफरेंट इलेक्ट्रोड्स एंड दैट इज लुकिंग एट इट फ्रॉम अ डिफरेंट इलेक्ट्रोड. And now Zubair is going to tell you, or somebody can tell what the diagnosis is based now that you have two electrons. The pacemaker makes all its, or ICD makes all its decisions based on the pace sense electrogram, right? This is more to help it finalize more about it. मगर जो कहता है कि भाई है कि नहीं है electrode, वो उसको देख के कर रहा है.
Since he has given me the appointment as a honorary faculty of NICVD, so it's my duty to enhance your level to, mashallah, you are very smart. I'm very impressed. So we have to enhance your things to that upper level. So one of the things is that shock electrogram, we call it, okay? The HVA and HVAB. As Adam said, that is looking from far place, we have a global view. When we start doing here, SCAR VTs, and I will come here and do that, I'll play my golf and do the SCAR VT. One of the things we rely on the EKG. The other thing is the QRS morphology from the ICD, and we look at the shock electrogram. So you will need to tell your staff that please also put the shock electrogram whenever there is arrhythmia, because that gives you the morphology. So the other thing is, just a comment on the event which is happening, that 130, 140, 150, for that event which happens, you will tell us the diagnosis, but for that kind of thing, one of the things which is very crucial is to have a remote monitoring. And we are going to share with you, because the patient could be in Sakhar or somewhere else, or not even in the town, but we should be able to see from remote place what is going on and take action. So you will tell us.
Yes, so very well explained. So we see in the pace sense EGM, and we have a near field and a far field one. So in a near field, you can coincide with this. So these are the real activities. And in between these two activities, there is a lot of non-physiological activity. So interestingly, there is activity in only one channel, not in the both near and far field. So this excludes the EMI. So EMI is one of the close differential. So to exclude this, it means there should be activity in both the channels.
Okay.
So again, the device senses it as a Fib sense, fast VT, VT, and there is intermittent undersensing of the these noises also, and then there is a charge, and then a shock was delivered. And interestingly, after the shock has been delivered, so because there is some fault or something, a problem in the lead, so this noise continues.
How
so this
did
noise
patient
continues.
do after this? Did he continue to have these things, or it was just one-time event?
No, the patient received 5 or 6 shocks.
Eh?
5 or 6 shocks
Yeah.
due to this.
Okay. Okay. What thing, I don't know the patient, but I told you that thing, I guess you are thinking what I'm talking about. The thing for which the industry has promoted some safety features and some monitoring things, okay? If I looked at it, I will be thinking of that thing.
Okay.
Unless if I see that the patient has a hand in the plug or something, he was doing something. The other thing is that it is specifically to the pace sense lead.
Pace sense.
If you have the EMI, that should also affect even the other one.
On the other.
Particularly that is more superficial.
Yes.
So did this patient not have that thing which I'm talking about? Again, I'm not naming that.
No, if you're
And this
talking
is
about...
Medtronic pace ICD,
This
right?
is a Medtronic lead
Yeah.
which has a recall.
Yeah.
So basically this is a Fidelis lead.
Yeah. Yeah.
So it has got the
Yeah.
recall.
So did this patient have that thing or he did not have that thing? What
This
was
is the Fidelis lead.
impedances?
Fidelis lead.
No, what was the impedance?
Well,
okay, let's...
The impedance was not shown.
No, hold on. For the fellows. Okay, if a patient comes in and we suspect like a lead fracture, okay, and we look at his static lead increase at the time when the patient comes in there, in the office, okay, and I say that the lead increase at that given time is normal. I have not looked at the patient's other data when I say normal. If the impedance is normal at that time, does that rule out lead fracture? Yes or no?
No.
Yes or no?
No.
Okay. So what would we look at? Perfect. Because sometimes those fractures or stretches are so minor that when you look at global, then you will see little blips.
Trends.
There's so many trends going on.
Okay. So question. Yes, sir? Okay. So the question for the fellows. So what does this show? Charge and charge lever. So is it a first shock? So can anyone predict, is it a first shock, is it a third one?
This
Is a
not
first or second
shock,
shock?
This is mandatory shock.
So basically this is not the first shock because it is committed one. So in this, the device just charged the capacitors and delivered the shock. So there is no confirmation. Okay, so this is the second or third or anyone, but not the first one. So after the shock, the activity continues. So this shows this is a problem in the patient's lead. So basically this was the Fidelis lead which has a recall. So these are the differentials. So one of the closer differential is EMI which has been ruled out and the lead fracture is there.
It is a good differential. Well, what was the actual stuff in this guy?
I guess another question would be, is there a way of preventing something like this? How could you, can a device not shock for this? Are there ways of the device detects this or alerts the patient? Yeah, what I meant was what are the ways of, what are the different features for detecting, how does the lead detect possible noise? How does the device detect possible noise?
I think you are talking about noise reversion. Noise reversion algorithm is there. Yes.
So I think one of the things is just the duration of these, if there two or three things that sort of make the device think that this is not real. One is variations in the impedance, obviously it causes alerts. The other thing is that if the RR interval is so short that it cannot be physiological, there is no way that a ventricle can repolarize and repolarize and repolarize again in like 50 milliseconds. So it's no
then the answer to that is that obviously it will shock because the ICT is always there in a way that you have to help at the, you don't want to miss a real feature.
What device?
So actually they have not mentioned the IPG, so they have mentioned only the lead, which is the Fidelis.
You don't know what the device is.
Regarding the IP,
the shocks and not alerted or go into the noise reversion mode.
it's an older device.
So the newer devices, as Dr. Azam was saying, will give you go into the noise reversion mode or give you an alert. It will not keep shocking on.
No, no.
This must be an older device who's done this. So the newer device have the fail-safe mechanism.
And they have lead integrity mechanism also.
No,
Yes.
They give you warning.
Yes,
no,
absolutely.
excuse me. I dealt with this stuff since Prince Fidelis came and the lead fractures came. It is there since the time, unless this is 20 years old ICD. You know, you need to go back. They all have that. The FDA put it for them mandatory that they have to put that alert. It's how you look at it, whether you looked at it
So
or
it
not.
must be an older trace.
I don't think so. Do you have the ICD interrogation, not the electrogram? It will come when you interrogate. I told you it will come down, bottom, left side. Because what you have is electrogram. That won't tell you that. When you interrogate, there will be triangle, eye, alert. It will say multiple, whatever, 1,000 something. It will give you number. I'll send you that. I'll send you that stuff.
Sir, newer devices, we all looked at it. So this must be an older device, no?
No,
So
because,
it's an older device.
you know, again, we don't want to go into arguments. What you showed us is the electrogram.
Electrogram.
What you need to show us the initial interrogation, that's where it will show you.
Okay.
Yeah.
So another tracing, a patient was implanted a dual chamber pacemaker for intermittent AV block. So ECG was recorded at follow-up and is shown. And the patient was asymptomatic. So the device settings were mode is triple D, 60, 120, and the atrial and ventricular outputs at 2.5, paced AV is 200, sense AV is 180, atrial sensitivity 0.5, and ventricular is 2.5. So now the question is, we have to explain the variable AV intervals.
Explain the AV intervals difference and also explain if there is any problem in sensing somewhere.
Sensing, or if there is any abnormality.
The first beat is A sense V pace, second is A sense V pace, and in third there is A pace, V pace. Fourth beat there is atrial undersensing, so there is A pace. The QRS falls in the crosstalk window, and there is a safety pace. The safety pacing duration is around 110 millisecond. And then there is a sinus beat, and then again safety pace. Due to
Very good. So as it has been shown, so we have sensed AV, paced AV. So these are the different one. But interestingly, we have here is another paced AV interval. So this paced AV interval is shorter than we have shown before. So basically, there is atrial undersensing. As a result, there is atrial pacing. And at the same time, the ventricular channels sense there is an activity, and as a result, the device give another spike for the ventricle. So this is basically the ventricular safety pacing. And the intention is to avoid the crosstalk from the A pace. So here, we can appreciate it easily. So this ventricular safety pacing works only when there is a A pace. Whenever there is an atrial pacing, there is atrial blanking followed by a crosstalk window which initiates. And if any of the activity is sensed within 110 milliseconds, then the device will give a safety pacing at 110 milliseconds. So this is intended to avoid the asystole. Because there is a possibility the ventricular channel has sensed this atrial spike. So this is to avoid the asystole and save the patients from asystole. So very good description. So now we have a patient presented in OPD after ICD shock, and the device settings are shown. VT is 330 milliseconds, VF 240, and SVT to VT limit is 260 milliseconds. So we have seen these patients a few weeks back. So this is the tachogram. So anyone?
It's a tachogram showing two zones, the VFib zone and a VT zone. The initial V's are in the VFib zone, and then there is a burst ATP given.
So only the V's are in the VFib zone, or
VT zone.
VF or VT zone?
VT
or
zone.
both the V and A are in the same zone?
Are in the same zone, yes.
No, you
Initially, both V and A's are in the same zone,
Okay.
initial half, and then only the V's are in the VT zone,
Then?
and A's are in the sinus. ऊपर है वो, हाँ थोड़े ऊपर है ना, हाँ. That's after the burst.
No, even before the burst.
Then you cannot appreciate the atrial activity both here and here also. It means device was unable to see the A.
It was unable to see the A's.
So initially the device was able to see. So what you can see or you can observe in VTs are, you observe the ventricular channel, ventricular activity here, and the atrial activity some here is around 1000. क्योंकि साइनस तो अपना चलता रहेगा, उसको कोई प्रॉब्लम नहीं है कि नीचे वेंट्रिकल में वीटी है या नहीं है. तो हमें सिर्फ वेंट्रिकुलर एक्टिविटी फास्ट नजर आती है, नॉट द एट्रियल एक्टिविटी. बट हेयर बोथ आर इन द सेम जोन. So it means some sort of a 1-to-1 tachycardia is going on. Either it's SVT or VT 1-to-1, and then later on only the V's, and you can appreciate only A here, single A, and then only the V's can be appreciated here, and no atrial activity is there. So later on you can appreciate there is a detection burst, there is a burst of 8 beats, and then you have atrial activity, ventricular activity, and then everything is out of the zone.
What's the differential for that 1-to-1 with the other? So क्या differential होगा?
वो वैसे मुश्किल हो जाएगा बताना, because you're not seeing the initiation.
Sir, EGM से
नहीं, EGM से ज़्यादा भी इसमें.
I will show you EGM.
इसमें जो आपका ये है, because the tachycardia is already there.
Yes.
We are not seeing the initiation.
Initiation नहीं है इसमें.
If you see the initiation, then you can see what is leading, and that could guide probably.
That's correct. You know, that's very, very nice, because you will see what triggers it. Is it A which triggered, and it starts with VA. Otherwise, when it comes 1-to-1 here, we don't know, it could be anything. So, yeah. Unless we see some response to pacing from that burst.
So here's the EGM.
Yeah.
So on the top there is atrial, ventricular, near field, and there is a line. Above the line there is the atrial activity, below the line is the ventricular activity.
Why are you saying that?
Stability है.
So what are the possibilities? What are the possibilities? You have
Initially, there is 1-to-1 VA conduction or AV conduction. So it is in the tachy zone, and the device is labeling as it's sensing it as a tachycardia, and now it will try to apply the discriminators as well. Since was there any SVT-VT limit given?
260.
260. So it will apply the discriminators at this tachycardia zone.
So what about the tachycardia?
The question Dr. Azam asked you is very simple. That when you look at this, look at it like an ECG. If it was a ventricular tachycardia with 1-to-1 VA conduction, where would the A land? If it was an AV and RT, where would the A land? So the same ECG principles would apply in the EGM also. Forget about what the machine is going to do. It's going to do it later on.
So they are almost the same time. So yeah, they are almost on the same time, so it's less likely to be a ventricular tachycardia, because in ventricular tachycardia there is going to be a retrograde atrial activation, so there is going to be difference between the V and A. So here it's almost a parallel activation of atria and the ventricle.
So the differential will be then?
It can be a JT, it can be a typical AV.
Very good. Okay.
So now this shows it most likely this is an
or an atrial tachycardia with a prolonged PR interval.
Prolonged PR.
Very nice.
But if it were with this longer PR interval, it would start venti barking over here, which is not good.
Say that again, Amir, I couldn't hear.
So if your PR interval, because right on top of the QRS nearly, if it were first degree AV block, the tachycardia is very fast. You would expect a Wenckebach over here. It's not. It's going one to one.
Maybe the patient is very young.
Maybe it's a dual tachycardia.
Less likely.
With a very good
Less
AV
likely.
node.
Depends if the patient is anxious.
Possibly.
That's autonomic tones, yeah.
Yeah, less likely, but yeah.
So this is what we recorded later on.
Okay. Okay.
So the tachycardia continued.
Okay.
But
so
what about the
tachycardia is
marker
still
channels?
continuing, and if we look at the atrial EGM, there is atrial activity, but when we look at the marker channels, it is not being sensed over there. Now the device, there are more V's than A. The device applies the wavelet WV. It's saying that the morphology is matching the sinus rhythm, but ultimately, since there are more V's than A, the device label is as a VT, and it gives the first therapy, which is burst.
No, is the morphology matching sinus or is matching the, because it also will depend upon when you see next time or programming that what is your criteria, what is your cutoff for matching. Did you put 70%, did you 90,
70%.
whatever. But the fact that it called it VT, it means it did not match for the given criteria.
But it's a wavelet.
Annotation is wavelet
So
matching.
usually when you program
Yeah.
wavelet,
Yeah.
it's the morphology match.
Yes, so that's what I'm talking about.
And then, but it gives you have to set the criteria for the device to see that whether it's 2 out of 3, 4
Yes.
out of 3.
No, that's exactly I said that. I
But-
said, no, hold on a minute, okay? Usually it is like 5 out of 8 or something like that. So I know about that stuff. Then the percentage match, you set it. You know, it's not that it will be always this, whatever you set it. You can make it like I tell people, 3D mapping, you can make a color look like any garbage. So you will see that when you go next, because I studied, I stayed until 2 a.m. I studied this. I opened the Alan Bogan and the Wilcoff book. So you go to next, it will tell you the story.
Just a couple
Yeah.
of things. I think you spent all that interesting
So actually, it has applied the wavelet, but then the rate is too high. When the rate is too high, it just refutes it, even if it matches.
No. So what I think.
Can you just pass it?
So what I think, it has applied the wavelet, and the device is saying that this wavelet is matching the native QRS. But since there are more V's than A, the device has detected it as a VT, and it has given the first therapy of the VT.
Just to one point, the device initially recognized as sinus tachycardia because the sinus onset, this is a Medtronic device, so the onset feature is on, and there was a 1-to-1 conduction, but then उसके बाद under sensing हुई और उसके बाद वो dissociate हो गया, then it applies the wavelet. Now there is a function of high rate timeout in Medtronic devices. So I think the high rate timeout is on, and the device has now declared as VT and started the therapy.
Is it
डॉक्टर आजम इसमें एक मैं पॉइंट कर दूं वो सी वी आर रीडिंग द डिवाइस यार एक मिनट पीछे जाना प्लीज सो इफ यू लुक नहीं वो अगला वाला ही इसमें यू रीडिंग द इंट्राकार्डियक्स ना अब उसने तो अपना काम कर दिया अब आपके पास आ गया है नाउ यू हैव टू इंटेलेक्चुअली लुक एट दिस डिवाइस लुक एट द पेसिंग and you have to see what the pacing is doing. You basically, this ventricular pacing can either entrain, overdrive, and you can see the response. You can see at the initiation what the ventricular pacing has done to the atrial cycle length. And from there you can have a differential.
Exactly, Dr. Amir, you are exactly right. There are two aspects of this tracing. One, what is the tachycardia? explanation what is going on. The other side of this tracing, what the device is doing and understanding, and why the device is shocking as VT. So there are two aspects which needs to be explained.
So I guess now remind me, I thought the algorithm, some of the मुझे पुराने algorithms जो याद हैं उसमें यह है कि once you have VA dissociation, it does not look at anything else at all. So
yes, absolutely, you're right, absolutely.
इसमें तो इस हिसाब से तो VA dissociation यहाँ पीछे हो चुका है, और उस हिसाब से अब इसको कहना है कि भाई मैं ये तो VT है, चाहे इसका wavelet match करे, चाहे sinus onset match करे या ना करे. And this is exactly what we do, right? If I see an ECG with more V's than A's, I will say कि यार ये तो VT है और कुछ नहीं हो सकता. अब what Zubair has shown us is that even though the device is saying there is no A, why is there no A? Why is the device not sensing any A? Because the A is now falling exactly at the same time as V, and therefore it's far field. वो कहता है कि यार ये far field over sensing को prevent करने के लिए वो atrial post ventricular atrial blanking period के अंदर वो fall करेगी.
No, so it could be a possibility, but if we can say it's in the blanking, so the device is, so the device is mentioning here is the blanking, because the newer devices show whether there is activity in the blanking also is there or not. So there is activity in the blanking and it has been labeled here.
ये पुरानी डिवाइस है जो कि ब्लैंकिंग में ले रही है, अभी उसमें भी वो रीड करेगी.
So it has read in the blanking.
डिवाइस बिल्कुल रीड करेगी.
मेरे ख्याल में वो ब्लैंकिंग में भी नहीं कर रही, डिवाइस उसको देख ही नहीं सक रही, क्योंकि अगर तो वो ब्लैंकिंग में गिरता तो डिवाइस would have labeled it as AV.
Over here it's calling it A blank.
A blank. A blank.
It's one of those it's falling in the, but it's not falling. This one did not fall in the absolute blanking. This one fell just outside the absolute blanking. जो absolute blanking में उसको वो फिर नहीं पढ़ पाती है.
Okay.
अच्छा इसका ये देखिए ना, ये जो भी हुआ secondary to the pacing, उसको पढ़ो ना.
That's the next part of it. So
Yes.
I guess.
So when there is an ATP at the rate of 270, you can see the atrial rate was also accelerated to the 270, and later on the tachycardia was terminated.
And there is a VAAV response.
No, but the tachycardia was terminated.
And the tachycardia terminated.
Terminated.
Terminate with an A.
Terminates with it.
Termination. Retrograde, then retrograde, termination.
Yes. So what now? Sorry?
So based on this, can we rule out VT?
I don't think so. It's VT. It's not VT.
No,
It's all due to atrial undersensing.
Based on this, can we rule out tachycardia, SVT?
Yeah.
Which SVT can we rule out?
So it looks like AV and RT, because if we look at during ventricular pacing, we can see that it fastens the atria, and in almost about the fourth beat, it starts resetting the atrial rate. So it's like there is progressive fusion, and it resets the atria after 3 to 4 beats. So it looks like it's an AV.
So मतलब है कि it's unlikely to be atrial tachycardia because it would not have terminated with this. So unlikely. हो सकता है terminate, but unlikely. It's also unlikely to be AVRT with such a short VA interval.
Yes.
ठीक है, ये दो चीजें थोड़ा unlikely हो जाती हैं. क्या ये VT हो सकता है? बिल्कुल VT हो सकता है, क्योंकि उसमें बहुत ही तेजी से ऊपर गया. मगर VT में भी इतना short VA interval बड़ा unusual सी बात होगी. बहुत unusual सी बात होगी.
Yes.
अगर VT हो तो retrograde है. Okay, Zubair, अब असलियत बताइए आगे आप.
Next slide, because that has next month, because this is just showing. Okay, now look in the match.
So there is 85, 79.
Sinus tech wavelet. Yes.
I was telling you this stuff because I looked at this goddamn thing until 2 a.m. and read the Aaron Goebel's book. So So it did the match also.
Okay.
So just one point.
Yes, sir. So here it shows the wavelet not applied, V rate greater than A. Yes.
Sorry.
So, but later on.
By the way,
but later on this has been written wavelet not applied.
ये स्टेबल ने हॉग कर ली हैं तो क्योंकि वो इस वजह से इन्होंने हॉग किया है कि इन्होंने कहा कि अगर बोल दो इस वक्त सभी बहस कर रहे हैं बीच में हमारे भी निकल जाएगा, nobody is going to pick on us. So use the same tactics, say some garbage and use the word blanking, p-warp, इस तरह के 2-3 चीजें हर चीज में डाल देना, because then it becomes सब सोचने में मगन हो जाते हैं. Okay, so go ahead. So Zubair, you want?
Yes. So this patient presented to us with ICD shock, and so we came out that this patient has inappropriate shock due to SVT, and this was inappropriate because of the undersensing of the A. And the reason of undersensing, we were unable to figure out why there is undersensing intermittently, but later on when there is a ATP, there is appropriate sensing is there. So this was inappropriate shock to resulted in appropriate shock to this patient. But later on the numbers, the atrial sensing were very good. It is more than 2. And
it's only your marker channel that is not picking up, your EGM is picking up a good electrophysiology.
yes.
So that is surprising.
The problem is, yes, with the marker channel. So the patient ends up with a shock. Problem is this.
तो आई थिंक वही आपकी बात जैसे हम बात कर रहे थे कि वो ब्लैंकिंग में probably absolute blanking में गिर जाता है every now and then, and that's we probably would that explain it, Zubair, you think, or
so we were unable to figure out this.
नहीं सर, वो उसमें फिर वो मार्क करती है AB. If you look at the first atrial marker annotation, this is AB. So I haven't figured out what it is doing, but just one quick point that I want to make over here. Initially in the tracing and the tachogram, you see 1-to-1, and it is marked as sinus tachycardia because onset is on. So there is a very specific function of the Medtronic ICDs. So if the onset has set that this is a sinus tachycardia, so the other things will not apply. The other discriminators will not apply. They only apply when the atrial undersensing starts. If you see on the next slide, so when it is dissociated, then the wavelet is applied and the device start treating the patient. So onset and stability in the Medtronic devices, if they applied, they withhold all the discrimination and the shock because they applied first in a chronological order.
Okay. So what is my take from this? The explanation जो Zubair ने दी, आपने दी, the machine looks at it like we look at it. First thing it will do is it will look at the rate and it will say कि भाई ये fast है, it looks like VT or VF or whatever is when it's falling. Then it will say कि भाई ये slowly शुरू हुआ है कि fast शुरू हुआ है. अगर वो आराम से शुरू हुआ है, आहिस्ता आहिस्ता, it looks like sinus tachycardia. Or if it's really irregular and it looks like AFib, which is stability, तो फिर वो वेवलेट को नहीं देखेगा. वेवलेट को वो उस पर देखेगा एज अ फाइनल क्राइटेरिया कि भाई अब ये VT के जोन VT ही लग रहा है, अच्छा मैं इसको फाइनली बिफोर आई डिसाइड ऑन थेरेपी डज इट लुक लाइक VT और नॉट लुक लाइक VT. सही कह रहा हूँ मकसूद में? एंड देन इट विल डू इट. तो व्हाट मकसूद इज सेइंग इज कि इट डिड नॉट लुक एट द वेवलेट बिकॉज अब तक तो वो साइनस टैकीकार्डिया की तरह चल रहा था. जब उसको नज़र नहीं आया कि साइनस टैकीकार्डिया, तो फिर उसने वेवलेट के तौर पे किया. तो एंड that's probably what it is. However, it should probably not have used any of those criteria once it didn't look at it, because it would have called it कि भाई ये तो wavelet V is greater than A है.
Surprising चीज इसमें ये है कि generally if it's let's say it's an AV and RD, it will start suddenly and then be a very massive jump in the rhythm rate. So the device will discreetly pick up the initiation. इसमें initiation pick नहीं किया, which could be that it has warmed up into this, or the patient went into an AV and RD or SVT while exercising. तो ये क्या कर रहा था?
अच्छा, इसका beginning tachogram का दिखाएंगे please Zubair.
सर इसमें initiation नहीं है.
He was just sitting.
Tachogram दिखाएंगे?
He was just sitting. Sitting, yes.
इसमें एक पॉसिबल एक्सप्लेनेशन ये हो सकती है कि मल्टीपल APCs कम विद AV कंडक्शन एंड देन AV and RT starts.
APCs, there are APCs.
नहीं, अभी I'm just making an assumption, but because we haven't seen because sinus tachycardia, the onset is applied, and onset is applied usually on the percentage-wise gradual onset.
Gradual onset.
Right? Yes, exactly.
The other time that you can, the device will have something like this कि भाई उसको gradual onset लगेगा, वो उस वक्त के जैसे आपने सेट किया हुआ है इसको 400 milliseconds पे हमने सेट किया हुआ है. अब जो टैकीकार्डिया शुरू हुआ वो 420 milliseconds का था या 430 milliseconds का था. अब वो जैसे जैसे वो बढ़ता गया, आपके एड्रेनर्जिक्स बढ़ती गए, आपका AV नोड और स्लिक होता गया या आपका टैकीकार्डिया थोड़ा सा और तेज हो गया, तो अब वो it has just now 430, 420 and now it's come in the zone. So क्या कहा यार ये तो बड़ा आहिस्ता आहिस्ता है, ये मुझे sinus tachycardia लगा. If it is something just at the border. So things, very nice tracing, very well done. तो बहुत अच्छी tracing थी, बहुत सारी चीज़ें सीखी. क्या चीज़ें सीखी इसमें मैंने, from what I learned was that it will apply, it generally looks at the sinus node and it will look at function. और वो कैसे recognize करता है कि sinus tachycardia? Because it will gradually increase. It will look at, it also looks at stability, which looks at कि भाई beat to beat variation कितनी है, and if the variation is great, then it will call it atrial fibrillation and it will not look at anything. If both those things it does not match those criteria, then it will say कि भाई this doesn't look like AFib or sinus tachycardia, हो सकता है VTO, हो सकता है SVTO. So then it will look at the wavelets. And wavelet में क्या है? इसने कहा कि wavelet तो बिल्कुल मैच कर रहा है, बिल्कुल उसी तरह के हैं जैसे कि sinus rhythm में. मगर उसके बावजूद it said कि look, all these things are there, but despite that, I am going to provide a therapy. Why? Because I don't want to take the risk. And it will do that in two cases. एक case तो ये है कि V's are greater than A. वो कहेगा भाई V's are greater than A, I don't believe anything anymore, I'm just going to go ahead with therapy. And the other time is कि even if the V's are not greater than A, एक उस पे SVT limit होता है. And we say कि भाई, you know, after 30 seconds or 20 seconds अगर tachycardia चल रहा है, अब, you know, we can't risk it. Just go ahead and treat it. इतना लंबा SVT होना नहीं चाहिए. Now,
एक साइनस जो हम जब डिवाइस को प्रोग्राम करते हैं तो उसमें जब भी टैकीकार्डिया 1-to-1 होगा तो उसमें 3 सेटिंग्स आती हैं. एक होता है साइनस टैक, AFL और एक 1-to-1 अदर्स, ये करके लिखा होता है. तो जब 1-to-1 टैकीकार्डिया जब भी होगा तो डिवाइस देखेगी कि R-to-R इंटरवल में वो जो एट्रियल इवेंट है वो कहाँ फॉल कर रहा है. तो अगर वो एट्रियल इवेंट बिल्कुल ऐसा फॉल करता है कि वो कहीं मिड ऑफ द R-to-R इंटरवल पे है तो इट विल लेबल इट एज साइनस टैकीकार्डिया. और अगर वो बिल्कुल बिल्कुल यानी कि QRS के फ़ौरन बाद या QRS के बिल्कुल पैरेलल एक्टिवेट होता है तो उसको लेबल करता है एज अ 1-to-1 अदर SVT.
So that's a very valid point. This is Sarim is talking about the algorithm known as PR logic. So PR logic इस device में मुझे नहीं लगता कि on है. इसके अंदर सिर्फ onset on है और wavelet on है. So
I would think कि someone is troubled by inappropriate shocks in this patient, because अब देखो इसका जो initial detection है वो 30/40 है, which is not a standard setting. Redetect is 12/16. तो किसी ने इसको खोला है इसकी detection interval को.
So जो अभी VF की जो अभी newer recommendations हैं for the Medtronic devices is 30/40.
अच्छा नहीं, sorry, ये VF है.
So VT नहीं. इसमें हमें देखो उसने लिख के भी दिया हुआ है डिवाइस ने कि इनिशियली उसने शॉक क्यों विदहेल्ड किया हुआ था. इनिशियली साइनस टैक के लिए विदहेल्ड किया हुआ था, उसके बाद वेवलेट के लिए विदहेल्ड किया, देन द हाई रेट टाइम आउट अप्लाइज एंड द डिवाइस स्टार्ट थेरेपिंग. सो और जो PR लॉजिक की जो सारिम बात कर रहे थे वो बिल्कुल सही बात है. PR लॉजिक अगर ऑन है तो वो आपको ऑन करना पड़ता है. अच्छा, तो उसके अंदर फिर वो तमाम चीज़ें अप्लाई होती हैं और डिवाइस फिर अपने इस तमाम तर उसमें बताती है कि उसने क्या क्या किया और क्या क्या देखा.
अच्छा, एक चीज़ और सालम, you were saying that rate at onset 72 beats per minute. What it is saying is that what was the patient's, so it also takes into account whether the patient was exercising or not. So what that is telling us is what was the sensor thinking at that time. तो वो सेंसर के हिसाब से इनका हार्ट रेट उस वक्त 72 होना चाहिए था. You see what I'm saying? So when we talk about VVIR, तो डिवाइस के अंदर R भी है. अब वो ये देख रहा है, वो कह रहा है कि भाई ये बंदा एक्सरसाइज तो नहीं कर रहा था कि जब इसका हार्ट रेट इतना तेज हो गया. Activity at that time. So its activity at rest जो है, at onset was such that it was resting activity थी और सेंसर का रेट जो था उसका 72 beats per minute होना चाहिए था. So not very fast activity. That's what I think, but I don't know if that's that. Yeah. So very nice, super one to that. जी?
करना है सारी इसकी जो अपना इनिशियल इंटेरोगेशन है या री-इंड्यूस्ड टैकीकार्डिया करके उसको अपना इसकी इंटेरमेंट करनी है, किस तरह से रूल आउट करेंगे जो फाइनल सेटिंग होगी इसकी.
नहीं सर, वो तो लेकिन अब्लेशन से पहले क्या करना है तो
So basically we made the AT lead more sensitive because one of the thought is the lead is under sensing. There is so, and then we have kept this patient for ablation also.
Yes, sir?
For ablation.
So what else could we do? I'm just wondering. I mean, I think it's a wonderful question, Shabad. क्या चीजें हम कर सकते हैं?
Atrial sensitivity वाली बात तो जैसे डॉक्टर जुबैर ने की, it is all right. Second ये कि I would off this onset function. And number third one, I would off the high rate timeout. Because the new recommendation all suggest high rate timeout to be off, stability to be off, onset to be off until or unless there is an indication of this. So this might avoid another appropriate.
मगर आप onset को off अगर कर देंगे, high rate timeout को आप अगर off कर देंगे, does that mean कि then it will apply it immediately? There will not be any high rate timeout, or it means
and
the other
the wavelet will apply and withhold the shock.
तो अगर हाई रेट टाइम आउट आप ऑन नहीं करेंगे तो वो उसको शुरू से ही उसको शॉक नहीं करेगा, उसको वीटी कॉल नहीं करेगा.
Inappropriate shock avoid कर लेंगे और then you start medications and try an EP study on that kind of patient and ablate it if it is an AV and RT.
He is on list.
For it get out.
Yeah. उस टाइम से पहले
एट्रियल एक्टिविटी नज़र न आने का एक तो यही है कि वो सेंसिंग जो है, पीछे उधर फरीहा को भी प्लीज़ भेज दीजिएगा माइक. तो वन ऑप्शन है इसके सेंसिंग को इम्प्रूव करें, लेकिन इस केस में आई डोंट थिंक सेंसिंग के इम्प्रूवमेंट, हाँ, क्योंकि इसके इतने बहुत अच्छी थी लेकिन नज़र नहीं आ रहा था.
This needs a second opinion.
So, can I just comment on one thing? This is a classic example where the device is not gonna, so device is gonna treat it because all the A's are falling in the blanking period. So this is actually an AV and RT where device is always gonna treat it as VT because it's gonna be outside the blanking period. So no matter what you do changing, you cannot go around this kind of problem where the V is falling right just underneath the A. And when you see the ATPs that the device delivers, there's progressive fusion before it terminates. So you cannot apply VAV, but you can actually look at stim A, VA time, and this is AV and RT. So this patient, instead of reprogramming the device, this patient should have an AV and RT ablation. The dot plot that you see is very classical of how a device will look, how an AV or an RT will looks like, because there is VA linking. In the dot plot, there is black dot followed by the open box. In a sinus tachycardia, it is the reverse. If I'm not sure if somebody can zoom this up. There is a black dot, which is the V, and then there is an open box. So black dot and then open box. So this is very classical of VA linking. And no matter what you do, it's not the device reprogramming that can change anything, because it's always falling right under the QRS, where it's not going to be seen. Okay.
So other things that we would not, so somebody like this, I would put in more aggressive ATP pacing, ताकि अगर tachycardia जो है वो terminate वो हमेशा हो जाए और वो वहाँ तक जाने की उसको नौबत ना आए.
AV and RT ablation, because the device.
AV and RT तो ablate करना ही है ना, मगर वो.
Yeah, because there's nothing programming wise that you can help it, because that's what the problem is.
Oh, very good. I think, thank you.
So now another interesting case, 72 years old patient and underwent dual chamber pacemaker for paroxysmal AV block. And the patient experienced syncope in the ward 30 minutes after the intervention. So the rhythm strip during the event was shown, and the device settings are triple D 6120, 18 ventricular outputs are 2.5, sensitivity, atrial sensitivity 0.4, ventricular is 2.8, paced AV is 160, compensation of 40, and the PVARP is auto.
मेरा कहीं नाम तो नहीं लिखा हुआ इसमें.
Again, ECG is always important. The iron tone that comes first before other stuff, that,
So there is a clue 30 minutes after the procedure.
So was the chest X-ray done?
No. So what could be the differentials here? Either the atrial lead has been dislodged into the ventricle, or vice versa, the ventricular lead has been dislodged into the atrium, or there is a header switch. No, but you have to prove why not the atrial lead dislodged into the ventricle.
So do you check the device before the patient leaves the lab? As a routine, do you check the device, program the device after you implanted it before the patient leaves the lab, or you implant and then that implantation is done the next day? So the programming is done the next day?
No, this is a tracing from literature.
Oh, okay.
ये हमारी भाई ये
For
वाला
academic.
केस जो है ना, हाँ जो जितने
मैं यही सोच रहा था कि आपको बुरा करने का मुझे कुछ टाइम मिलेगा.
ये हमारे जो होंगे हम जला चुके हैं उन ECGs को, हमने नहीं रखे हैं ये वाले. One of the fellows should look at this. I think इंतजार आप बताएं.
So if we look at the start, so there are two pacing spikes. So as Dr. Zubair has given, the paced AV delay is 160 millisecond. The first spike is just before QRS, and it looks like it is forming that QRS. And after around, looks like ये 160 millisecond के बाद ही एक और pacing spike आई है. But यहाँ एक question आप कर सकते हैं कि ये safety pacing क्यों नहीं है? तो it should be 110 millisecond के बाद ये थोड़ी सी longer लग रही है, तो ventricular safety pacing नहीं है ये. So looks like ये atrial जैसे lead switch in header है, और A pace किया, V pace किया, A pace किया, उसने V बनाया, और उसके बाद then V pace किया. कैप्चर इसलिए नहीं हुआ कि that was an absolute refractory period. खैर वो अगर कैप्चर होता भी नज़र ना आता, क्योंकि यहाँ पे QRS के अंदर है. But if we look at the other part where P's are there, but there is no QRS. So initial part when the sinus rate is slow, that is why the pacemaker is working at the lower rate limit, whatever it was set. So it was AV sequential pacing. But when sinus goes faster, तो जो P wave है, the ventricular lead is sensing, atrial lead is sensing this as a V, क्योंकि lead switch हुई है, तो इसलिए उसने कहा है कि it is the negative rate is above lower rate limit, so it is just not pacing anything. So जिसकी वजह से आपको P wave assist ली मिल गई है. तो ventricular lead is sensing that P wave is V. So V to V cycle length is basically in this is shorter than the lower rate limit. That's why pacemaker developed P wave assist ली. And again उसके बाद जैसे ही साइनस थोड़ा स्लो होता है, and then it starts working at lower rate limit, और साइनस फास्ट होता है तो पेशेंट को ये सिंकपी होना शुरू हो जाता है.
So the question is, ये जो हम पैटर्न देख रहे हैं ये इंटरमिटेंट क्यों हो रहा है?
So,
अब इसका आंसर सेटिंग्स में है कि जब स्विच हो गया तो वेंट्रिकल की सेंसिटिविटी कितनी है, कि ये इंटरमिटेंट ये सब क्यों हो रहा है. So the excellent description by Intisar. So why it is not the atrial lead which has been dislodged into the ventricle? Yes.
एट्रिया को पेस करेंगे तो वो एट्रियल लीड डिसलॉज है, वो वेंट्रिकल में है तो
वेंट्रिकल को कैप्चर करेगी,
क्रॉस टैक विंडो में आ जाएगा उसका, तो वो उसको सेफ्टी पेसिंग दे देगा.
Either there will be a safety pacing or no V pacing.
या नो पीसिंग.
ठीक है. अब ventricular lead dislodge into the atrium क्यों नहीं है? So the answer is clearly क्योंकि atrial lead अपनी जगह पर है, तो जब A pace होगा तो atrium capture हो जाएगा. So initially obviously there is no A capture here. Sinus beat हमें मिल रहा है. So the last one is the header switch. हेडर स्विच हो गया है, लीड्स अपनी पोजीशन पे बिल्कुल ठीक हैं. अब ए एट्रियम की जो लीड है वो वेंट्रिकल पोर्ट पे लग गई है, वेंट्रिकल की लीड एट्रियल पोर्ट पे लग गई है. सो नाउ द पेसमेकर्स आर प्रोग्राम्ड कि पहले एट्रियल एक्टिविटी होगी देन वेंट्रिकुलर एक्टिविटी होगी. सो व्हेनेवर देयर इज एट्रियल एक्टिविटी, अब क्योंकि ये वेंट्रिकुलर लीड है सो देयर इज अ वी पेस फॉलोड बाय द वेंट्रिकुलर एक्टिविटी विच इज एक्चुअली द एट्रियल लीड. तो यहाँ पे अगेन कोई एट्रियल एक्टिविटी नहीं है तो उसने सेकंड पेस दी है. सो द आंसर इज राइट. सेंस नहीं हुई, जो सेंस नहीं होगी
क्योंकि वो जो लीड उसमें उसकी जो आपका वेंट्रिकल का सेंसिटिविटी.
अब प्रॉब्लम ये कि पी का एम्पलीट्यूड कितना है. नाउ इट डिपेंड्स ऑन द सेटिंग्स. सेंसिटिविटी इज 2.8. तो पी का अगर एम्पलीट्यूड उससे छोटा हो जाएगा तो इट विल नॉट गोइंग टू बी सेंस्ड. बिल्कुल. और यहाँ पे एक्चुअली इंतजार वाज राइट कि जो अकॉर्डिंग टू द डिवाइस के वेंट्रिकुलर रेट बढ़ गया है, बट एक्चुअली इट्स द साइनस रेट जो कि बढ़ा है और डिवाइस ने उसको इनहिबिट कर लिया है. तो एक्सीलेंट.
इफ अगर वो बीच वाली जो ट्रेसिंग है ओनली द वेंट्रिकुलर स्ट्रेंथ स्टिल, तो डिवाइस इज कंसिडरिंग इट एज अ के ये वी आ रहा है, तो दैट्स व्हाई मतलब डिवाइस ने कोई जो है ना स्पाइक नहीं दी. What about the first complex and what about the sixth complex? वहाँ पे वो क्या अंडर सेंस कर रही है उस पी को?
Yes. अंडर सेंस होगा ना पी.
ठीक है.
2.8.
तो सर why it's sensing over there?
क्योंकि फ्लक्चुएट कर रही है, सेंसिटिविटी बिल्कुल करीब है उसके.
I think what it is this is a really good expert implanter. उनकी जो पी वेव है वो इतनी अच्छी है कि को कभी 2.93 की पी वेव है, कभी वो थोड़ा कम होकर 2.7 हो जाती है. एंड दे आर सो हैप्पी विद सीइंग कि इतनी अच्छी मेरी पी वेव आई. उन्होंने जल्दी जल्दी अपने हेडर लगा दिया और ऊपर का नीचे लगा दिया दूसरे का.
वन कैन अप्लाई
मैग्नेट लग कुछ भी नहीं होगा
सर मोड चेंज कर लेंगे. सर मोड चेंज कर लेंगे.
AI.
नहीं, but no, so you could even put in a
magnet.
आप रख देंगे, it will become DOO and it will pace everything. So that should be
AO.
जी. हाँ.
It will.
ये DO हो जाएगा ना? जी जी हाँ, दोनों पेश कर देंगे. So the question is, can this happen? If
Yes.
you are a good electrophysiologist, you are a fine person, you are very dedicated to your patients, can this happen? जी.
It will happen mostly when senior people are implanting. No, I'm not joking. If you're a junior person following protocols and you are allowing your team to, check loop. हम जब भी गलती करते हैं, वो तभी करते हैं when I override systems. When we're following intasar, we never go wrong.
So yes, these things can happen. और इसकी बहुत सारी वजूहात होती हैं. Most of the time it is because the cases are not going well, you're in a hurry. It often happens during device changes. So आप generator change करते हैं, उसमें हो जाता है. अच्छा, but almost always it will happen in patients who are not dependent. Because complete heart block intermittent है, आप pacemaker डाला है आपने, वो sinus rhythm में चल रहा है and you don't see it. So, and this is the patient that you will get in trouble with. A sinus patient जिसका अपना rhythm है ना, जिसको जो pacemaker dependent है, आप उसका TPM off करेंगे, आपको वहीं lab में नजर आ जाएगा कि ठीक है कि नहीं है. But this will happen in patients who are not dependent and then they'll go to the ward. So what you have to make sure is that you do not close your pocket or do not break scrub until you see actual pacing on the monitor. जब तक आपको pacing नजर न आए, आपने वहाँ से हिलना नहीं है. And this only happens if you don't do that. And once you notice it, it takes 5 minutes. You even forget about it. शाम तक ये हुआ. ये हो जाए तो आपको महीनों तक याद रहेगा. बल्कि जिंदगी पूरी याद रहेगा कि भाई ये हो जाता है. So always make sure you will leave the patient को आप देखें. How will you make sure कि ये pace सही कर रहा है कि नहीं कर रहा? How will you check? Lima, how can you check pacemaker काम कर रहा है कि नहीं कर रहा अगर normal beat आ रही है तो? अब आपने pacemaker में analyze हमने कर दिया, मैंने जल्दी लगा दिया, and I am your fellow, and you say I can't see any pacing. I want to see pacing before you take the scrubs off. मैं कहूँगा अच्छा मैं कैसे pacing मैं क्या कर सकता हूँ? ये तो pace नहीं कर रहा अभी, तो sense कर रहा है. So what can we do? आप उसमें magnet रख देंगे. You can put the magnet on, or you can put the programming head on magneting it. So transiently उसको, it will function as a magnet, and you will see both your A and V's coming in and doing it. So always make sure you do the क्या कहते हैं, हमेशा check ज़रूर कर लीजिएगा ये.
तो 2 बीट देता है वेंटिकल की.
स्क्रू करते
वक्त देता है.
I did not know that.
No.
So that's a feature. ये इसका feature है.
लेकिन this is absolutely right कि mostly the problems happen when you are overconfident or you think you are over smart. If you think you're too good, then the thing starts going pear-shaped.
So the next case is a patient who has been implanted a dual chamber pacemaker. He complained of palpitations. So during the atrial threshold test performed in this patient, the tachycardia was initiated and the symptoms were the same. So the device settings were triple DR 60, 140, atrial outputs are good, atrial sensitivity is 0.3, ventricular sensitivity 2, sensed is 210, paced is 250, PVARP 150, and PVARP 150. So PVARP and PVARP 150. So this was during the atrial threshold checking. So it's a simple one.
Pacemaker mediated tachycardia है sir.
But you have to explain beat by beat.
A pace, V sense, A pace, V sense, A pace, V sense, A pace, V sense. लास्ट बीट के अंदर A पेस करता है मगर कोई कैप्चर नहीं होता, P वेव कैप्चर नहीं होती. फिर उसके बाद V पेस करता है और वो रिट्रोग्रेडली कंडक्ट करता है एट्रिया के अंदर और एक टेकिकार्डिया इनिशिएट हो जाता है. और हमारा जो अपर ट्रेकिंग रेट हम लोग यूजुअली 130 पे रखते हैं तो उस पर ही ये टेकिकार्डिया चलता है, उसको एक्सीड नहीं करता.
So yes, it's a good explanation.
So what is this PC? Is it captured?
Premature beat, premature contraction according to the pacemaker. So here we can appreciate the A pace V sense, again A pace V sense, then there is a A pace, there is no V sense, then the device has to give V pace. So as a result of this V pace, there is a retrograde conduction, and as the P-VARP of this patient is very short, it's 150. So this retrograde conduction was out of the P-VARP and sensed by the device as a premature contraction, and then it again initiated the sensed AV. So there is a V pace, then again a retrograde conduction, sensed pace, sense pace, sense pace, and the clue to this is this tachycardia will be at the upper rate of the patient. So this is pacemaker mediated tachycardia or endless loop tachycardia. So like every other tachycardia, there are two limbs. One of the limb is the normal conduction system and the other limb is the device or the device leads. So the antegrade, the prerequisite in these patients are the retrograde conduction. So there should always be a retrograde conduction to maintain the tachycardia. So in these patients, you may have atrial undersense or atrial oversense, atrial loss of capture. So as a result, there will be a V pace, and this V pace will be conducted through the conduction system to the atrium, in which it will be sensed. So this A sense will be out of the P-VARP. So when this will be a sensed, it will again initiate the sensed AV and it will pace in the ventricle. So as a result, the re-entry will continue in this patient. So how you will terminate this tachycardia? So the question is.
Acutely to magnet.
So if you don't have a programmer or magnet.
Magnet application.
So if you don't have a, very good. Yes. So one of the participating part is the node. So simply you can give AV nodal blocker. So when you give the AV node blocker, the tachycardia will be terminated. So other options are the magnet and head of the program. So what should be done in future to avoid this tachycardia? नहीं ठीक है, और हमें सेटिंग में क्या चेंज करना चाहिए? P-VARP है, तो P-VARP बहुत ज़्यादा शॉर्ट है जिसकी वजह से रेट्रोगेट कंडक्शन सेंस हो रही है. तो नेक्स्ट टाइम जब P-VARP आप इसका एक्सटेंड कर देंगे तो रेट्रोगेट जो कंडक्शन है वो P-VARP में फॉलो होगी और लेबल हो जाएगी एज अ AR.
तो इसका स्पेसिफिकली P-VARP छोटा किया गया किसी वजह से?
यस, क्योंकि अपर रेट भी ज़्यादा है, जैसे बहुत सारे लोग
नहीं, मतलब कि P-VARP छोटा करने की रीज़न हो सकती है ना कि इन केस इट्स अ यंग पर्सन एंड यू वांट
because teenager, he was a teenager, young लड़का था, young लड़का था,
ठीक,
तो इसलिए उन्होंने इसका P-VARP शॉर्ट किया था.
बट उसमें अगर आप P-VARP सिर्फ बढ़ा दोगे,
ऑटो पे आप रख सकते हैं.
Consistently, auto would be one. What about a pure PMT option in the, because then this device will transiently treat it and then go back.
The second option is कि PMT इसका ऑफ था पेशेंट का, तो PMT इसका ऑन कर दिया था. So now coming to the case number 7. So the dual chamber pacemaker was implanted to a patient with sinus node dysfunction. So, and the EGM recorded on the pre-discharge visit showed the settings were triple DR, 60-120, atrial output was 2.5, ventricular output 2.5, sensitivities were shown 0.4, ventricle is 2.8, sensed compensation was -30 and paced AV was 150.
Okay,
so now again you have to keep the three differentials.
First, QRS atrial undersensing, and then there is A pace.
Capturing?
It's capturing the ventricle.
Very good.
V sense, this is V sense, and then there is V pace. And the second beat, there is atrial sensing, ventricular sensing simultaneously.
Simultaneously.
And most likely the atrial lead is sensing the ventricle.
Later on.
Okay. And then again there is A sense, V sense. Then again, under sensing and A pace, V sense.
So what is happening in the first beat and this one, this beat?
In
and
the
it is
fourth beat,
annotated here.
The atrial, it's capturing the ventricle, actually.
It's actually
Fusion.
capturing the ventricle in every complex except the second one. But there is a difference. If you look closely at the marker channel, here you can appreciate V sense, and before V sense there is
There's
a
a
spike.
annotation,
So it's there and it's there.
As well. It's detecting the QRS.
QRS.
Yes.
So next,
Then the same pattern continues for the next 4 beats. That's a safety pacing.
okay. So what will be the differential in this patient? Again, the
Most
three.
likely it's a
We have
lead
three.
dislodgement, atrial lead. Atrial lead dislodged in ventricle.
So again, the header switch is out, the ventricular lead dislodged into the atrium is out, and the atrial lead dislodged into the ventricle is the correct answer. So here you can appreciate whenever there is a pace, the ventricle is captured. And at the same time, this sinus, which was the native one, has make this V, and it was sensed in the crosstalk window. So as a result, there is a ventricular safety pacing. And on the next beat, the A sense and the V sense are at the same time simultaneously. So this shows the atrial lead and the ventricular lead are both in the same chamber. But the A pace capturing the V shows that the atrial lead is in the V, not the V is in the A. Yes.
So I was thinking that the first one probably has not captured because the QRS looks the same as before in the atrium, and it may be a conducted beat.
Yes, it's a conducted.
And now in here, when we are in the crosstalk, when it falls in the crosstalk window, does the VS stand for ventricular sensing? And how do we know? Is there a marker for ventricular safety pacing, or it doesn't usually have a marker, or at least?
No, only the abbreviated AV interval can define the ventricular safety pacing.
So
but
this is, I would like to add, this is a specific marker of Medtronic for safety pacing.
Safety pacing.
So if you see that A pace, just look at the second marker annotation, A sense and V sense height. Both the height of that annotation marker is smaller. And A pace and the V pace always has a bigger height than the sensing markers in Medtronic. So अगर आप वो देखें कि जहाँ पे V sense लिखा हुआ है उसके बाद एक और मार्कर है जिसमें कुछ नहीं लिखा हुआ. So that is the marker of V pace spike that corresponds to the upward. So and it all happens with atrial pacing. Hence the ventricular safety pacing, because the A pace, then V sense, the QRS is sensed in the crosstalk window, and then you have another spike, which is the safety pacing spike. It is not annotated as V pace, but it is marked as a bigger annotation on the line.
So now coming up to the case number 8. So 49 years old male presented in OPD after 1 day of device shock. So the settings were VT at 440, fast VT 310, and VF at 270. So now this is a tachogram of the patient. So now to start with, yes.
On tachogram, there is tachycardia. Both the A and V are both falling in the. They are both less than 200 milliseconds, but there is more atrial activity than the ventricular activity.
Okay. Later on.
And later on, there is a shock. there is a shock, there is no pace, ATP, there is just a
No.
shock, and after the shock there is.
So the question is, what is happening here?
and V.
What is happening till there? And then you appreciate the V's are separated from A. So initially the A and V are at the same, then
The atrial rate is
more or
more
less
than
at the
ventricular
same.
rate.
Then you have scattered activity of the ventricle. Then at this time, the A's are there, they are faster. Then the V has separated. And then you can appreciate the shock, and both the activity of the atrium and ventricle is out of the zone. So what really had happened here, initially and later on? जी सर.
So
Yes, A is
इसमें
fast.
डुअल टैकीकार्डिया चल रहा है.
Initially क्या हो सकता है?
इनिशियली सिर्फ एफएब है, और उसमें हम देख सकते हैं कि जो वेंट्रिकुलर एक्टिविटी है वो काफ़ी स्लो है और इरेगुलर है, लेकिन एट्रियल एक्टिविटी बहुत फास्ट है. और वो वेंट्रिकुलर एक्टिविटी एट्रियल एक्टिविटी बहुत फास्ट है, और आगे जाके हम देखते हैं तो वेंट्रिकल रेट भी फास्ट होता है, वो सडन ऑनसेट फास्ट होता है, और वो वीएफ जोन में आता है. तो एट्रियल एक्टिविटी वेंट्रिकल एक्टिविटी बोथ आर इन द वीएफ जोन, लेकिन देयर आर मोर एज देन वी, और एट्रियल रेट बहुत ज़्यादा फास्ट है एज कम्पेयर टू द वेंट्रिकुलर रेट. अल्टीमेटली डिवाइस जो है उसको शॉक देती है और दोनों टैकीकार्डिया रिवर्ट हो जाते हैं और पेशेंट साइनस पे आ जाता है.
So the question is, why not the AFib with fast ventricular rate? AFib with fast ventricular rate. Initially,
तो हाँ, तो अगर हम देखें इंटरवल प्लॉट पे तो जो वेंट्रिकुलर रेट है वो काफ़ी रेगुलर है. सो इसमें यही होगा कि जब डुअल इस तरह का टैकीकार्डिया होता है तो डिवाइस वही पीआर लॉजिक लगाती है, और उसमें फिर वही चीज़ है कि 1-to-1 साइनस टैग एएफ उनके एल्गोरिथम यूज.
So here's the second.
So अब इसमें ओके, so ठीक है, देयर इज मोर एट्रियल एक्टिविटी देन देयर आर मोर एज देन वीज, और उसके बाद जो वेंट्रिकल का रेट है वो फिफ्थ जोन में आ रहा है, और डिवाइस डिटेक्ट्स it as VF and gives the first therapy of VF. और उसके बाद when the charge ends, device delivers the shock, और दोनों टैकीकार्डिया ख़त्म हो जाते हैं. अब इसमें कि why did the device shock? तो पीआर लॉजिक में डिवाइस दो चीज़ें दिखेगी. एक तो दिखेगी कि मॉर्फोलॉजी मैच हो रही है वेंट्रिकल की नेटिव से या नहीं, और फिर दूसरा ये दिखेगी कि वेंट्रिकल की स्टेबिलिटी कितनी है. तो ये दोनों चीज़ों को दिखेगी. और इसमें क्योंकि वेंट्रिकल रेट इज़ फेयरली स्टेबल, और पता नहीं से उसमें मॉर्फोलॉजी भी लगाई या नहीं लगाई, लेकिन अल्टीमेटली डिवाइस सेज द रेट्स वीएफ.
So actually this patient had paroxysmal atrial fibrillation. So initially the patient was in atrial fibrillation, and later on at the same time one can appreciate the AFib is going on, but later on the patient also developed ventricular tachycardia, which was initially was not, tachycardic cyclin was not stable. Here you can appreciate it was not stable, and that can be expected at the initiation of the tachycardia, but later on it gets stabilized. So the device recognizes the ventricular tachycardia as appropriately, and then it gives a therapy. Okay, so the charge and reconfirmation, so it's the first therapy, charge and reconfirmation, charge lever. So as a result, the tachycardia in the ventricular, which is the VT, and the SVT in the atrium, which is atrial fibrillation, both terminated, and the patient reverted back into the sinus rhythm.
वैसे very nice trace, and जो surprising चीज़ इसमें है कि ventricular tachycardias do tend to be defibrillated, cardioverted. Atrial fibrillation is relatively resistant. Even मैंने देखा है अंदर devices से जो जाता है बाहर, probably 30 joules है. That's the reason. आमतौर पे settings में पुराने वक्तों में हम 15 joules पहले रखते थे.
Yes.
Hardly ever used to convert. Atrial fibrillation को touch भी नहीं करता था वो.
बिल्कुल.
But possibly. हाँ.
Thank you very much.
Thank you. Lovely, lovely. ये 30 मिनट मुझे ही दे दे. ये 30 मिनट मुझे ही दे दे. ECG पे.
I would like to call Dr. Amir for shield distribution. Dr. Azam, would you like to come for the field? Second shield is going to be for Dr. Zubair. We will be having a lunch break of around 30 minutes, and after that we're going to gather again for the next session. Assalamu alaikum. We're going to start our last session now. This session is going to be on analysis of interpretation of intracardiac EGMs. It will be conducted by Dr. Sarim and Dr. Mohammad Asad. Dr. Faisal has to come, but due to health issue, he is not going to be present in this session. Dr. Sarim.
Assalamu alaikum. So I'm Dr. Asad. So I will be starting the cases. So let's go to the first case. Next slide, please. Okay, so we will be discussing some EP tracings. So this is an ECG of one of the patients who had history of palpitations. So anybody will like to comment on the ECG before we move forward?
So don't overthink. Things are very simple. It can be a normal ECG as well, so don't try to take out things which are not already present there. So, and just make this interactive as much as possible. Okay?
So this is a middle-aged gentleman who presents with the history of palpitations, and this is ECG during sinus rhythm. Actually, I haven't made these slides, so these were from another author. So I cannot comment really on that.
Hello. This V1 is not the real one. It's defective, so please don't comment on the V1. No.
So come on, guys. Go ahead.
So let's start from the P waves. So what do you think? These are the sinus P waves, or is some kind of another activity going on?
No, this is sinus P.
Okay, good. So I think whenever in doubt, always start from the P wave. You have to see how the conduction system is working. So if it's a sinus P wave, so
after this meeting, it would be very nice. जो जितने भी trainees हैं in electrophysiology and those who are aspiring to join training program, अगर इधर आए हुए हैं तो we should meet them after the meeting.
Sure. Okay, so P waves looks fine. So what about the PR interval now? So is it normal? Is it prolonged? Is it short?
This is normal PR.
So it looks to be a healthy looking normal PR interval. Okay, so what about the QRS complex?
Also seems to be normal.
It's also narrow. Okay.
QT interval seems to be normal.
What about T waves? Are they fine? Although it's a discussion on EP tracing, but you have to read ECG as a whole.
So it's normal ECG, nothing fancy.
Because there are lots of hints sometimes on the ECG which leads to the diagnosis or the most likely diagnosis in the case before even putting the catheters inside. So
what are the things on an ECG that you would look for that can induce palpitations? That one could probably. But otherwise, so this ECG looks fairly normal.
Yep, it's normal.
Okay, we'll move on to the next slide now. So now this is intracardiacs. So before we speak on it, anybody would like to comment or give his opinion?
Okay, so these are the intracardiac traces. Initially lead 1, 2 and V2 is shown. There is a drive train there is a ventricular pacing with drivetrain of 600, and then there is an extra stimulus at 330. And there is concentric activation of the A wave. Then this is followed by a sinus beat.
Else what?
Concentric CS activation.
There's a drivetrain of 600, and then we gave an extra stimulus at 330, ventricular extra stimulus. There's, after a pacing spike, there's V, his, and A. So there's a retrograde conduction. So maybe it's retrograde RBB.
Okay, nice.
Very good points. So I think whenever describing the ECG, always start from, the tracings always start from the ECG. So look at the site where you're pacing from, because sometimes you have to do pacings from multiple sites. So never ever skip these ECG's findings. So where do you think this pacing is being done from? Most of the routines in the most of the laboratories here, I think they start from the RV apical pacing, if I'm not wrong, because in our setup we always used to start from the RV apical pacing. So for that, look at the ECG. So we do not have V1, but V2 is more of a left pendulite, yes, and lead 2 is negative. So this means you are more towards the apex and more towards the right side. So you're doing a right apical pacing, okay? So, and then, so you're checking for the retrograde conductions. So for the retrograde conduction, so first of all, you have to be sure that whether this pacing artifact is capturing the ventricles or not. Is it really capturing the ventricles? So this is for the beginners as well. So for those who are advanced in their training, this might look to be a very simple things, but I think you should not miss the basics. So first of all, we have to make sure that the V is being captured. So I hope everyone agrees that it is being captured. Yes? Yes. And after that, now this, which kind of testing is being done? So it's a ventricular testing, but there are different types of protocols. So which protocol is being followed over here?
We are doing ventricle extras.
Good. So it's a ventricle program, ventricle extra stim. Okay. So we are giving, we do not have unfortunately too many spikes. We can really see probably because there's a kind of hidden spike in there. So the only thing we can see is a 600 millisecond RV distal. That is the first spike, a pacing artifact. The second is at 330 millisecond cycle length. So what happened during 600 millisecond and what happened during 330 millisecond? So any opinions
in
or
the
any
first
thoughts?
beat, it seems like there is a we can see a V, and then probably a small a in the his proximal. But then when we see the second beat, we see that the V, both V's are quite different. The first V seems to have a his, while in the second one out, it just separates out.
So the first
we can see a V and H is separated out, and then an A. And if the V-H interval is more than, I think it's 40 milliseconds, if it's more than 40 milliseconds, that means there is a retrograde right bundle block. Because
just show what she's saying so that everyone knows.
Sorry, this was not working initially, so now. Sorry, I cannot see who is speaking. Oh, so great. I was just looking out who was speaking. Okay, great. So, sorry if you can repeat it again for the audience. I can also mark that out for you here.
When the drivetrain of 600 ends, the beat which comes, it seems like it's a ventricular beat. You can see there is a V, and in his proximal you can see there is an A. So this is a VA probably, but then when you see the second beat, in that you see that the V, there is a V, this is a capture, this is a V, this is an H, after that this one is an H, and this is A. So coming back to the first complex, now we can see that the V and H are fused in this one.
So this is V and H, which separated out when we gave a stimulus of 330 milliseconds. Now when V and H separates out, that means that when we gave an impulse, it takes a longer time to reach to the His. Probably because the right bundle got blocked, and it takes more time. If transeptally it goes through the left bundle, it takes more time to travel, around 40 to 60 milliseconds. So we see the VH, how much the difference there is in VH. If it's more than 50 milliseconds, then we say that, I think it's 30 to 50 milliseconds. If it's more than that, then we say that this is retrograde right bundle block.
Great,
Yep.
excellent.
Excellent.
So the main purpose of doing a retrograde extra stem is you have to see how the conduction is moving upwards. Is it through the node or is it through some other pathways? Okay.
So my question is that if you're seeing such a beautiful His retrogradely, why are you not seeing the same His on the same catheter
antegradely?
Antegradely.
It's a very good question. Sometimes the His is not in your own hands. So most of the times it's the, I think, nature.
The stability of the catheter also also matters. The stability of the catheter also matters. Secondly, the morphology of both the antegrade and retrograde His is also different.
So very rightly said.
What I wanted for people to understand was that when you're doing an EP study and your His disappears, which is so nice. Retrograde His लेना काफी मुश्किल काम होता है. And you have, if you have short spaced catheters, उस पे आ जाता है. तो उस पे भी आना चाहिए था. I would look for pre-excitation after this happens. जो कि नहीं इस पे नजर आ रहा because आपका His नहीं है. लेकिन in that case, sometimes if you get pre-excited due to any reason, your His can disappear.
Yep.
But you need to, whenever you're doing maneuvers, try to stabilize your His because it gives you information. And if you are making purchase on the retrograde findings, then antegrade should be giving you something. Or the other thing it means is that what you're looking at is a distal part of the His bundle deflection, and the anterior catheter is probably in such a manner that it is not picking up that distal in antegrade activation.
Yes. So one important point as well, like you can see A over here and A is over here. So this is a very low amplitude A, and look at the A's over here. So this might something have to do with the motion of, because heart is always in the motion. So all the catheter might be kind of moving, and recording might be difficult sometimes. So
the actually catheter look very stable.
But I think
so. The catheter, if you see, if you compare your His, so look at your His, and look at how do you get the V, you get the V and A together. So if you look at, so the catheter looks pretty much stable, and that's why it's surprising that why you are not getting the His. So I'm not sure whether your His is moving. I think the His is stable. It's just the nature of the retrograde conduction is sometimes you see it on the retrograde. So you don't see your catheter moving or the morphology changing or the bipole changing. The bipole also does not change. Your proximal and distal bipole remains the same morphology. So I'm not sure it's, I think it's...
But we have got, I think, what we needed to have. So we need to see a retrograde His in this case. So
typically अगर आपका clockwise torque अच्छा ना हो ना, because अगर आप उसमें देखें जहाँ पे His नज़र नहीं आ रहा, antegradely वो जो last उसमें, because the V is very छोटा है, इसका मतलब clockwise torque अच्छा नहीं, clockwise torque अच्छा हो तो आमतौर पे
very right.
उसको रोल करके उसके ऊपर गीली चादर डाल दिया करते थे,
ऐसी सर ऐसी होता है,
टॉर्क की और हाथ भी खराब
इसी तरह होता है.
Sometimes clipping भी करते हैं probably वो, we have done a few times as well, clipping करके उसको हम attach कर देते हैं. So
आपकी field है ना should be meticulous. ये जो noise है, try to remove these, they are in your hands when you are doing an EP study. ताकि आपको different क्या ये for the, I'm not telling you, I'm telling the people who are training right now to have a very clean ECG as well as ये जो noise वगैरह, और अगर इस किस्म का you're not redundant, तो हटा दो 9-10.
Just बता सकते हैं where is your RV catheter, because what's the best place to pace from to get a retrograde hiss?
I think it's more of a basal because we have a kind of a good separation. But since we do most of our cases, because we sometimes also have to do an RV apical pacing in some of the scenarios as well. So
just for the
so if you're not seeing a good haze, so try to pace from the basal RV.
So just for the audience, can you explain why that is?
Okay, so because whenever you are putting your catheter on the apex, so the route, the retrograde conduction route is a bit shorter. So sometimes the V kinds of merges with the haze. So if there's a kind of a long V or there's some kind of fractionation or any disturbance, so the time will be very short and sometimes the haze will be seen inside the V. So it's pretty hard to delineate the haze from the V.
So what you're saying is that even though anatomically the base is closer to the location of the hiss,
exactly.
Electrically it has to travel a further distance.
Yep.
So since we are seeing a pretty good haze over here, so
okay. I think we have gone enough now on the retrograde. So carry on.
Okay. So what does this suggest then? So what's the final conclusion based on this retrograde activation? So is it going through a node or through some other alternate route? So as she very rightly explained all these things. So the thing is, to evaluate a retrograde conduction from the node, so you have to see the his and the A relation. So if the his moves out and then the A moves out and the HA remains the same, this means the retrograde A activation is dependent on the his, suggesting a nodal activation.
Yep.
And however, you cannot clearly see his over here. If we had, we will be also very much sure, we can explain that pretty well. But still, we can also see that this A moved out, and if we can measure the distance from here to here, sometimes it might be here, definitely. So it looks to be a pretty much same interval. So this suggests that it is a retrograde nodal conduction so far. So does this prove anything, or does this rules out anything based on this maneuver? So any comments on this? So
Yeah.
this rules out accessory pathway? Yes? No? So these are the only two answers available, yes and no. So you, okay, so
Not left-sided pathways.
yes, very right. So it doesn't still rules out the accessory path. It can still be present. So there are many scenarios for that. We will not go into the details. So going on to the next slide. So now we have done another form of pacing, ventricle pacing. So anybody would like to have a say on this?
So a simple one, don't overthink. Okay. So it's decremental. Yeah, you are doing straight pacing and
So this is ventricular straight pacing and drive. Actually, we are seeing the Venki-Beck. So 320, 320, then 311, 310.
Okay,
So
very right.
pacing is 5 followed by V and then A. And after second, third, fourth beats, pacing is 5 V.
So it's a ventricle pacing, you're very right, and we can see there is some decrement, although not too much, but we started from 320 milliseconds, we went on to 311, then 310. So we are kind of doing a decremental pacing. So it's not a straight like fixed rate pacing. We are doing decrement, although not too much. I do not know it will give so much yield or not, but since we have slides now with this pacing, we have to comment on the activity. So first of all, you're doing pacing, it's capturing the ventricles consistently. There's no loss of capture. Okay. Now again, we have to see a retrograde conduction as well. So what do you think is now the retrograde activation like? So you can see. So first of all, you always have to see his now here. So This is the
point.
Okay, so now if you can see, somebody said concentric activation. So what do you mean by concentric? So let's clear this concept as well, because there might be some people who needs to know about concentric or eccentric. So concentric
means we are pacing from the His catheter. So the earliest A or earliest activation would be from the His distal, followed by CS 9, 10, 7, 8.
So what do you think is happening? Is it a concentric or eccentric activation based on?
This is concentric activation.
So you can see an A over here. Looks to be a far field of, this might be good A. So look at this A, and it is the earliest A so far we can record.
Yeah.
So we cannot see any good activity on his proximal, but we can see his distal. So the earliest A so far in all the EGMs is at his distal. So it is more of a concentric and not eccentric. Okay. So and then when we're doing a decrement, so any changes in the activation or V to A relation, or it appears to be fixed. So there are some hints, if you can see, there are some hints on the HRA. So you can see in HRA.
Fifth beat, there is ventricular pacing, but there is no atrial activity on the HRA catheter.
No atrial retrograde activation.
Yeah.
So now what's happening over here? Third year.
So हम वेंकी बैक तो कर रहे हैं, यानी जो V इंटरवल है प्रोग्रेसिवली हाँ
Sinus activation.
That's what I think. Then you block, तो अगला वाला जो है वो nodal conduction लग रहा है. Possibly. Is that possible?
बहुत slight. आप fusion आप कहना चाह रहे हैं sort of a fusion हाँ.
That's the question.
So obviously you cannot judge if there is a 20 millisecond decrement or not. We don't know.
Right.
हाँ.
बिल्कुल.
So if it's decrementing or not, eyeballing, I'm not sure. Decrementing, but maybe decrementing.
अगर वो decrement करना ऊपर देखेगा तो higher artery चेहरा वारस को देखें तो maybe there's a.
So if we look at the CS12 after the block, that V is different and this V is different. So there the cycle starts again.
So
maybe it's very slight decrement. We are not sure about
very
that.
difficult. I didn't make this slide, so I'm sorry if I for these things, because movements are always very important in EP. So, but the thing is that if you can see here and look at this, so I think it's a very grossly different VA.
So if the Vankebax, if there is a slight decrementation, I don't know, it might be possible that it will take 10 beats to drop. So that's why the VA is decrementing, but it's on the very, it might be decrementing, but in a very slow manner. But there is a clue that after the block, the VA is very short as compared to this one. It means that it was decrementing.
So now my question for the fellows is, how will you differentiate this behavior from the pathway behavior? So if it's a retrograde conducting pathway, so what will it behave like when it blocks? Or,
most of the time.
Most of the time.
मुझे मेरे उस्ताद ने कहा था EP में never say never.
हाँ. So pathways can decrement?
Yes,
Yes, they can.
So if it's a non-decremental, the usual pathways, sometimes there are rare pathways, we're not going into that.
इस तरह से किया जाए कि in a non non-decremental pathway, what would be the difference between VA block and AV block?
Because sometimes this also helps you in understanding the concepts. So when the pathway blocks, it blocks suddenly, but the VA will remain fixed because it's not non-decremental. It's an all or none response if it is conducting or it's not conducting. So, but now here we can see, although we do not have a tracings from the previous, this might be going on for a long time and then this happened. But you see there's a kind of a VA prolongation, not very classical prolongation, but still you can see these slides. So the pathway usually doesn't behave like this. The traditional non-decremental pathways. Decremental pathways, obviously they can. So it's a fixed kind of, either it conducts or it doesn't conduct.
But again, if we see last 3 beats, so you continue pacing at 310, 310, 310, and after that we have fixed VA with 2-into-1 block. I can see that. So if we look at last 2 beats, yes, 2-into-1 VA block.
Very right, very right. The thing is, we do not have a hiss. So we need to have a very good hiss to identify where the level of block is.
Carry on, carry on. Yes.
So I'm going.
Next.
So now this is the third. This is the opposite chamber being paced now.
So what is the protocol?
So we have gone retrograde now. We are
And
going
from
anti-
which chamber we are pacing?
So
yeah.
you can see spikes over here. So where is the stimulus artifact seen?
So CS56.
Good. So we are pacing from CS56 now.
Yeah,
so
600 and then extra at 360 milliseconds. And again we can see the, I think there is a decrement in AV conduction, but I can see his in last beat, and his is separated out from that V in his bundle. Catheter. इससे आगे वाला जो last.
Sorry, इससे आगे कहाँ ये?
हाँ ये वाला.
So this is a hiss.
Where is the hiss?
No. So identify the A and the H and the V.
So this is an A because you are capturing, you are giving stable artifacts and.
नहीं hiss catheter पे दिखाओ ना. So A कहाँ है, H किधर है और V किधर है, and you'll know.
So पीछे जाएं spike के बाद जो second last beat पे. So this is spike, then A.
Yes.
And then maybe a small hiss.
Yes.
Separate deflection and
Yeah,
then V.
तो पीछे लेके जाओ.
बीच में पीछे
तुम उसको ना चक्कर दे रहे हो.
Actually we do want to confuse Intisar. Are you talking about this one?
Yes, so that is his, and then
okay.
And then V.
Okay.
And उसके बाद then again A H and then V. So here V signal is splitted, I think, and if you look at QRS, it becomes broad.
Okay.
Good.
Else what?
So it looks.
What
like
is
it
the
becomes
HV?
pretty excited, yes.
I think let's be a more kind of generalized. Do not go into the depths. So first of all, let's generalize it. So what is all suggesting all this? Is there any kind of hint towards any diagnosis, or it's just a clinical phenomena being seen? So what do you think?
If you only see the first 3 ECGs, what happened to
it? So
what is happening to the intervals? And secondly, this white QRS, is this a pre-excited one or an aberrant?
No, that looks aberrant.
Okay, what makes you think?
So if you look at HV interval in that, it is not short, it is longer than previous HV interval. So that goes again pre-excitation.
Good.
So to begin with, I think to begin with, if आपने measurement नहीं की हुई, साथ लिख देना चाहिए उधर. आपका जो drive train के ऊपर HV interval है, that looks magnanimous. ठीक है ना? And then अगला वाला जो है वो उससे भी ज़्यादा बड़ा लग रहा है. And my question to the people over here is, why would you specifically pace from CS56 preferentially, if you do sometimes for the same maneuver? Usually high right atrium से करते हैं और high right atrium आपके पास है भी और बड़ा अच्छा उस पर signal आ रहा है. अनलेस आपकी मशीन हमारी तरह की हो जो हाई राइट एट्रियम पेस ही नहीं करती है, तब हमें CS से करना पड़ता है. बट प्रेफरेंशियली एज एन EP, why would you pace from CS 5-6?
So when we are expecting left-sided X-ray pathways,
और इधर आ जाओ.
Okay. और यानी पाथवे से हट के भी सोचो. इससे और क्या हो सकता है? एक तो इससे आप रिफ्रैक्टिव पीरियड्स वगैरह चेक कर सकते हैं. और क्या हो सकता है इस ड्राइव ट्रेन के साथ एक्स्ट्रा स्टेम में क्या कर रहे होते हैं?
so tachycardia induce कर सकते हैं.
एक्सेलेंट. सो टैकीकार्डिया, अगर आप ब्रेड एंड बटर टैकीकार्डिया इंड्यूस कर रहे हैं, पेसिंग फ्रॉम हाई राइट एट्रियम वर्सेस पेसिंग फ्रॉम अ CS प्रॉक्सिमल कैथेटर, किसके चांसेस ज़्यादा होंगे? So you start with HRA, and if you fail over there, the next step is to move closer to the slow pathway and work there.
Okay,
Sorry for digressing.
So I think this is just a phenomena being seen, so we cannot say for sure.
Yeah. So next.
Is there any diagnosis in this or not? So let's move forward. So again, we're doing a pacing from CS 5-6, and now we can see something different over here. So we're not seeing any aberrancy over here this time.
So what is the observation? And there is some special phenomena. You can name it.
HR is early. So HR is
Question over here is,
yes.
you are blocking your left bundle at 360. At 330, why would you expect a normal conduction?
So this is a 360 and this is a 330. 330. So it's
तुम लोग 30-30 का jump लेते हो?
This is not my slides. Again, I'm sorry about that.
नहीं,
I have to.
उस 6 केस हो जाएंगे 3 के टाइम में ना.
सर वैसे वो जंप के लिए 10 है और इस पे तो खैर 10 जरूरी नहीं है.
I think might be some new fellow might be doing this case.
Decrement 10
अच्छा, anyway, so what is the answer? Why would you expect a block bundle or to recover conduction with a incremental extra stem?
There's a phenomena called
the feedback phenomena.
So let me summarize this finding. So we are giving an extra stem, and then we find an aberrancy, and we are given extra stem with a much shorter interval, and we are finding a normalization. So what's this phenomenon? It's a very important phenomenon. Often comes in the exams.
It's a gap phenomena.
Very great.
Okay.
So
and why is it happening? Why the left bundle recovered?
So it has to do with the refractive periods. So if you can appreciate the refractive periods, how they work.
If there is a more distal block, then the proximal part it gets recovered, and then you can conduct from there.
उल्टा हो गया.
So the thing
उल्टा हो
is-
गया कुछ.
सब बोल दी.
So
हाँ कुछ उल्टा हो
let me
गया.
explain it. So basically
block
there
in the
are-
proximal side
So
will
there-
relieve the block in the distal side. So यहाँ क्या proximal है?
So the thing is, if you can see, we are finding some split potentials over there, if you can appreciate. So if you can see in the last, before that left bundle, we can see just after a pacing, we can find two very sharp and split potentials. So in my opinion, we have to see it further to see whether there was an intra-Hesian delay along with an infra-Hesian delay, which led to left bundle as well, because the HV interval, because we cannot see a pretty good haze in the normal conducted beats. So if we had seen the haze in that beats, we might have been able to describe that broadness of the left bundle. So clock.
That is why the case is moving. So yes.
So it's simple. Look at the AH interval over here.
Intra-Hesian delay से left bundle
No, along with that, so that's what I'm saying. If we had a haze over here, so we can see the HV interval, how the HV interval was in the normally conducted beats, and then we can assess with that beats. So unfortunately, we do not have the haze in the normally conducted beats. Otherwise, we have been it will be easier to evaluate these conduction.
हाँ बढ़ गया ना A H So it's simple. The node has decremented it to such an extent that the AH has prolonged, and now the left bundle has enough time to recover from the refractory period. It's simple. Just keep the thing simple.
That's more plausible. Okay. So far, I think we are still in.
Yeah.
Still not able to decide. So what about this tracing?
So what is the pacing protocol and what it has resulted in?
So now we are again pacing, and so,
Easy one.
So
here we are pacing from CS, and the activation sequence is eccentric here, and the earliest A is at CS.
We are pacing from CS.
CS. We are pacing from CS.
So let me take this. So we are pacing from the CS. The drivetrain is at I think 400 or 500 milliseconds, then an extra stimulus comes in at 300 milliseconds with the prolonged AH interval, and looks like a jump with an echo beat. And the second beat, it has gone again into the circuit and becomes the left bundle branch block. So this looks like a rate-induced left bundle branch block as we've seen previously. And the VA seems to remain constant, but there is an observation on the left side CS, the A is prior than the V because of the left bundle branch block. Because we have no signals on the CS7.
If we time VA from the surface to the earliest, it is constant in the left bundle as well as in the narrow one.
So if you see the signal on the left bundle branch block intracardiac at the his, the first signal is the his, then you have an A, and then you have a V.
So let's start from here. Very rightly said. So what about? So we can start from here. So if you can see, this is an A, and then this is probably in his, most likely in his, and then converted into V, and we again have a signal on an HRA. You see over here. So when we are pacing over here, so we cannot see anything. But over here, when there's a huge gap between this V and A, and then again something happened here, and then we had a run of some tachycardia going on. So as you said that this AH and echo back to the atrium retrogradely, and then we had started our tachy, and this was a narrow beat, and this was a broad beat. Okay, so one more important thing you have to see when you are finding an aberrancy, how is the VA interval looks like. So is there any change of VA interval or not? Looks.
And you have to calculate the VA from the surface.
You have to calculate it, but
that's also important.
Gross look. So there is not a gross.
It's zero almost. But I would say it's minus. Yeah, it's almost negative. Yeah.
Intervals.
V to high rated.
इसमें VA मेजर करें ना तो जो नैरो बीट पे A तो हमें इतना अच्छा नजर, HRA पे देखें तो it looks the same, but अगर आप इसको हिस पे देखें the earliest A is present on the his, so ये तो नेगेटिव आ जाएगा फिर. ये ग्रीन मार्कर A पे जरा प्लीज रखिएगा. ये नहीं, ये V है.
हिस के A पे.
बीच वाला जो सिग्नल है that is the his का A.
इसके पीछे वाला.
नहीं इससे पहले वाला. Yes, this is his A.
ठीक है. It's बिल्कुल ऐसी.
So CS में जो तुम्हें A नजर आ रहा है, so your his A is falling on that. So what is the? Are you thinking that this is his?
I don't
Which
think
one?
so. This is an his.
His is before the A. Before the A.
So his is before that.
Yep.
Yeah, this one. Or these are two his.
No.
ये लेकिन A explain नहीं होता ना.
So but this is in line with this A's. So अगर आप देखें तो ये A's है and then small tacky to be.
So your his A should be in this. अगर ये tachycardia जो तुम prove करना चाह रहे हो, उसमें his A को क्या होता है? So his A should be the earliest A.
Yes.
His
Yes.
A should be the earliest A.
So this is okay.
And this appears to be a bit negative, although we are used to seeing a just V on A or a short VA, but this is one of the important concepts. If you find a negative HA, it again leads to some diagnosis. So it shows that it is favoring which tachycardia. So any tachycardia with a negative HA, I hope you're understanding the concept. So this means that the retrograde limb doesn't depend upon the previous activity. So which tachycardia is kind of ruled out, and it is never possible.
Anyone has any issues understanding it or no? Or you understand what's happening or not?
डॉक्टर सर एक बार दोबारा से
Yes
बता
or no?
दें.
तुम्हें समझ में आ रहा है?
नेगेटिव
लोगों को नहीं
HA
समझ आ रहा?
दोबारा बता दें.
नहीं समझ रहा तो बताओ ताकि हम एक्सप्लेन करें ना.
So the point is, देखें जो
मैं तुम्हारे पास आ जाता हूँ ताकि उनको समझने में आसानी हो जाए ना. पॉइंट करते हैं. ठीक है. So what is this? This one.
A.
And what is this? A. And this one, which is an A on the his, is leading. Yes? So his A is leading, and if you draw here, from here till here,
It's almost zero or negative, I would say.
almost zero है?
हाँ.
है ना?
Yep.
So your VA is almost
Zero.
Zero. Okay? Okay? Now, so now tell us what's the differential now?
Or
Yes. And?
three differentials. JT and तीसरा बचा है 80 विद अ प्रोलॉन्ग PR इंटरवल और फोकस होगा वो नोट के पास का. अगर वो ऐसा 80 है उसका फोकस बिल्कुल नोट के पास है और वो उसके साथ जा रहा हो नोट पे डेक्रीमेंट कर रहा हो उतना अनलाइकली. चले जी नेक्स्ट. So this left bundle is due to phase 3 block, right? Due to tachycardia. Okay, next.
But I have just one question. So if this is atrial tachycardia, then why his is leading the A even in his bundle?
His is leading?
The A. His is before A. So even in atrial tachycardia.
So if it's atrial tachycardia with a very prolonged PR interval, that A will be before. Before.
It's the basically the thing is, so the his and the A relation is very important in tachycardias. So if the tachycardia is a nodal dependent tachycardia, this means if the tachycardia is node dependent, then you have to see a his. And if it's a non-nodal dependent like atrial tachycardia, then still you cannot just prove on this tachycardia, you have to do some maneuvers in order to prove that. So here you can just give differentials, you cannot give the diagnosis. Although very rarely there are some features which can help you within the tachycardia when there's a wobbling. So sometimes if you find a wobble within the tachycardia, then this can lead to some of the diagnosis differential. So wobbling means कि tachycardia की cycle length variation हो. Then you have to see the driver of that tachycardia. So which change first and which change the next. So here you can give the differentials and you have to do maneuvers for that. It's unlikely, it's likely, but so we have to
टॉप
do.
मोस्ट आपके JT और एटिपिकल इम्यूनिटी होंगे.
If you're seeing the his where you're seeing the his, then atrial tachycardia is out.
His before the A.
चले next. एक ही केस पे पूरा पता निकल जाएगा टाइम. हाँ.
Okay, so now we have the tachycardia going on.
So same tachycardia going on. Okay. Next.
So what about this tachycardia? How is the VA interval? Is it changing? It looks to be a regular. Okay. So now anything significant? I think this is the concept we have discussed too much. So let's move on forward. So this is the ECG during tachycardia. Okay, so this was just to show that tachycardia on the ECG. So let's move forward. We are short of time as well.
Okay.
So
same tachycardia,
so
and now it has become narrow.
So now again a change in tachycardia as well.
So what is this phenomena called?
So what do
Why
you
does it happen?
What do you see? Which features do you see when there is a change in the morphology of the QRS? So what would you like to measure? The VA interval during the beat which is wide based, and the VA interval during the beat which is narrow based. So what do you think? This looks to be a pretty cycle. Obviously it changes, but let's assume this tachycycle length is the same, and the VA during broad beats and the narrow beat. So
they are also same.
Because this is our slide, so let's take it. They are not changing. Yes sir. I think
इसमें वो खुल सकता है?
printouts में है. They have printouts as well. They have printouts, so we can measure.
साइकिल लेंथ मेजर करो, साइकिल लेंथ चेंज होती है या नहीं?
And I hope everyone has the caliber as well.
Earliest, sorry?
Earliest?
So why looking at the earliest V in wide complex tachycardia? What's the purpose of looking at earliest T? I think it's the A that matters.
So
the
if
most.
it's just it's not diagnostic of anything.
So it's basically there are two concepts. We'll not go into details. There's a global VA and there's a local VA. So they have their own utility, but that is a different concept. So we'll just stick ourselves to the cross V.
लेकिन with the left bundle earliest V दोनों सूरतों में surface या RV apex पर ही मिलेगा. Left bundle के साथ. Right bundle में फिर different हो जाएगा.
Anybody has measured?
Cycle length same
है? And the cycle length is the same.
VA भी same है, cycle length भी same.
So now, does this helps out in ruling out something? So what tachycardia, or which?
This is actually restitution.
Sorry, which issue?
This is actually restitution, because when a tachycardia is going on, it can cause a phase 3 block. But then, as the tachycardia keeps on going on, then the bundle may recover from the block.
So the thing is, I wanted to tell you that which pathway mediated tachycardia.
In that case,
सिंपल चीज़ है. अगर कभी भी ईपी में नैरो कॉम्प्लेक्स के साथ बंडल ब्रांच ब्लॉक आ जाए ना, वीए टाइम मेजर करो. वो कौन सा लॉ है जो अप्लाई होता है इधर टू रूल आउट? इप्सी कुमेल्स लॉ. तो ये कुमेल इसमें अप्लाई होएगा? हो रहा है या नहीं हो रहा? नहीं हो रहा. तो व्हाट डज दैट मीन? अगर चेंज नहीं हो रहा, हाँ, अगर राइट साइडेड एक्सेसरी पाथवे होगा तो नहीं पता चलेगा, लेकिन अगर इप्सी लैटरल उस साइड का एक्सेसरी पाथवे होगा, आपका बीए टाइम बढ़ जाएगा ना. तो वो नहीं बढ़ा ना, तो अब क्या नतीजा निकला है या नहीं?
लेफ्ट तो नहीं है,
इप्सी लैटरल नहीं है. चले, गुड.
हमें यहाँ तो VA टाइम ही बहुत शॉर्ट है, तो हम यहाँ पाथवे क्यों सोच रहे हैं?
This is just a question for the fellows, not. This is just
why you are thinking?
Just a question. This was just a question.
So guys, you understand, if there is a short VA time, अगर septal VA time आपका 0 है और या negative है, तो you're not thinking of Comel's law or thinking of a pathway here, ना?
So in AV and RT किसी भी bundle branch के block होने से VA में कोई फर्क नहीं पड़ेगा.
Although traditional saying is, whenever you see a V on tachycardia, it's almost always AV and RT. There's no need to do maneuvers, but still, You have to prove your verdict.
Measure करें.
Pediatric electrophysiologist कहाँ गया हमारा मोहसिन? वो अभी तुमसे पूछता है.
But this is
not
what I'm
almost.
saying.
This is not always. There is no always. Dr. Amir कहते हैं.
Almost
There
always.
is no always.
Almost always. So this is what we have been taught, that almost always. So, but the point is, if you do not discuss, this
So
will not be
electrophysiologists are very humble.
So this
They
is
can't say always. It should be. So we have to.
AF ablations.
Okay, so
नहीं सही है. कुछ चीजें सिंपल होती हैं. मेरा मेंटल कहा करते थे कि अगर कुछ समझ नहीं आ रही कंसील कंडक्शन बोल दो तो यू तो इसी तरह से व्हेन यू सी द फंड ट्रांसफर सोचो जरूर. लेकिन डॉक्टर यावर का पॉइंट बिल्कुल सही है. इतने नेगेटिव वीए टाइम के साथ you should not be thinking. You need at least 130 milliseconds to be in the accessory pathway. It's a serial activation. A will move out from the V. ठीक है? तो it cannot be on top of the QRS.
okay. So now we have done another maneuver. So if you can see the center of the slide, we have given some extra stim, and now what we are looking for. So if you can see, this is tachycardia going on. We have given a extra stim from RV distal, so it has captured, and this is kind of. So the main purpose is you have to do a his synchronous PVC. So in order to rule out, in order to evaluate for the pathways. So over here, his synchronous PVC was given, but there was no change in the VA interval. It remained the same. It didn't pull in or pulled out.
His synchronous PVC कैसे देते हैं?
हाँ. और कौन सी PVC को कहते हैं कि हाँ इस वक्त हिस रिफ्रैक्टरी है? क्या टाइम होगा उसका?
The time interval. What's the time interval?
Within
for
30
that?
to 50 milliseconds. His.
Within what?
30 to 50.
35 to 55
milliseconds.
So that is the interval. So if you give the extra stim within that interval, although you have to measure the his, still if you cannot measure the his, you can map that out where the most likely the his is.
So you measure the V to his. Yes, isn't it?
Yes, you can measure.
His to, yeah, and then you give 30 milliseconds earlier. 30 to 50 milliseconds.
So for his sickness, you have to see the fusion. So you have to see the fusion when you know about the pace beat and the non-pace beat, your sinus beat. So then you are able to see fusion. So
लेकिन is this the his synchronous PVC जो दी है? Is this the हाँ वो फॉल तो करिए लेकिन
हमारे पास हिस भी है और बेसिंग स्पाइक भी है.
वेंट्रिकल को पूरा या फ्यूज्ड है?
फ्यूजन है.
Fusion.
That's also.
So you have to say fusion.
तो वो
It's captured, yes. So that's why you have to see fusion or you have to measure the time intervals.
So what did the his refractory PVC do?
So this his refractory PVC does this rules out, rules in. So
पहले तो response क्या आया?
response तो
क्या किया इसने?
Response is there is no change.
No change.
It remains.
So does it rule out anything?
So there was no change in the V interval. So this his sickness PVC helps you in the diagnosis or something else. Exclude. It helps to exclude pathway.
कौन सा pathway?
Every pathway. So it not always rules out pathway. So it's always helps in the septal based pathways. The free wall pathways you still have to look for other things. So okay. So
ये PVC जो है हिस्से भी काफी पहले आ जाए and it pulls in the tachycardia by the prematurity. तो उसमें क्या देखेंगे?
यानी हिस बनने से पहले आ जाए.
हाँ.
बहुत लेट PVC.
और घुस
बहुत
जाए.
लेट PVC है.
और घुस जाए अंदर सिस्टम.
बहुत लेट हुई ना सर.
और you're pulling it in, pulling the that single beat के बाद का जो tachycardia उसको pull in कर रहे हो, तो उससे कुछ नतीजा अखज़ किया जा सकता है? वो तो बड़ा
वो तो किसी में भी pre-excitation index के लिए तो हिस रिफ्रैक्टरी होना भी जरूरी नहीं है.
Yes, in this case you have to see the H to H interval as well as the A to A interval. अगर तो pathway होगा तो उसमें उसको हिज से जाने की ज़रूरत नहीं होगी, तो ऑलवेज ए ज़्यादा एडवांस होगा एज कम्पेयर टू द हिज। और अगर एविनाटी होगा तो उसको ऊपर जाने के लिए हिज को उतना पुल करना पड़ेगा।
अच्छा नहीं, मैं वो पूछ नहीं रहा।
अच्छा।
वो तो आपने हिज सिंक्रोनस डाला है, उसमें आप अंदर जाएंगे नहीं जाएंगे, डेक्रीमेंट करेंगे, वो खत्म होगी बात। मैं ये कह रहा हूँ कि आपने वो इससे पहले दिए हिस्से, यानी कि यू कैन गो अप एंड रीसेट ऑन दैट सिंगल बीट। व्हाट विल यू लुक एट? सो मतलब कि उसने एग्जैक्टली इक्वल टू द प्रेमेच्योरिटी टैकीकार्डिया को अंदर पुल कर लिया।
एग्जैक्ट कैप्चर फिनोमेना, कि जितना आपका कपलिंग इंटरवल है क्या A to A उतना एडवांस हो गया है। सो बेसिकली
आपने एडवांस कर लिया है, उसमें रेस्पॉन्स कुछ देखोगे? अच्छा ओके।
एक्टिवेशन सेम एक्टिवेशन है,
सेम एक्टिवेशन। और
so the thing is you have to see the his, whether the his is pulled in or not, and if the A depends upon this who's
खूबसूरती ये है।
अब जो हिज बनेगा वो रेट्रोग्रेड हिज बनेगा, क्योंकि हम हिज बनने से पहले ऊपर
है कि वो 10 पाथवे खुल जाते हैं और हम 10 के 10 पाथवे डिस्कस इकट्ठे ही कर लेते हैं। अगर एक सिंगल बीट ने, सो व्हाट इज एंट्रेनमेंट?
रीसेटिंग ऑफ द टैकीकार्डिया,
रीसेटिंग ऑफ द टैकीकार्डिया परपेचुअली। And if you do it for a single beat, that is a single beat entrainment. So if you send in a premature beat and it pulls in, that means it's entrained for that beat. तो उसमें आप वही देखेंगे, PPI post pacing interval देखेंगे, VHP response देखेंगे, and that should be able to give you quite a bit of information. ठीक है ना? That's a single. अक्सर हम लोग क्या होता है, entrainment कैसे करते हैं? V से करते हैं। आपका VA ब्लॉक हो रहा है at let's say 300 और आपका टैकीकार्डिया 270 पे चल रहा है। You can never entrain it from the V, but you can get into the circuit with a single PVC, and that can give you a single beat entrainment. And the same things you will look at: post pacing interval, VAHP response, and you can have clincher diagnosis actually. हाँ,
और यही वजह है कि हम डेल्टा VA हम निकाल सकते हैं, क्योंकि सिर्फ एक सिंगल बीट एंट्रेनमेंट पे।
और नहीं, और प्री एक्साइटेशन इंडेक्स वगैरह वो सारी चीजें अपनी जगह है, लेकिन ये बड़े सिंपल मैनूवर्स हैं एंट्रेनमेंट के, ब्यूटीफुली डन। आई थिंक entrainment is probably the most beautiful thing in electrophysiology. It helps us across the board.
Thank you for bringing this point out. It's a very important point. So so let's move forward. So now we are giving another extra stem, but to look for some other things. So now we can see.
अब ये कहाँ से दे रहे हैं और इसका रिस्पॉन्स क्या है इस एक्स्ट्रा स्टेम का?
So let me help you out. So now at least we have reached to some of the closest differentials of AV and RT. So to elevate an AV and RT and to rule out with this from another tachycardia, the very closest differential, you give an atrial extra stem and you try to look for something. So what's happening here? So you're giving an extra stem again from CS5-6, and then what you see is whether the next
हमने PVC दी या PAC दी, ये तो बता दें। ये बता दें पहले, हमने क्या किया, PVC दी या PAC दी है? लेट है या अर्ली है?
लेट।
और इसका रिस्पॉन्स क्या है?
Good. So what does this suggest now?
इसने इमीडिएट हिस को पुल इन किया या डिले किया, या जो सब्सिक्वेंट या नेक्स्ट हिज है उसको डिले किया या पुल इन किया? क्या किया उसने? क्या किया? डिले किया। तो क्या रूल आउट हो गया? रूल आउट हो गया, बताएं। और ये मैनुअर हम करते क्यों हैं? Yes, good. So JT rule out हो गया?
So if it was a JT, so will the next B will be reset or not in a JT? In a JT, a next complex will never be affected because it's a focal. So it has to be a re-entrant. This proves it has to be a re-entrant because you're kind of resetting the tachycardia. So this rules out a JT. If there's a pulling in, or even if it terminates as well the next beat because of the delayed conduction. So now we are reaching somewhere. Okay, so
सर एब्लेशन तक जाना भी नहीं है, हम एब्लेशन नहीं करने वाले इसमें। वो वाला पोर्शन नहीं दिखाएंगे हम।
So I think for the sake of time, I'll move forward now.
हाँ, वो वाला दिखा दें पीछे वाला कि how did it happen actually, वो पीछे वाला दिखा दें. ये चलते चलते हुआ.
So these are not my cases.
और हाँ, something happened. Yes.
Something happened over here. You can see the look at the
HRA को देखने,
complexes.
HRA को भी देखने.
So look at the complexes here. So there is something going on. So this is again a very important concept you need to remember. So now look at the intervals.
कहाँ पे? नहीं और पीछे है. नहीं पीछे है. How did it started actually? वो important है. So ठीक है. So अगर हम इस A to A इंटरवल को देखें तो ये यहाँ पर टैकीकार्डिया स्लो है, यहाँ ये फास्ट है. तो हो क्या रहा है, हम पहले देख चुके हैं कि हमारा हिस था, ये A है, ये V है. AH, इस AH को देखें और इस AH को देखें, ये AH छोटा है. तो AV NRT में जो हमारा रेट्रोग्रेड है, जो फास्ट पाथवे से ऊपर जाता है, H to A इंटरवल फेयरली रिमेन्स कांस्टेंट, लेकिन A to H इंटरवल कैन चेंज. सो यहाँ पर यही हो रहा है, A to H इंटरवल चेंज हो गया, टैकीकार्डिया फास्ट हो गया. जैसे ही टैकीकार्डिया फास्ट होता है, हम इंफ्राहीजियन 2-1 AV ब्लॉक में चले जाते हैं. सो दिस इज एक्चुअली हैपनिंग. जैसे ही टैकीकार्डिया फास्ट हुआ, या हम देख सकते हैं HRA to HRA अगर हम मार्च करके देखें तो ये टैकीकार्डिया फास्ट है. अच्छा, फिर उसमें एक चीज़ और कि इट्स नॉट बेसिकली द VA. अगर हम VA को देखें तो VA डिफरेंट है, तो ये थोड़ा हमें अजीब सा लगेगा कि ये तो VA लिंकिंग ही नहीं है. क्योंकि सर जो ब्लॉक है, हाँ, जो ब्लॉक है वो हिस बना रहा है, यानी कि इट गोज टू हिस. हाँ, ये वो हिस बनाता है और स्नीक्स अप द फास्ट पाथवे और ये बना देता है, लेकिन इट डजंट मेक वी. हिस सर अपनी मर्जी का मालिक है, वो आता है तो आता है, नहीं आता तो नहीं आता. अच्छा, इसमें सर डू करेक्ट मी इफ आई एम रॉन्ग. मेरा ये इस ट्रेसिंग के बाद ना मुझे थोड़ा सा कॉन्सेप्ट हुआ कि इट्स नॉट बेसिकली द VA लिंकिंग, इट्स बेसिकली द HA लिंकिंग. हाँ, तो हम, हाँ, क्योंकि उसमें अगर हम देखें तो बिल्कुल VA डिफरेंट था.
So now this is an ECG, so I would like to see the concept here as well.
सर हमारे जो वो है एब्लेशन वाला, हिस वाला 2.5. हाँ, एब्लेशन वाला ही है. नहीं सर, आ जाते हैं सर. हम लेजर भी है. हाँ,
Okay, so now in the ECG, okay, so we go through this quickly. So now we can sometimes, if you're not sure about the tachycardia, you can sometimes see that the tachycardia, the QRS are not that fast. But the thing is, when the patient presents with symptomatic palpitations and when you suspecting AV and RT, so just as we discussed that there can be 2-to-1 conduction. So always try to look at the P waves. So if the P waves is right in between two QRS complexes, so always be thoughtful that this might be an AV and RT with 2-to-1 conduction. So if you can see P waves over here, these are inverted in inferior to lead 2 and lead 3. So any inverted P waves with a right in the center of QRS complexes should always be.
other, because sustained 2 to 1 block in AV and RT, you can, but it's very rare. और ये जो आपने rule बताया ना, if you're seeing a P in a between attack, तो Bick's rule है, and that's can also be for flutter.
हाँ, 80 flutter दोनों में हो सकता है.
P wave, if you're seeing a P wave exactly in between two QRS complexes, then that means there's a hidden P wave within the QRS. So that's Bick's rule. तो ये जिस तरह से बोल रहा था मुझे Bick's rule का वो हो रहा था. So which is fine. So this is a rarer finding. Bick's rule will apply very commonly on flutter, passive flutter. ये जो है या initiation में you get 2 to 1,
yes,
but then they are not sustained. अच्छा आपने ये तो ऊपर से 2 to 1 है, नीचे से 2 to 1 देखा है in AV and RT?
जो upper common pathway block वाला वो वाला?
हाँ, upper common. So that is also, I have seen it actually quite not rarely. So ऊपर से not rarely, नीचे से block मेरे पास हैं भी, मैं दिखा भी दूंगा इंशाल्लाह next वाली उसमें. हाँ, नहीं
वो after ablation हो रहा होता है.
Before ablation.
Okay, great.
Okay, so
first case is over.
Second case open कर
Number 2. So this was an AV and RT, and
so it was just like a platter of AV and RT. We had a lower common pathway block.
No, I
we
think
had
this
a
is
bundle
very
branch
good.
block.
And see, there are AV and RT's bread and butter. Each one of us will do it most of our lives. And so what we need to understand is if, let's say if you're not getting tachycardia to start, likely to be AV and RT. कुछ चीजें होती हैं ना जो AV and RT की उसमें आती है गार्ड में वो, I think that should be put across, and very nice case. पर मुझे एक बात समझ आती है, रेट्रोग्रेड हिज में इधर ही आता हूँ जब भी कैप्स होती है तो उसी में
आप
मुझे
हमारी
नजर
लैब
आता
में
है.
हैं.
हाँ,
आप हमारी लैब में
आना पड़ेगा
फिर
मेरे
आपको बताइए उसमें आप रेट्रोग्रेड हिज मिलता है.
okay, so now this is the second case we are going on to. So he's a 35 years old male who presented with palpitations, and this is the ECG done in the sinus rhythm. So if you can zoom this, please zoom this out so we can see it clearly.
Pre-excitation है या नहीं है?
So just any quick comment so we can move forward after that.
पाथवे हो सकता है. हो सकता है, हाँ, कंसील्ड होगा, हाँ, या बिल्कुल हाँ, लेफ्ट लेटरल होगा.
Okay, so this looks to be a pretty good sinus rhythm. So there is no manifest pathway. Peer interval looks fine. Palpitations, middle-aged man, and this is the ECG done in the sinus rhythm, middle age.
So classically अगर मुझे इसका MCQ बनाना होगा तो I would put AVRT on top of my differential because it's a man, it's a middle-aged man.
Okay.
If it were a middle-aged woman, I would put AVNRT on top.
Very right. Okay, so we'll move forward now. So now you're doing pacing.
यार अब इस पे भी retrograde hiss नहीं दिखाना मुझे. बड़ा depressed हो जाऊँगा.
मैं सर वही देख रहा हूँ. नजर तो नहीं आ रहा.
So what do you think? It's a pretty easy slide. I think those who are used to doing pathways, I think it will be pretty easy for them to understand. So let me talk you through it. So this is a ventricle pacing, and this is the kind of decrement over here. So 270, 270, 260, and then I'm not sure.
I think इसमें इतना इस वाली
kind of
slide में
decremental
कुछ खास
pacing
नहीं
going
है.
on. So what we are seeing is, so if you can appreciate the activation, so how is the activation looking like? Is it concentric or is it eccentric? So it's an eccentric activation. And which site is the earliest to be activated? CS12 is, so it's a distal to prox activation. So it's an eccentric activation, and now.
So what I would do at this point in time is I would try to deep throat the coronary sinus so that I could bracket the, then it will make my life easy.
Exactly.
For.
So the question here arises, every time when there's an eccentric activation, does this rules out AV and RT? It's a very important concept. So although we are just kind of always have in mind that whenever there's eccentric activation, AV and RT is unlikely, but that's not the case.
It doesn't, because AV and RT can also have left-sided extensions.
Exactly.
And that is being preferentially used. तो आपको 5-6 तक तो आ सकती है. हाँ 1-2 तक जाना जरा relatively मुश्किल है.
So it It rarely occurs because it all depends on how the retrograde activation is looking like. So if we have done so many ablations previously, so there's a kind of conduction block and then the pattern changes. So it's always do not rule out AVNRT, always look for AVNRT if you have previous history or any previous nodes.
And for fellows also, when you deep throat the catheter, mark it on the trace. Because once the study is done, you do not have the fluoroscopic images, you do not know where the catheters are. So always leave a note.
Yeah, sure. Okay, so now let's move forward. This is now a ventricle extra stim testing. So again here we can see, so at cycle length 600 millisecond.
Is it 600 or 500?
I think it's 600. Sorry, 500.
500.
500.
So I would ask you, if I would ask you that why not pace as slow as possible, as the native allows, because उसमें हो सकता है VA conduction हो, and the moment you go faster, तो let's say अगर 700 या 800
हो सकता है शायद patient का उसको grade 550.
Okay. I think traditional way is to start from 600 milliseconds.
No, standard way is. But if let's say my heart rate is 900, तो उसके ऊपर फिर then I can start at 700 or 800 even. And I've seen a lot of times कि वहाँ हल्की सी VA conduction आती है. Always good to know whether there is VA conduction.
Sure. Exactly, very right. So, so at 500 millisecond, so you can see again eccentric activation. So we have now given an extra stim at 270 millisecond, and the pattern activation remains the same. So it's around
almost कोई 100 यानी कि 600 मिलीसेकंड तक ही होगा हार्ट रेट इसमें.
So okay, so now this is again a very important slide.
अब ये इनको बताने दें.
So
अब इनको बताने दें please.
I think most of the time the hiss helps you a lot. If you get a hiss, good hiss, I think a lot of things are cleared out.
चलें जी फेलोज प्लीज बताएं क्या हो रहा है. बताएं एक तो पहले प्रोटोकॉल क्या है, कहाँ से पेश कर रहे हैं और ऑब्जर्वेशन क्या है. जल्दी जल्दी बताएं अगर जल्दी छुट्टी चाहिए तो.
So I'll help you in this. So
नहीं हेल्प नहीं करें. माइक टेबल पर है. सिंपल है. डॉक्टर माहिन ट्राई कर सकती हैं.
The aim is whenever you give an extra stim, you need to block something and you need to go through some other route. So that's the main purpose of doing extra stim. So you have to clear this out whether this is going through the node or a pathway. These are the two possibilities.
इससे पहले जो हमने एक्स्ट्रा सिम ली थी वो एट्रिया में जा रही थी और अर्लीस्ट एक्टिवेशन हमारी CS12 में थी. हम जब थोड़ा और अर्ली हुए तो अब क्या हुआ?
पहली वाली तो CS12 पे अर्ली है. ठीक है. एंड सेकंड वाली में
दो बड़े बड़े रास्ते हैं वेंट्रिकल के इम्पल्स के पास ऊपर जाने के लिए.
नहीं तीन भी हो सकते
हैं. वैसे तो बहुत सारे भी हो सकते हैं. बहुत सारे भी हो सकते हैं. टू कीप इट सिंपल दो तो हैं इस केस में जो हमें पता है.
So let's
और बल्कि सर वो जो दूसरा है उसके भी नीचे दो है.
डिप्रेशन की बात ये है कि तुमने VA कंडक्शन दिखाई नहीं हमें, मतलब एक्सेस मतलब नॉर्मल वाली VA कंडक्शन.
सर वो दिखा ना VWC किया था.
नहीं ये तो शुरू से एक्सेंट्रिक है और अभी
So इसमें एक कॉन्सेप्ट है सर, आगे वो मैं डिस्कस करूंगा. So we'll discuss that in further.
नहीं मुझे सिर्फ ये चीज हो रही है कि ये जो स्क्विगल आ रहा है ये मैं बता देता हूँ कि हिज है. मैं क्योंकि रेट्रोग्रेड है जिस पे सलाम भी किया मैंने. अब क्वेश्चन ये है कि आपका एक्सेंट्रिक ड्राइव ट्रेन के ऊपर ब्लॉक हो रहा है, एक्सेसरी पाथवे ब्लॉक हो गया, लेकिन वो नीचे से हिज तक जा रहा है, नोड भी ब्लॉक हो गया.
नोड भी ब्लॉक हो गया
लेकिन आपने हिज तक फिर भी आप पहुंच गए.
तो यहाँ पर तीन चीजें ब्लॉक हो रही हैं. राइट बंडल, नोड, पाथवे. तो हम ट्रांसेप्टली लेफ्ट बंडल से ऊपर जाके हिस तक चले जा रहे हैं लेकिन हिस से ऊपर नोट हमें नहीं जाने दे रहा. सर वो क्योंकि वो सेपरेट आउट हो गया ना, हिज सेपरेट आउट हो गया वी से, so इसलिए हम राइट बंडल पे रेट्रोग्रेड ब्लॉक हो चुके हैं. His. So again I retrograde his. सर ये सच में सर इसके बाद वाली साइड देखिएगा, उसमें फिर से जाएगा.
सर इट्स वेरी अनलाइकली कि अगर ये ए होता तो और कहीं पे भी ए नहीं है, तो इट्स वेरी अनलाइकली कि जस्ट यहाँ पे ए क्यों रिकॉर्ड कर रहे हैं, कहीं और भी हमें ए नज़र आना चाहिए. So the thing is that we have blocked the pathway, we are seeing a haze, but we are seeing no retrograde conduction through the node.
So this
it
is
has blocked.
VART as well.
So I think.
Yeah, I must say that I had never seen a retrograde haze before the last 4 years at NICVD, and I think it has a lot to do with people looking for it. And the other thing is, I think the system is actually really good at picking it up. So I think there are some system capabilities also. So वो बात ये है कि सिस्टम बनाया हाइंस वेलन का बनाया हुआ सिस्टम है.
So just one question.
Distal.
Proximal में look at this.
नहीं उस पे एंटीग्रेड में नहीं है ना.
I think this is a very tiny spike.
हाँ,
very tiny
वो
spike.
दोनों में नहीं है. इनफैक्ट एंटीग्रेड रेट्रोग्रेड दोनों में नहीं है. तो फिर वही कांटेक्ट का इशू है.
Not sure, but this looks to be up.
हाँ नहीं वहाँ पे नहीं है. हाँ. अच्छा उसके ये वाली स्लाइड में बताएं जरा.
Again, slide with so many
ये इनको बताने
concepts.
हैं. हाँ इसको बता. इस स्लाइड को तो फेलोस को बताना चाहिए. प्लीज बता दें.
I think you have to choose someone because.
Choose someone. इंतजार ट्राई करना. पहले स्टेप पे तो आ गए ना. रेट्रोग्रेड राइट बंडल ब्लॉक हो गया था.
Yes.
फिर क्या हुआ?
What was the timing for the previous extra stem?
So it's 260.
ये 260 पे था इस पे.
It's not 250.
So उस 260 पे we had 3 blocks. राइट बंडल ब्लॉक हुआ था, नोड ब्लॉक हुआ था और पाथवे ब्लॉक हो गया था. अब हम और अर्ली कर रहे हैं.
So there is bundle branch re-entry if you look at that. So
Good.
block in node, then again V and followed by then again retrograde conduction.
इंतजार दोबारा बताना.
So I'll help you in this. So let's start from here. So we have got we are doing a ventricular pacing.
Yes.
So we are getting a retrograde conduction.
Followed
it looks
by-
to be an eccentric, right?
Yes.
And then something happens here. So again an extra.
एक ही मिली है.
Again an
Extra एक है, extra एक है.
एक्स्ट्रा सिम एक ही मिली है.
Again capturing here. So again it is capturing over here.
So
And
extra
then
bit.
Look at antigradely now.
हाँ सही कह रहा है बिल्कुल.
So that extra has captured V, and as we discussed, there's right bundle branch block, इसलिए कि VH separate हो गया है.
Good.
उसके बाद there is another V. So that shows कि there is re-entry in the bundle branch.
Good.
And then after that there is retrograde. Maybe.
अच्छा इंतजार यहाँ तक बड़ा अच्छा कर लिया कि वो राइट बंडल में ब्लॉक हुई, ट्रांसेप्टली गई, लेफ्ट बंडल से ऊपर गई, हिस तक चली गई, उसके बाद दोबारा राइट बंडल से नीचे वी में आ गई.
Yes.
और ये क्या ऊपर एट्रियम में गई या नहीं गई?
दोबारा लगता है नहीं ये नहीं गई.
नहीं गई ना?
नहीं गई
क्योंकि ऊपर ही नहीं बना.
Yes.
अभी भी इसको नोड रिफ्रैक्टरी में
Node
मिला
पे block
और
हुआ
पाथवे भी रिफ्रैक्टरी पीरियड में मिला. तो अभी वो घूम के वापस नीचे आ गई है राइट बंडल से वेंट्रिकल में.
Yes.
ठीक है, फिर क्या हुआ?
So उसके बाद so it went up. अब यहाँ देखें atrial activation is again early at distal CS, so that shows that it is not a sinus beat. So again नीचे से ऊपर गई है and then HRA तक.
Good.
And उसके बाद it came back.
गुड, वेरी गुड. जो वो नीचे आई थी फिर वो पाथवे से ऊपर चली गई.
Yes.
फिर उसके बाद वापस नीचे आई या नहीं आई?
वापस नोट से आई है.
Good.
Because we can see his there.
Good. जबरदस्त.
Excellent. Great, excellent.
Do we have could you see a hiss in the antegrade hiss नजर आ रहा है?
Yes sir, आ रहा है.
Yes sir,
आ रहा है. डॉक्टर से जरा पॉइंट आउट कीजिएगा.
So you want?
हाँ. है. एंटीग्रेड पॉइंट आउट कर दीजिएगा डॉक्टर साहब.
छोटा सा W जो है वो A है और H बहुत
ये
बड़ा
है. एंटीग्रेड H ये A है.
Nice job, Indra. Very good. मैं तो इतने सारे बीज देख के घबरा जाता हूँ actually.
Okay, so this is now just showing right bundle over here, nothing of any significance. So now let's move forward with this. So we have got a run of some tachycardia with a right bundle branch block. Okay, and you see a one-to-one VA conduction, and the active. I think probably it's been. Any ceremony. Next slide is this.
So again, if we look at first beat is sinus, went via AV node, second is sinus, third is APC, and it went with prolonged AH interval to the V and came up with via the pathway. So it starts tachycardia. So wide complex tachycardia because there is right bundle branch morphology. So this is likely orthodromic AVRT with right bundle branch block.
So एक PAC से spontaneously induce हुआ है. ठीक है. Surface to 1 2. HRA पे हाँ देखेंगे तो लॉन्ग है. Earliest पे तो फिर
डिस्टल है.
अच्छा. And left sided atrial tachycardia. और एक और था जो शुरू में. हाँ लेफ्ट रेनियन जो है इम्यूनिटी का वो भी हो सकता है. और एक और मगर बायस्टैंडर नहीं. रेट्रोग्रेड बायस्टैंडर में ये तो नहीं मिलेगा. हाँ. क्योंकि वो जब तक वो नीचे जाके ट्रांसेप्टली क्रॉस करेगा उससे पहले फास्ट पाथवे से ऊपर निकल जाएगा. हाँ उसमें एग्जैक्टली उसमें रेट्रोग्रेड नहीं होगा. बिल्कुल. सो उसमें हमें प्री एक्साइटेड एवीएनआरटी मिल सकता है. बिल्कुल बिल्कुल. सो डॉक्टर यावर इज आस्किंग कि ये एवीएनआरटी है और क्या पॉसिबल हो सकता है कि एवीएनआरटी के साथ हमारे पास एक रिट्रोग्रेड बायस्टैंडर्ड लेफ्ट फ्री वॉल पाथवे हो. तो क्या हमें उसमें इस तरह की एक्टिवेशन मिल सकती है या नहीं मिल सकती? AVNRT retrograde conducting right or left free wall pathway. क्या उसमें एक्टिवेशन ऐसी मिलेगी या नहीं मिलेगी?
Because ventricle is not part of the circuit in AVNRT, so it is not possible.
हाँ तो eccentric activation is only when you go from retrograde up. AVNRT में circuit is above the तो bystander pathway जो है antigrade जब उसका ऊपर होगा तो वो नीचे जाएगा with pre-excitation. You'll be pre-excited but you will be even AVNRT. But retrograde या concealed में ये चीज़ नहीं आएगी. Because it's below that level.
वहाँ तक पहुँचने से पहले वो ऊपर जा चुका होगा.
नहीं इसमें शॉर्ट कहाँ है? वो आरवी को आप आरवी को देख रहे हैं. आप करीब आ जाए ना आगे आ जाए. वो तो लोकल इलेक्ट्रोग्राम बता रहा है ना उधर.
यानी सरफेस से आप सरफेस की वी से आप
अगर आप सरफेस लेंगे ना तो सरफेस बहुत पहले से स्टार्ट हो जाती है।
हम भी देख लें।
ये इन्होंने मेजर
नहीं सर मेरे ख्याल वो सामने से ना वो पता चल रहा है, वो सरफेस की वी से अगर हम लें तो वो है लेट ही है।
वो लोकल वीए है।
अच्छा एक चीज़ और कि आउट ऑफ द कॉन्टेक्स्ट यानी इसमें अगर इस पेशेंट में लेफ्ट बंडल ब्रांच ब्लॉक हो जाए तो हमारा सरफेस से जो वीए है वो तो प्रोलॉन्ग हो जाएगा, लोकल वीए प्रोलॉन्ग नहीं होगा।
नहीं तो मतलब कि राइट और लेफ्ट दोनों बंडल
नहीं।
अच्छा
हाँ अगर एक पेशेंट है इसको ओआरटी होता है और लेफ्ट रिवॉल्व पाथवे है और अगर उसको लेफ्ट बंडल ब्रांच ब्लॉक होता है तो सरफेस से अगर हम टाइम करें वीए को तो वो तो प्रोलॉन्ग हो जाएगा। इट हैज टू गो डाउन द राइट बंडल मेक अ क्यूआरएस ट्रांसेप्टली फिर वो बनाएगा ये, तो ये तो प्रोलॉन्ग हो जाएगा,
सर्किट बड़ा हो जाता है,
सर्किट बड़ा हो जाएगा। लेकिन जो हमारा लोकल वीए है CS12 का वो सेम रहेगा, इट शुड बी सेम।
नहीं लोकल वीए तो आप साथ साथ पढ़े नहीं, वो नहीं बढ़ेगा।
हाँ वो
ये
नहीं
बढ़ेगा ग्लोबल वाला ऊपर से जो आप बर्ड्स आई व्यू देख रहे हो, बिकॉज उसमें पूरा सर्किट जो लोकल वीए है वो तो साथ साथ पड़ेगा ना नेबर्स, तो वो तो उनको उसको फर्क नहीं पड़ेगा।
लेफ्ट बंडल के साथ होगा ये, हाँ क्योंकि लेफ्ट बंडल के साथ होगा ये कि सरफेस का क्यूआरएस जो है वो तो राइट बंडल से बन जाएगा और जो वहाँ का जो बन रहा है वो ट्रांसेप्टली जाना के उधर का वी बनाएगा, तो हमारा सरफेस के वी से वहाँ का जो वी है वो भी टाइम लग जाएगा। अच्छा इस तरह अगर हम एवी नाटी में देखें तो इसका बिल्कुल उल्टा हो जाएगा। एवी नाटी में अगर लेफ्ट बंडल ब्रांच ब्लॉक हो गया तो फिर क्या होगा कि हम राइट बंडल से नीचे आके वी बना लेंगे और वो फास्ट पाथ पे से बना के बनाएगा,
ज्यादा फर्क नहीं पड़ेगा।
हाँ, तो उसमें जो सरफेस से वी है वो हमारा सेम रहेगा। लेकिन जो लेफ्ट बंडल का अगर CS12 पे अगर हम देखें तो उसमें इट कैन बी नेगेटिव, क्योंकि हमारा ए पहले बन के वहाँ ए बना देगा, हिस्से ऊपर जाएगा फास्ट पाथ पे से पहले 1-2 में जाके ए बना देगा, दिस वन हैज टू गो डाउन राइट बंडल ट्रांसेप्टली फिर जाके बनाएगा, तो वहाँ हमारा वी नेगेटिव हो जाएगा।
Okay, very nice discussion. So we'll move forward with this. So
ये क्या था?
We are facing from HRA now, and what we can see is you can see still a right bundle over here.
बताना है माइक यू हैव द माइक।
Atrial extra stim first drivetrain at 500, A is conducted, AHV is seen. Then when extra stim at 250 is given, again A, H and V is seen. Then the tachycardia is initiated.
एक्स्ट्रा स्टिम से पहले CS में क्या हो रहा है? एक्स्ट्रा स्टिम आई है या
एक्स्ट्रा स्टिम 250?
एक्स्ट्रा स्टिम 250 है ना?
हाँ
उससे पहले V है ये।
CS में देखें आप एक्स्ट्रा स्टिम से पहले क्या हो रहा है?
सब AV कंडक्ट हो रहा है ना, AHV है ना, सब पहले में AHV and then again AHV and that V initiated the tachycardia, retrograde A बना है फिर।
ओह नहीं एक अच्छा पॉइंट वैसे।
What about that A that which is after extra stim?
So the thing is, look at this, the cycle length. It's 500 and it's almost half of that. So you're giving 250 a very shorter cycle length. So what happened here? Look, A to H interval has been grossly increased.
Yeah. It has prolonged.
Okay, and then it got some time for the retrograde conduction to occur.
Yes.
And that again went eccentrically. And then again it came down antegradely in a tachycontinental. Okay. So
हाँ मेरे ख्याल पुल आउट हो गया होगा। हाँ टैकीकार्डिया में वो बिल्कुल ब्रैकेट किया हुआ है। हाँ कैन बी पुश
bracketing. Very right. Very right. So this is just showing a tachycardia, eccentric 1 to 1 conduction. This is the morphology during the tachycardia.
हाँ,
Because we had a right bundle.
एक व्यू देखने में कुछ एंटीड्रोमिक जैसा लगा था V1 को देखते हुए.
Okay, so now again we gave something over here and we found up. Now again same concept as we discussed before. When you gave us PVC and to his synchronous.
इसमें तो आपको eccentric activation मिल रही है तो बड़ा आपको sort of idea हो गया है. Let's say कि concentric activation होगी with a relatively longer time. How would you differentiate it from ventricular tachycardia? तो कोई maneuver कर सकते हो?
सर दोबारा से बताइएगा.
सर ये atrial pacing करेंगे तो क्या होगा? Excellent. ठीक है. वो उल्टा जिस तरह से
Good.
response है उसी तरह उल्टा response हो जाएगा वो VAA. We have to entrain it from the VAA. So that's a very good maneuver.
Then we can
Described by my senior fellow. I'm an author on that paper also. Pace में I think सब आएगी. So do read that.
AVVA.
is for ventricular tachycardia. AVA is for
Antidromics, ORTs.
हाँ नहीं वो सारा ये when you got a wide complex tachycardia हम narrow में नीचे से कर देना wide को ऊपर से कर सकते हैं. If you can get one-to-one conduction in brain then it's a very easy, simple and nice maneuver to follow.
सर इसमें मेरे ख्याल में शायद मेरे ख्याल में बंडल ब्रांच के एंट्रेंट में AVA है ना, क्योंकि वो हम जब पेस करेंगे तो हम नीचे जाएंगे बंडल पे और वो बस घूम कर ऊपर आ जाएगा. हाँ बीटी के लिए फोकल बीटी जैसे हमारे पास है. हाँ जस्ट लाइक हम 80 को ऐसे करते हैं VAA रिस्पॉन्स.
So this is a ventricle overdrive pacing during a tachycardia at cycle length of 260 millisecond. And now what you can see over here, so it's left bundle morphology. And when you're doing a ventricular pacing, you have to measure few things. So this helps you in differentiating off from the AVNRT and AVRT. So what you would like to see here, so you always have to measure the VA intervals. You see the atrial resetting and you see the fusion. So these are the things which you have to see when you are resetting a tachycardia or doing a ventricular overdrive pacing. So look at the first beat. So what do you think this beat is? It's a kind of fusion beat because it is pretty narrow as compared to the wide complex. Okay, so now you have to see the next A. So is there any change in the next A, any change in the atrial activation sequence or the VA timing?
No,
it looks
there
the
is
same.
no change. Yeah, there is no change.
So if you are not changing the activation sequence and you are progressively fusing, then it's diagnostic.
Of ORTs, yes.
Okay, so even AVRT there will never be a fusion. So whenever you are producing a fusion, so then this favors.
क्योंकि हमें AVNRT के सर्किट में जाने के लिए हमें पूरा वेंट्रिकल को पेस करना ज़रूरी है. हम फ्यूजन के साथ AVNRT के सर्किट के अंदर जा ही नहीं सकते. और इसमें हम ड्यूरिंग ट्रांजिशन जोन हम सीधा चले जाएंगे इसके अंदर. हाँ एग्जैक्टली ठीक है.
Okay, so now again we have given an extra stem from V. So any important findings over here? So now we have to measure again the VA intervals. So look at the VA intervals during a right bundle and during the extra stem from the ventricle, right ventricle. So is there any change in that? The activation remains the same.
टैकीकार्डिया के दौरान हमने एक हिस्ट रिफ्रैक्टरी PVC दी है. आई होप इट्स हिस्ट रिफ्रैक्टरी. हाँ हिस्ट रिफ्रैक्टरी है. ठीक है. फिर क्या हुआ? इस हिस्ट रिफ्रैक्टरी PVC ने क्या किया?
So So if you can measure
क्या
this
किया?
interval, look at the. So
ऊपर गई?
Look at this V interval and
फिर
look
क्या
at
हुआ?
this V interval. So what do you think is happening? If you can measure that in your printouts, so you'll find there's something happening. Doesn't it look to be a bit prolonged?
Which one, Dr. Sir? कौन सा कह रहे हैं?
अच्छा, let's say कि you have this tachycardia and you put in a refractory PVC and it pulls in the tachycardia.
हाँ.
So it's his refractory PVC.
कुछ differentiate नहीं किया
in
हमने.
the next A.
हाँ.
Does it mean that it's mechanistic of the tachycardia?
No.
Because now you have blocked the node. So anything which is resetting the tachycardia, it has to go through a pathway. So that's the purpose of doing a His synchronous, because you want to.
No, my question is, there will be three responses, like the neutral response होगा,
कुछ भी नहीं होगा.
reset कर देगी, मतलब कि pull in करेगी, और एक delay करेगी, और फिर terminate कर देगी.
Exactly.
Without changing the
Without changing.
तो उसके लिए मैं पूछ रहा हूँ आपसे कि अगर आपको result मिलता है कि it pulls in.
No, this doesn't help too much. Or the best thing is it has to delay or either terminate.
Yes.
Terminate is the best thing. If you terminate with a PVC, this is definitely intrinsic to that tachycardia and not a bystander.
Yeah, I think these are very excellent maneuvers and you need to read through them. So अगर आप वो pull in कर लेगी, it means कि the bystander accessory pathway can be a bystander.
और
अगर वो उसको delay करेगी या terminate कर देगी, then it means that it's mechanistic of the tachycardia. So
और सर termination में भी फिर ज़रूरी है कि वो A में जाए बगैर terminate कर दे.
हाँ हाँ, बिल्कुल बिल्कुल.
क्योंकि वरना वो 80 भी हो सकता है.
Otherwise atrial tachycardia को भी कर सकती है. बिल्कुल सही है.
So
ये सारे लोग appreciate कर रहे हैं पीछे या मैं अपने से बातें कर रहा हूँ? सारे दोबारा बताओ खड़े हो के आवाज़ें बुलंद और clearly.
मेरी आवाज़ तो आ रही है ना? सही है. तो अगर हम हिस रिफ्रैक्टिव पीवीसी दें, उसके 3 रिस्पॉन्सेज हो सकते हैं. या तो वो ए को रीसेट नहीं करेगा, जिसको हम नो चेंज कहते हैं, या फिर वो ए को एडवांस कर देगा या डिले कर देगा, या इट कैन इवन टर्मिनेट द टैकीकार्डिया. सो एडवांस अगर करता है तो इट डजंट मीन एनीथिंग. अगर आपके पास एक बायस्टैंडर्ड पाथवे है और बस ये बता देगा इट्स अ बायस्टैंडर्ड पाथवे, इट्स पार्टिसिपेटिंग और नॉट, ये कुछ नहीं बताएगा. और अगर वो डिले कर दे विद द सेम एक्टिवेशन सीक्वेंस, तो इसका मतलब है कि हाँ वो ORT है और वो जो भी पाथवे है वो पार्ट ऑफ द सर्किट है. और लेकिन वो टर्मिनेट अगर करता है तो उसके लिए फिर देखना बड़ा ज़रूरी है कि क्या वो ए में जाकर टर्मिनेट करता है या एट्रिया में पहुंचे बगैर टर्मिनेट करता है. तो अगर एट्रिया में पहुंचे बगैर टर्मिनेट करता है, इट्स मोर सजेस्टिव कि ये ORT है. लेकिन अगर वो एट्रिया में गया और फिर जाके टर्मिनेट किया तो इट्स स्टिल पॉसिबल कि वो वहाँ पर एक AT का फोकस था और उसने जाके उसको टर्मिनेट कर दिया. सो दैट्स और एक्टिवेशन सीक्वेंस शुड बी सेम ऑल द टाइम.
अच्छा, वो जो एडवांसमेंट वाली जो बात थी कि थियोरेटिकली वो बिल्कुल सही बात है कि इफ द टैकीकार्डिया एडवांस, बट इफ द टैकीकार्डिया एडवांस विद द सेम एक्टिवेशन सीक्वेंस, मतलब उसमें फिर कोई और चीज़ होना बहुत हाईली अनलाइकली होता है.
चांसेस हैं जहाँ आपका AT का फोकस है वहीं
एक चांस है कि वहीं पे ही एग्जैक्टली आपका AT था जहाँ पे आपका वो पाथवे था. तो
वो मैं इस पे एक बात कहूँगा कि सो ये सारी की सारी जो सिचुएशन है ना, ये उन्हीं रेयर केसेस के लिए है. बिकॉज अ लॉट ऑफ टाइम यू सी एन एक्सेंट्रिक सीक्वेंस, आप ट्रांससेप्टल करते हैं बगैर कुछ किए. लेट्स से उस पेशेंट की कॉम्प्लिकेशन हो जाती है और लिटिगेशन हो जाती है, और जो अपोजिशन का लीडर कह रहा हूँ लॉयर है, वो आपसे कहता है कि आर यू श्योर यू हैव नॉट एंट्रेन्ड द टैकीकार्डिया, was it an atrial tachycardia? तो फिर आप फंस गए आप.
I'm just saying for all the practical purposes, but this is I heard a lecture of George Klein and मतलब he was very confident. और मतलब फिर हम जितना भी देखते हैं, मैंने आज तक मतलब
नहीं, आप सही कह रहे हो, आप सही कह रहे हो, उसमें कोई वो नहीं है दो बात. बट ये है कि जो बेसिक प्रिंसिपल्स हैं वो याद रहने चाहिए, ताकि जब आप वहाँ खड़े हो रहे हो आप किताब नहीं खोलेंगे. और इसी तरह से कि अगर हमें पता है कि शॉर्ट VA टाइम है, अबलेट कर दो. इट इज़ द सिचुएशन वेयर यू हैव टू डिफेंड द केस आफ्टरवर्ड्स, दैट यू शुड नो कि मैं ये चीज़ कर सकता था, उसका ये रिजल्ट आता. वहाँ खड़े होकर आप बोल सकते हो अगर आपने किया होगा मैनूवर.
एक्स्ट्रा स्टेम दिया, उसके बाद ए जो है ना पुल इन हो गया. कुड द नेक्स्ट बीट विल हेल्प? या
सिंगल बीट ना,
या नेक्स्ट बीट उससे.
यानी QRS जो बना वो
आपने एक्स्ट्रा स्टेम दिया, A पुल इन हो गया, द नेक्स्ट टैकीकार्डिक B
विल हेल्प। V की बात कर रहे हैं ना, नेक्स्ट V पुल इन हुआ या नहीं हुआ?
A.
So the thing is, whenever you give an extra stem, so there are rare cases in which, although with an eccentric activation, this can still be 80, but the place from putting in the extra stem, the pathway is right there. So if it changes the next beat, the one beat which you have given extra stem, the complex is made. But the next complex, if it reset, this shows that you have entered into the circuit of tachycardia, because in no space you can reset the next beat. The same concept of the JT. So to differentiate the JT from the AV and RT. So if you give a late APC and it resets the next beat, so how come it resets? Because the next firing has still not been made. The same concept applies here. But still the rare cases of AT, eccentric activation, the left free wall ATs, the bystander sometimes. So you can pull in with the same activation sequence, but you have to see the resetting. The resetting is a very important concept. So you always have to see the next beat as well. Not
all these maneuvers have to be done very cleanly. If you do a dirty maneuver, then you cannot. फिर वो हिलेगी चीज़ें, अगला रीसेट हो जाएगा, पर समझ नहीं आ रही होगी. Sometimes ऐसे maneuvers में आप catheters move कर देते हैं, उससे हो जाती है. Only read the results when the report is very clean.
One more important point, you always have to be sure that tachycycle length is stable. Because if there's a wobbling in tachycardia cycle length, sometimes you can erroneously diagnose that resetting, although there's a very grossly change in the cycle length. So you always have to be pretty sure the cycle length is not changing. I think this is for all, so thank you very much. So if there is any other questions, you're most welcome.
तुम्हारी ablation की choice क्या होगी? Will you go retrograde or antigrade?
So if you can see, in this case, I will definitely like to look at the, and I will try to look at the antigrade, whether it is manifesting or not. So in this, I couldn't find any antigrade. So it will always have to do a retrograde in this case. So the one which I have been trained for is a retrograde aortic approach. I have not been trained on any transseptal. So
नहीं आप atrial और ventricle pacing की बात कर रहे हैं ना?
हाँ, मैं कह रहा हूँ कि आप ablation की approach आपकी क्या करोगे?
So it's a retrograde. You go transaortic, you map. You have to take a larger curve mapping.
But देखो retrograde जा रही है. You can map from the antigrade approach also, ना?
Yes, but
कर तो सकते हो.
Yes, these are both approaches. But since I have been
supposing retrograde fail हो जाती है, फिर
so
नहीं कर सकते retrograde में. सारे तो नहीं कर सकते ना 100%. So would you go for antigrade?
Yes, the thing is for an antigrade, so the point is where you are targeting. So if you are targeting a V, the antigrade will be a good option because you're close to that. And if you are targeting retrogradely, you have to find the earliest day. And for that you have to go.
नहीं
वैसे सर सक्सेस के चांसेस
मैं तुमसे सिर्फ पूछ रहा हूँ वैसे
में ज़्यादा है.
मैं सिर्फ तुमसे पूछ रहा हूँ वैसे कि तुम्हारी चॉइस क्या होगी इसके बीच में?
I think the way which makes you feel easier, I think go that way. So the things which you have done a lot.
हमें तो हम लोग को ट्रांसेप्टल इजी लगता है.
So don't
transseptal easy नहीं है, retrograde easy है. Going through the aorta, whole length of aorta, turning around,
देखिए जो
tricuspid valve,
जिसको मैनूवर करना है ना वहाँ से, वो मुझे बड़ा मुश्किल लगता है.
I think
I'm just joking. नहीं असद ये you are seeing Azam Shafqat sitting over here. नहीं but नहीं असद को मैंने एग्जामिन किया था. He is an outstanding person. So नहीं मैं तो वैसे पूछ रहा था अप्रोच तुम्हारी क्या होगी. रेट्रोग्रेड करो, बिल्कुल सही है.
Although it's quite difficult, but I think we have done that a lot. So
मैं कभी फंसा तो आऊँगा तुम्हारे पास.
Thank you. So most welcome, sir. Thank you so much.
With this, we come to the end of today's session. Before we conclude this session, we'd like to have Dr. Amir, sir, for shield distribution. We're going to have a shield distribution for Dr. Sarim and Dr. Asad. Dr. Sarim, would you like to step on for your shield?
से ज़्यादा वो अच्छा है, वो स्केल बहुत बेटर है। हाँ दोनों मैडम दोनों प्रोवाइड कराएं। जी जी वही स्केल है, लेकिन मुझे ना अभी तक वो 80 जो डिले होकर जो टर्मिनेट हो रहा है ना, सीरियस नहीं वो अभी तो you're lucky कि
Dr. Asad?
बुला दो अब चलो घर जाना है, मेरी से बाय रोड फ्लाइट है, जब नहीं चाहे वहीं था चाहे मुँह चमा से क्या
Before the computer,
वो मैं उस पर कह दूँ, आप लोग मुझे वैसे ही तंग कर रहे थे रेट्रोग्रेड के ऊपर कि ट्रांससेप्टल भी कोई ऐसा नहीं होता। मेरा वन ऑफ माय मेंटर्स ही यूज्ड टू डू ट्रांससेप्टल, तो सुई बाहर नहीं निकालता था, वो मलता रहता था उसको। तो जब दूसरा वाला मेंटर आया उसने कहा व्हाट आर यू डूइंग, कहता है आई एम ट्राइंग टू फाइंड अ पेटेंट फॉर अ मिनोवाली। उसने कहा नो यू आर डूइंग ब्लड डिसेक्शन।
Before the concluding remarks, we would like to pay a token of appreciation to our corporate partners. For that, I would like to call Dr. Ghazala to pay a token of appreciation to Getz Farm. Do we have a representation of Getz here?
सर्टिफिकेट दे दिया है इस पे अपना
यही दे देना।
ये कितना बड़ा दिया था मैं रखा हुआ दिया था तो वो दिया वो जो करते कौन लगे ये मुझे वो डिले करके 80 वाला मुझे मैकेनिज्म नहीं समझ में। ओ भाई उसने कहा कि डिले हो गया तब भी समटाइम वी कैन।
Next, I would like to have a representation of Farmivo.
नहीं लेकिन अगर ए बना के करने लेट हो गया तो इससे कि 80 रूल आउट नहीं होता, ऐसे कैसे होगा? वो अब मैं जा रही हूँ क्योंकि वो इट्स टाइम टू लीव।
Johnson & Johnson.
Johnson & Johnson.
Do we have someone from Johnson & Johnson? Johnson & Johnson, Mohammad Akram. Next is going to be our corporate partner, IQ. We have a people from HiQ, Boston Scientific, Crosons, HiQ. Thank you. presentation from Boston Scientific. Next one is going to be Sami. Next is going to be Sami Farmer. Before we end, we would like to have a closing remarks from Dr. Amir. As Park HR is president, I'd like to have a closing remarks, then we're going to close officially this ceremony.
Thank you. These are my first remarks as president of Pakistan Heart Rhythm Society. So it's a landmark thing. I believe that this was a fantastic event. And I'm very happy to see that people, EP is really growing, because when, I don't know, it was 20 years ago, when I went to Pindi to be with General Imran, that was the time we used to sit and, he used to drink a lot of tea at that time. Now he is very well controlled. And we used to work till very late. And in a month's time that I was with him, we did about 65 cases. And there was a lot of intellectual layer. So, and it's very heartening to see young people, you're at a different level. When we started, EP was just evolving. But what at least pulled me towards EP was the intellectual lure. So I still would tell all the young people that, it is look at it as a subject. It's not a procedure. If you know your subject, if you have a gun and you know the terrain, and if you've studied the target, you will be a good hunter. But if you just rely on the gun and don't look at the terrain and do not know your subject or your target well, you will not flourish. When I went in, General Imran, he's my inspiration. He is not only an electrophysiologist, he's a philosopher. And so is Dr. Azam Shafqat, who was my real mentor in the sense that I trained with him. Both of them have a philosophical tilt. They're different personalities, but they have a philosophical tilt that should not go out of electrophysiology. General Imran lured me into electrophysiology. He said कि यार ये जो EP वाले बड़े अच्छे लोग होते हैं, ये एक दूसरे की बड़ी मदद करते हैं. And I looked around and I actually saw that, because he played a role in my life, and I would want to do the same for others. No cutthroat, no pulling the other person down. It was a love for the subject and love for the thing, and I still believe electrophysiology is amazing. I've been to the European Society of Cardiology meeting, and EP was rampant over there. Other subjects are, kind of being squeezed into a corner, because this is a subject. And again, quoting General Imran, he used to say, यार तुझे पता है कि EP इतनी अच्छी क्यों है? वो इसलिए अच्छी है क्योंकि 40 साल लोगों ने सिर्फ कंधे पे वो पेपर्स लाद के फिरते रहे थे और वो ट्रेसेस नापते रहते थे. And they used to sit together and help each other understand. And that was the beauty of it. Electrophysiologists ने सिराते मुस्तकीम पे बड़ी देर तक काम किया है before they actually came into lucrative medicine, जहाँ पैसे की बात आती है. So this is my message to you. Keep that spirit alive. That defines electrophysiology. Why high in valence? So entrainment is my research topic, and whatever I've done. So I love entrainment. And जब मैं अपना पेपर लिख रहा था, उस ज़माने में fellowship में था, तो I went to the American Heart Rhythm Association meeting, and I asked people कि मुझे Albert Waldo को देखना. He's the person who described in the 80s entrainment. And I went in and, I was looking for someone very imposing, and I saw a very humble guy. वो इतना बड़ा hall था जहाँ 747 खड़ा हो सकता था in Boston, and he was speaking. He was humble. And people asked him question, and he went down the podium without answering those questions, and rest of the people who have been inspired by him and were his students got up and answered the questions. So that is the kind of field that we are working in, that is what we need to uphold. So I think this meeting lays that out, and I thoroughly enjoyed. I'm on call I should have been back rounding, but I could not leave after my ECG session because these sessions were beautifully done. And you have got all the senior people here. So electrophysiology is over here. You have the mentors sitting over here. And you have the new people over here who are really brilliant. I'm very, very impressed with all that you've done. So I think we should maintain this thing, and just thanking these three young people, Dr. Ghazala, Dr. Faria, Dr. Yawar, who have kept this flame burning. And I think with each time it is improving, and my very best wishes, and as much as I can contribute, and we still have our the entire faculty over here to help, and for the juniors too. Take the tips that have been given today, and always think of yourselves as philosophers. We are better than the rest of the cardiologists because we think. Just remember that. The day you stop thinking, you will become average, and don't do that. Thank you for that. I usually attack them right, left and center, so I'm kind of staying back and not, because I can see the balloons shrinking. This time the balloons were nowhere. It was all medical therapy. It was all yeah, exactly. People are now, people believe that it is your intellectual thought backed by good medicines that is changing the future, not procedures that we don't understand the outcomes of. So just take that. If you're a good electrophysiologist, if you're a good philosopher, you will always be a good ablator. Remember that. Okay, thank you.